Buongiorno a tutti, benvenuti a Roma in questa bella location. In una location così bisognerebbe fare i saluti in latino, ma li facciamo in italiano che è una lingua neolatina. Benvenuti a tutti gli ospiti, c'è gente che viene dai vari continenti, è un incontro sulle onde d'urto veramente internazionale, quindi sarà modo di scambiare delle esperienze, degli studi e quant'altro. Niente, poi nel corso adesso ci sono anche dei problemi tecnici, però nel corso della mattina saranno risolti e quindi andrà tutto per il meglio. Io adesso volevo chiamare qui il Presidente del Congresso, il Dottor Panegrossi, per fare un saluto di benvenuto.
Allora, intanto ringrazio tanto Alfonso Di Giorno, con cui collaboro ormai da un po' di anni, perché viene a Roma per queste attività sulle onde d'urto che rappresentano oggi sicuramente non più una novità, ma una certezza di trattamento in molte patologie, e credo che questo sia un convegno che debba mettere il fuoco su quello che è oggi il trattamento con le onde d'urto, perché sicuramente sono metodiche che avranno, anche con lo sviluppo dell'intelligenza artificiale, con lo sviluppo di tutte quante le novità tecnologiche, una ulteriore applicazione e quindi aiuto per noi e i trattamenti dei pazienti.
Ringrazio, volevo chiamare la Presidente della Santo, la Professoressa Vulpiani, uno dei maggiori esperti mondiali di onde d'urto.
Grazie. Buongiorno a tutti, ai colleghi, agli ospiti. Ringrazio veramente Alfonso e faccio i complimenti a lui e al suo team per l'organizzazione di questo evento internazionale che veramente in questo contesto storico per la medicina ci consente veramente di affrontare le nostre conoscenze e soprattutto condividere con tanti colleghi a livello internazionale le nostre esperienze nella metodica delle onde d'urto, che ha acquisito un significato particolare grazie all'evidenza scientifica portata avanti da colleghi di altissimo livello che sono anche qui presenti. Ritengo fondamentale questo incontro anche dal punto di vista umano, perché è possibile rivederci e scambiarci tante le nostre esperienze, sia scientifiche e cliniche soprattutto. Quindi ringrazio ancora Alfonso, il suo team, e soprattutto mi auguro che saranno 2 giorni veramente interessanti e intensi. Prego.
Grazie. Adesso vorrei chiamare il professor Maffulli, Nicola Maffulli, uno dei maggiori esperti mondiali. Le sue pubblicazioni sono notevoli in questo campo.
Well, thank you very much. It is a great pleasure to be here and to welcome you all in this hall. Well, you will not believe it, but until a few hundred years ago, in this hall, there were 300 beds. Okay, imagine, now we're used to single rooms in our hospitals. At the time, there were 300 beds, and God only knows how many surgeons and physicians walking around here. I should thank Professor Alfonso, because he's the one who had the vision to bring us all together in Rome. I've been involved in shock wave therapy for the past 25 years or so, and the person who brought me in this world is sitting over there at the bottom left, is Professor Jan de Krompe. We met more than a quarter of a century ago, and we started a soda list which has lasted in time. We've gone over to the same barber since, and our families have become friends. But above all, our families ourselves have become a huge family for shockwave therapy. This is a unique opportunity. It's the opportunity not just to listen to what we have to say, but above all, to interact with each other. Science can only advance to collaboration. Remember, it is not just multidisciplinarity. Here we have several surgeons, we have shockwave specialists, we have sports physicians, we have rehabilitation specialists. It is not putting together in the same room that makes science advance. It is the fact that we all talk to each other. Remember, it's not multidisciplinarity, it's interdisciplinarity. And for this, we should thank Professor Di Giorno for having brought us all together, and I very much look forward to interacting with all of you. Thank you.
Grazie, professore. E ultimo, ma non ultimo, Daniel Moya, le onde d'urto mondiali.
Thank you very much. It is really touching to be here, a place where our colleagues many centuries ago were treating patients, and we realized that besides time, besides geography, we are still working in the same way. We are trying to learn, we are trying to help our patients. Those basic things have not changed. I am really also moved because of how many people is coming from around the world. They don't care about conflicts or about strikes. They are here today. So enjoy this place, enjoy Rome, enjoy the science during these days. Thank you very much to Alfonso. I know the effort he did, and thank you very much to Citot for supporting this.
Grazie. Volevo qui un attimo la professoressa Berti dell'Istituto Ortopedico Rizzoli di Bologna e il direttore della fisiatria per un saluto alla platea. Che ha affrontato un duro viaggio con lo sciopero dei treni. Tra l'altro lo sciopero dei treni ha fatto sì che non arrivassero, ancora dovrebbero arrivare degli altri che sono bloccati a Milano, a Bologna, a Padova. Prego, prof.
Buongiorno a tutti, è veramente per me un onore essere qui in questo congresso mondiale così importante ed è bellissimo vedere proprio le esperienze qui raccolte da tutto il mondo, per proprio far sempre di più avanzare le nostre cure e la ricerca scientifica. Un ringraziamento a tutto il board del convegno e in modo particolare al mitico Alfonso, che veramente impiega tutta la sua passione e l'energia per il contributo per questa società e per questo evento. Grazie.
Bene, grazie. Direi che possiamo iniziare col programma. Professor Sangwei of China.
Thank you.
Por le tour.
Good morning. I'm sorry I can't speak Italian, so I will speak English here. Not change. Good morning, ladies and gentlemen, distinguished moderators. First off, I would like to sincerely thank Dr. Alfonso Di Giorno and Professor Daniel Moya for their kind invitation and moderation. It's a great honor for me to deliver this keynote lecture. My name is Wei San from China. Today my topic is transformative perspective on ESWT from evidence to future practice. Let me briefly show the roadmap of today's lecture. We will start from the origin and milestones of shockwave, then move to the evidence and indications. After that, I will share some reflections. Finally, I would look forward to future practice, especially AI-assisted ESWT. Shockwave was first understood as a physical phenomenon. During World War II, scientists studied the shock waves from explosions and high-speed flight. Later, people asked, can we control this powerful energy and can we use it safely in medicine? This idea led to lithotripsy and later opened the door to orthopedics and regenerative medicine. In 1979, Daniel developed the first medical shockwave device, Human One. This was the true milestone. It showed shockwave could be generated, focused, and delivered into human body in a controlled way. After entering orthopedics, ESWT expanded into more clinical fields. It was used for bone healing, tendinopathy, pain control, and later explored in wound healing, cardiovascular ischemia, regenerative conditions, this expansion showed shock wave is not only local pain treatment, it's a biological therapy based on energy delivery and tissue response. With this early clinical success, shockwave therapy entered rapid development. Publications in this field have continued to increase. Today, there are nearly 14,000 papers related to shock waves, with hundreds of new papers every year. This shows that shock wave is becoming an active and expanding field of medical research. Today, shock wave has been explored in many medical specialties. It is no longer limited to urology or orthopedics. It has become a cross-disciplinary technology connecting to tissue repair and regenerative medicine. This list of indications has become broader, from chronic tendinopathies to bone pathologies and skin wounds and emerging conditions. At the same time, contraindications are becoming more refined and specific. This evidence map gives us a balanced view. Some indications are well established, especially tendinopathies. Some are approved by FDA, and bone healing and ON, osteonecrosis. Some are promising, such like erectile dysfunction, pelvic pain, cardiovascular ischemia. Others remain exploratory, including nerve injury, spinal cord injury, and brain disorders. Different diseases have different levels of evidence. There are several clinical studies support shockwave in orthopedic conditions, such as plantar fasciitis, lateral epicondylitis, non-union, and ON. This evidence is strongest when the indication, device type, energy dose, and target issue are well matched. Osteonecrosis is one of the most important joint preserving indications for shockwave. In this field, our team have done a lot of work, including clinical studies, basic research, imaging guide treatment, and leading in the guideline and consensus development. Current evidence suggests that shockwave may be the most useful device and technique in early stage of pre-collapse or ONFH. Some applications, such as spinal cord spinal deformity, are still exploratory. They are interesting because they show the expanding vision of shockwave. However, they should be discussed with caution because stronger clinical evidence is still needed. Muscle spasm is another interesting area. The goal is not only pain relief, but also modulation of the muscle tone. Shockwave should not be seen simply as a muscle relaxant. It may influence muscle fascia nerve unit. Beyond musculoskeletal disease, shockwave has been explored in wound healing, soft tissue repair, including burns, skin ulcers, and diabetic foot. Shockwaves may improve microcirculation, promote angiogenesis, and support tissue regeneration. Cardiovascular application is an emerging direction in refractory angina and myocardial ischemia. Cardio shock, we call it ESMR, may promote angiogenesis and improve the microcirculation. Another kind of use we call intravascular lithotripsy. They use shock wave, deliver the energy inside the calcified vessels. We know the calcified lesion always disappeared after shock wave. That's why they use this. In andrology, low-intensity shock wave for erectile dysfunction (ED) is moving from simple symptom treatment and toward vascular regeneration. Recent studies focus more on vasculogenic ED, and they focus more on endothelial function and the microcirculation and patient selection. Spinal cord injury is one of the most forward-looking area for shockwave. Current evidence is still mainly preclinical, but the direction is important. Shockwave may modulate immunology and inflammation and improve microcirculation, I said it many times, and support the neural repair. The brain application is one of the newest frontiers of shockwave medicine. The focus is transcranial pulse stimulation. We call it TPS. It's a non-invasive image-guided neural modulation technique. Recent studies in Alzheimer's disease have moved from exploratory reports to more structured research. This remains investigational, but it shows movement from tissue repair toward brain network modulation. Before moving further, I would like to step back and share several reflections. Over the past decades, shockwave has become a platform where physical therapy, physical energy meets biological response. It connects energy delivery, tissue regeneration, precision targeting, and clinical decision-making. The question is not only what shockwave can do, but how we should understand and use it. In China, shockwave medicine is becoming more structured academically. We now have postgraduate textbooks, guidelines, and consensus. This means shockwave is entering a new stage. It's from technology to education, and finally, to a more mature medical discipline. This slide shows biological pathway of shockwave. The key idea is simple. Mechanical energy is converted into biological response through mechanical transduction. Shockwave may lead to angiogenesis, matrix remodeling, and antifibrosis, and lead to tissue repair. The next key point is precision treatment. For shockwave, precision means more than placing the probe into the painful area. It means delivering the right energy to the right defense and to the right biological target. If the target is inaccurate, the energy may be insufficient and dispersed. For shockwave, two elements are essential: effective energy and precise positioning. Without enough energy, this may be no biological response. Without precise positioning, the energy may miss the real lesion. This is the basic principle behind the precision shockwave. The future of shockwave medicine will not be driven by only one specialty alone. It will depend on the integration with AI, data science, biomaterials, drug delivery, regeneration biology, and medical and engineering. The next generation of shockwave will be more than a device. It will be a platform connecting technology, biology, and clinical translation. Another example is very important, it's very hot also. It's shockwave-assisted target drug delivery. Drug-loaded nanobulbs and microbulbs can act as local drug reservoirs. Shockwave may trigger the cavitation, promote local drug release, and improve drug penetration into the target. especially is very useful for the tumor. Basic research is helping us understand shockwave more clearly. The focus is moving from a simple mechanical effect to a multi-pathway biological response, including mechanotransduction, angiogenesis, osteogenesis, immune modulation, and neural repair. New platforms such as exosomes, biomaterials, organoids, and AI-assisted shockwave are also emerging. One important emerging direction is immunomodulation. Shockwave may act only stimulate tissue repair directly, but also reshape the local immune microenvironment. Recent studies suggest that shockwave may regulate macrophage polarization. This would support the angiogenesis and tissue regeneration. To study this mechanism more precisely, we need new validation platforms, such like organoids, organ-on-chip models, advanced imaging, and AI-based analysis. Our team has also expanded into this direction, including published work using organ-on-chip platforms. These models may help us understand how shockwave affects the tissue microenvironment more precisely. Here, I would like to highlight the important contribution of Professor Daniel Moya. For one key point from his work is the clear distinction between focus shockwave and radio pressure waves. I think he will make a more excellent and clear presentation later. I needn't go into detail here. But the clarification is very important for rational practice. Overall, shockwave therapy is considered safe, that's no doubt. But most side effects are mild and temporary, such as local pain, bruising, redness. But rare complications can still happen. Yeah, it still happens. What is rare is not impossible. What is unlikely is not non-existent. We should also recognize different opinions. In China, there is saying, 兼听则明. That means maybe not all the evidence is positive and not all patients respond well. And in clinical practice, we also see failed cases, but that doesn't mean shockwave is useless. It reminds us to improve the patient selection, dosing, device choice, and the treatment protocols. Shockwave are not magic. It should be used for the right disease, not for every disease. The future is not uncontrolled expansion. The future is to make shockwave more disease-specific, target-specific, and patient-specific. The goal is not wider use, but wiser use. Now, let's move to the last part, AI and future practice. Our team has started to explore AI in the diagnosis of ON, but we use the deep learning to analyze the MRI and identify the necrotic lesions. Diagnosis is only the first step. The next step is to combine the AI and the shockwave treatment, and then use it to help select the patients, define targets, plan the treatment, and predict the response. AI defines the target, shockwave delivers the energy. This slide shows a possible future workflow of AI-enhanced shockwave. AI may assist in target, the identification, the diagnosis, protocol, recommendation, real-time guideline, and outcome prediction. As we look forward to the future, AI and shockwave may bring many new possibilities, but technology should not be used for the technology's sake. In Chinese, we often say, only buy staying true to the original purpose can we reach the final goal. We do not chase every wave. We shape the right wave for the right patient at the right time. Technology may change the method of medicine, but it should never change the purpose of medicine. Okay, ladies and gentlemen, thanks very much for your attention. On behalf of my Chinese colleagues, I warmly welcome all of you to Beijing in 2028 for the next IFSWT, if we have this opportunity. International Congress, yes. Thank you, and see you in Beijing. Okay, I wait for your beautiful questions.
Thank you very much, Professor Sang Wei, for giving us this wide and excellent perspective about the present and the future of shockwaves. We have time for a couple of questions. I don't know if there is any question. Natalia? I know you can, but you will get the mic.
Yeah, maybe there's an interpreter for me.
Okay.
Yeah, that's good.
Thank you, Dr. Sheng. I'm Natalia from Brazil. I saw one of the slides about the scoliosis with the decrease of the angle, the Kobe angle. I would like to ask if you think these better results are because of the muscle treatment, or if it's like, what would you think about it?
Yeah, it's a great question. Yeah, this publication was published 5 years ago, and from then, there are many researchers devoted themselves into this field. Their research suggests, I'm not devoting myself in this field, but I know their research result doesn't show only the muscle relaxation. Yeah, they help to adjust the muscle tone and make the generation of the neuron part, and also strengthen the nerve repair for the scoliosis patients. Yeah, it's a complicated mechanism, but we should know it's only a preclinical work. There's still much evidence needed to prove that. You're welcome.
Now, Dr. Ram Chidambaram from India.
Hi, excellent lecture, Sun. Question about the side effect complications. We have published a book as well. So were they mostly with focused wave or radial pressure wave? Because that will help us to, in future training, because the focused wave is done by the medical practitioner, but radial pressure wave done by physios all over the world.
Yeah, that's a really great question. I think Daniel Moya have more words for this, but in this textbook we most focus on the focused shock wave, of course. For the radial pressure wave, we just make the classification and see it's maybe before we define it as a shock wave, but now we think it's not.
Yeah. Thank you.
Are there more questions? Dr. Mafuli, I'm sure you have something to say.
Yeah, well, it is one of the things that is emerging in the literature is that it's not so much the modality of administration of the waves, but it's the energy which is eventually imparted on the tissue. So it does not matter whether it's imparted by shock, by radial pressure waves, or by... Somebody didn't agree with me, obviously. Whether it's imparted by radial shock waves or by focused ones. And at the end of the day, what is really important is the energy that the tissue receives. So it is a question of horses for courses, and not everything works in everybody. One of the last slides that Dr. Sanwei was projecting was the fact that AI may help us out. But please remember that AI is not a substitute for real intelligence and for real humanity.
Thank you very much. I think we can move on to the next session. Sorry, Maria Chiara. See, I didn't see. Go ahead. No. San, just one more question. I couldn't see Maria Chiara.
Thank you. Compliment for your presentation. In my experience, I use in the treatment of tendinopathies the combined treatment with shock waves from radial shock wave along the muscle. What do you think about this treatment? Non ho capito.
So Professor Vulpiani uses a two-pronged management. So one, she uses therefore focus shock waves on the actual lesion in tendinopathies and radial pressure waves on the muscles around it. Do you think that these has some mileage in it?
I think I totally think it's possible. There are different kinds of opinions about this, but in our clinical job, we really did some such kind of work. Sometimes it's really helped the patients. Yeah. Yeah.
Thank you. We invite Dr. Panegrossi, Dr. Simplicio, and Dr. Faldini for the next session.
Simplicio.
Okay. Now we're starting the next session with Kenneth Gregg, speaking about cell molecular transaction and AMP communication therapy and rehabilitation. Please, Kenneth Gregg. He is here? No, non c'è Kenneth Gregg.
Ram? Sì.
Allora, we start with Ram Chidambaran from India about shock waves in calcific periarthritis of collateral ligament, finger and thumbs. Please.
Thank you.
Thank you. Good morning, ladies and gentlemen. Thank you, Dr. Alfonso and my good friend Daniel Moya for the kind invitation. Pleasure to be in Rome. And greetings from India, as well as Shoulder Elbow Society of India. Sorry. So, thank you, my friend. This was the meeting, small meeting held in Chennai with Daniel Moya explaining all about shockwave in 2 years ago. Sorry, where should I point? This is about just my journey, because in a shoulder elbow meeting, we know all colleagues each other, but here there's a mix of surgeon, physician, and physiatrists from all over the country. So I did my training, basic training in India, orthopedics, and then went to United Kingdom, did my orthopedic fellowship, then to France for shoulder fellowship, to Mayo Clinic USA for elbow, for wrist and hand in Hong Kong and Japan, then settled as a consultant upper limb surgeon in UK. I was there for 12 years. In that period only, I was one of the document reviewer for these nice guidelines for calcific tendinitis of the shoulder. Then we started to use that in UK, so I had experience with that. So when I moved to India, I started to use in my clinic shockwave. And meeting Daniel was a good stimulation to keep the momentum going for treat other conditions also. So currently, I'm in Chennai, India, an exclusive practice of shoulder upper limb surgery. Okay? So it's not advancing as you like. Sorry, should I point somewhere to? Oh, here. Okay. Go back, back. It's not advancing backward. No, no, no. I want backward, backward.
Back.
Ah. So the talk is about hydroxyapatite crystal deposition disease. There are two forms. One is calcific tendinosis and second is calcific periarthritis. Sorry, next. It is very common in the shoulder. We all know about it. Next. But a calcific periarthritis of the fingers is rare, and it presents as a painful monoarticular periarticular inflammatory process associated with juxtaarticular deposits of amorphous calcium hydroxyapatite crystal. I think it's not working the way I like to. 1/3 of patients report a preceding trauma. It's common in the MCP joint, followed by PAP joint, and more in the females. And only few case reports are there in the published literature. Often misdiagnosed because it is a rare occurrence, and the presentation can mimic an infection or a gout or pseudo gout in the hand. Blood tests are done are typically normal. X-ray is showing the calcification, even if it is microscopic. X-ray is important, and MRI, ultrasound help in the diagnosis to rule out other conditions. The treatment of acute calcific periarthritis of the hand is usually conservative with analgesics, plain gentle massage, ice compression, often self-limiting. It's been told like this. And this is like a case report. As I said, only case reports are available in the literature. It's a case report of showing successful treatment with conservative method. And this is another case report, 69-year-old lady with the PAP joint, little finger affected. But note this, with a conservative treatment, took around 6 months to recover in this particular patient, and often incomplete. So how long we can give conservative treatment for acute calcific periarthritis of the hand? Again, a review of 10 patients with acute calcific periarthritis conservatively treated. If you look at that, some of the patients had pain and reduced calcification even up to 6 months. So period of 6 months is also recommended. Again, case reports only, not a big case series. And sometimes they do have bad sequelae. This particular case reported, 50-year-old lady had multiple affection, and few of the joints had gone for erosive arthritis and ankylosis. So may not be always hunky-dory with conservative treatment. So any prognostic factors do you think that can decide the outcome? Yes. Number 1 is the thumb involvement. Number 2 is the calcification type 2. So if pain and symptoms persist, it was recommended to do ultrasound-guided barbotage or surgery. And ultrasound-guided barbotage, a simple, quick, effective way, and it reacts with the saline to form soluble compound which can be aspirated. But if you look at the series, 8 wrists, 2 thumbs and 1 fingers have been reported in the literature. And if you look at another case report, the completion of recovery is not always uniform. Mild calcification still persists with that technique. So question is, why not try focus ESWT in calcific periarthritis in hand? So when the patient comes for treatment, I got Daniel Moya in my mind. Of course, the prime indication for ESWT is calcific tendinitis of the shoulder. And second, these are the mechanism it works in calcific tendinosis. Deposit, the fragmentation of a calcium deposit, number 1. Number 2 is the neovascularization and healing promotion. Number 3 is the analgesic effect. So all 3 are good rationale to use it. Focus is preferred for calcific tendinosis with very few contraindication and very few side effect, which have been already covered by Dr. Sun. If you look at ESWT in hand therapy, I put this literature search. This is the latest research, 2026 systematic review, shows randomized control study, case series, cohort series, case reports excluded. We have 30 studies, and they cover all these 5 conditions: carpal tunnel, trigger finger, and dependence contracture, and post-carpal tunnel release pillar pain, scaphoid non-union. So these are the common 5 conditions. And it is proven beyond doubt there is short-term improvement in clinical parameters and patient-reported outcome measures. The long-term role in management remains uncertain because we need more robust studies. So we have evidence in carpal tunnel, and it's going to be covered by a speaker later on, but to say there is no significant difference between various groups with or without ESWT, so that means it can still work. And second, with the ESWT combined, there is a greater improvement. This is about trigger finger case series. Again, useful non-invasive intervention in terms of functional improvement. And if you look at calcific tenosynovitis, there are 1 or 2 case reports where the ESWT was found to be useful. So come back to our clinical cases. We've done about 4 cases, so I'll show 2 cases. As a case 1, 41-year-old IT professional uses a right hand for operating mouse for over 15 years, desk job with the operating mouse. And he come to me with a painful right thumb for 1 month duration. There was no history of trauma, a recent increase in the pain and swelling over the thumb. Examination, sorry, go back. Examination, he had tenderness over the ulnar aspect of the right thumb IP joint, restricted IP joint movement, FPL is intact. X-ray shows this flex of calcification in the region of collateral ligament of the joint. And this is the MRI. He had already done it elsewhere. MRI is very easily available in India. It shows that calcific deposit and the collateral ligaments are intact. There is no injury there. So calcific periarthritis of the thumb interphalangeal joint collateral ligament. So we counsel the patient for focused ESWT treatment, 3 sittings weekly. Simple analgesics, paracetamol was given, ice pack application after the therapy, and mobilized as comfort allows. No splinting was done. So this was the focused ESWT used. The one tip for the fingers is that you can keep the probe stationary and you can move the hand or finger to suit where you give the target and make sure the patient is comfortable. Start with the low energy and increase the energy as well as the frequency. So that was the treatment at 3 sittings given. And after 3 sittings with focused ESWT, the patient reported no pain, near full range movement of the joint, and mild swelling of the joint, IP joint persist. And this is after 2 months, complete disappearance of the calcium. As you see here, this was the pre-op, that is the post-op. Op it comes. I'm a surgeon, high volume surgeon. Post ESWT, I have to remember. So, and that is the functional movement. The patient has absolutely full excursion of the thumb IP joint flexion, extension, rotation, and full grip of the hand. And thumb IP joint is a very key joint for right hand. So second patient, 36-year-old dentist. She had injury to the right thumb 2 years ago after a fall. Pain settled in few days. She didn't do anything. 2 months later, started to develop pain, discomfort over the left MCP joint. Again, remember, MCP joint is more common. Severe pain for 1 week, unable to move the thumb at all. Examination, she had a swollen MCP joint, tenderness, range of movement restricted. They come to you as though it is like infected IP joint, joint. So that is the calcific periarthritis of the thumb MCP joint. You could see the flex of calcification on the radial collateral ligament side. That is the lateral view. And that is, we did focus ESWT 1 sitting. Patient couldn't come afterwards because she's not from Chennai, she's from another part of Tamil Nadu. So she came for 1 sitting and she called me and said, I'm fine, my pain is relieved, I will decide about coming next occasion. And she said the pain has completely settled, taking occasional paracetamol, started mobilization, and she sent this X-ray 1 month postoperative, doc, I don't have the calcium now. So only 1 sitting was given for that patient. So to summarize, calcific periarthritis of the thumb and fingers are rare. Mimic sepsis and other painful conditions. Blood test, X-rays, ultrasound, MRI are useful in diagnosis in differentiating from other similar presenting conditions. Conservative treatment is usually sufficient but may take time. If symptomatic, ultrasound-guided barbiturage or surgery used to be recommended in the past, but in our small experience, ESWT offers excellent pain relief, full restoration of movement, and complete resolution of calcium. Thank you.
Next presentation from Pietro Romeo about magnetism in biological system. Please.
Good morning. Thank you to Dr. Di Giorno for the kind invitation. I've explained something very different from other forms of technologies about the various treatment in the musculoskeletal disorders or in the rehabilitation. It's not this. It's, sorry. It's the magnetism. It's the other, yes. Aren't you? Ce n'è una prima, sì. No, le abbiamo messe insieme. No, sono la stessa cartella, due. Ha traslato la cartella e me ne ha messe due. Le abbiamo controllate. Altrimenti continuo con questa. Ok. Okay, sorry for this situation. Okay, I will don't talk with of the magnetism, but I will talk with the magnetic shock wave. It's something that's related to the phenomenon of diamagnetism. Diamagnetism is a phenomenon of repulsive effect when an high-intensity magnetic field meets diamagnetic substances. Diamagnetic substances are the substances that are very, very low magnetic susceptibility. So it's very difficult to move this part of this object and require an high intensity of magnetic fields. From this concept, we conceived a shock wave therapy about using the phenomenon of the magnetism. Here we can see the design of the shock waves. This is the same of the conventional shock waves. We have no big values of the pressures, but but low energies at the levels of the peak pressure, the pressure at 21 megapascals, the negative pressure, and the last time is the same from the other technologies. But the difference of the diamagnetic shock waves from the other kinds of shock waves is the volume of the energy. The volume of energy needs that is the fact that we have not only the focus of the shock waves, but we have also the volume of the energy that is delivered by the probe in a radial flat part of the machine. And so in this way we can have two kinds of energy. The first part of the energy is the focus of the shock waves, but we have also a volume of the energy from the energy delivered by the lens. In this situation, we have the energy area that is the conventional area of the shock waves and a volume of the energy that combine the diamagnetic shock wave. The principle of the generation of the shock waves is starts from the Fresnel principle, where a concave lens is transformed in a flat lens And with the high intensity of the movement of the magnetic fields, we produce a series of shock waves. But the very interesting part of this technology is besides the focus shock waves, but the other part, the volume of the shock waves, because we can add energy in the conventional energy of the focus of the shock waves, distributing the energy nearby the bases, and for a principle of the physics, the behavior of all the energy at a certain point is slow respect to the conventional machine. And all the energy is very high in respect to the shock pressure, but does not discomfort for the patients. Beside the focus of the shock waves and the generation of the volume of energy, we have also the energy derived from the movement of the lens. You can see the lens, and above the magnetic fields, the movement of the lens is derives from the high intensity of the magnetic fields at 2 Tesla that meets the lens and generates a flow of energy. And we have also the energy of the lens that are vibrational forces that go nearby the tissue. And the energy of the shock waves is the central part that is the Fresnel plate zone. Here you can see the different lengths that are different depth and different form of rings. This technology, we can change the rest time according to necessity of the pathology or for to avoid discomfort to the patients. We can we work with very low frequency of energy because for the principle of the physics, the low frequency allows the energy to go deeper, and we have also the diamagnetic energy, the only energy of the lens that is separated from the energy of the shock waves. And this is an interesting cases. It's a problem with scaphoid bone and radial osteochondritis in a colleague, surgeon of the end. And after the success of 2 surgery, he asked to me to be treated with this technology. We proceed with periodical treatment because the colleagues don't follow the days of the treatments, but we had the possibility to realize 8 sessions, and as you can see, after 6 years now of after the first treatments, you can see that the complete recovery of the problem. And the same is the use of the flat lens that is very useful to treat the soft tissue. We have a large area, a volume of the energy that is not focused in energy, but is unfocused, and treating all the parts nearby the lesions. We had the possibility to recover completely the pain. So, shock waves, you know, deliver energy. And when we talk about the energy, people talk also about the quantum mechanics. To realize the quantum mechanics in medical technology is very difficult because it needs a very, very high intensity, but with the possibility to treat in different ways and in a complete way all the concept that are the basis of this technology. Maybe we can go on about the or close to the quantum of the physics. Okay, thank you, and sorry for that.
We have 4 minutes, 5 minutes for questions. Do you have any question from? No? Have you experienced about the calcification in the finger? Because it's very interesting, the results of Dr. Chidambaram. Did you have any experience about this pathology in the finger with calcification? No, no. It's very interesting issue.
Thank you. Thank you very much.
Ok, basta. Adesso c'è l'altro, con gli altri moderatori però. Now, Dr. Cruel, Dr. Lacava, and Dr. Flores Salinas for the next section, please. Cruel.
So good morning all. I would also like to have you with us, and today we're going to have the symposium regarding treatment protocols and devices, and we will just kick off with Professor Daniel Moya, who is also the Director of Scientific Issues here at our lovely federation. Thank you, Dr. Moya. He will be speaking about shock waves and radio pressure waves, time to put a clear nomenclature into practice.
Thank you very much, Dr. Cruel. I am very happy again to be here. This is a beautiful city, a beautiful atmosphere, and of course we are also enjoying the gastronomy. And I had the chance to try gnocchis that were very good gnocchis, as you can see, and also fusilli. You see that these are very good fusilli. I realized that all my Italian friends are complying because those are ravioli, they are not gnocchi. But you know, what you feel is the same that I feel when I see something like this. They say that these are shock waves, and we know they are not shock waves. Why do we call them shock waves? I don't say that they are bad or good. I'm saying that they are different. And the same happened with the ravioli and the gnocchi. My grandmother, my Italian grandmother, would never forgive me for saying that raviolis are gnocchis. Why we are so touchy with food and we don't do the same in science when we are working with some specific devices and we are confusing them? We all know that this procedure was born as shock waves and was used to treat kidney stones, but it expanded to different areas and it is growing every day. But I think that I found one of the reasons. When the radial pressure waves appeared, there was this publication back in 2002 where they were saying that the radial pressure waves were shock waves. And after that, many people began to speak in that way and to publish in that way. There are some studies that have said that there are more similarities than differences between radial pressure waves and shock waves. And I think that type of publications make some confusion to us. Confusion that we can see even in papers that are published that are showing the result of the device giving this type of waves and presenting a graphic of a radial pressure wave device. So how can we defend this procedure, this technique, in front of our colleagues that do not know about shock waves if we are supposed to know about them, and we make confusion about the nomenclature? There are several authors that have make mistakes, and this is one paper that we were analyzing with a doctor in physics, Dr. Achim Loske, a doctor in physics from Mexico, who had been searching just about shock waves in the University of Querétaro for many years, and we realized that these authors in one paper are naming the technique in 3 different ways. How can we trust their results? Last year, I participated in a study. It was a survey among different specialists on shock waves around the world, and it is interesting that around 80% of us believe that we must make a difference in the nomenclature. But there was still a 10% that was against that. How can you be against reality, being a scientific? It is hard to understand. Of course, this is not only limited to the papers. There is an expansion, and the confusion goes to the population, the general population, through social media. And we know that the use of a unified language in science is very important. So why not making a clear point about this? When the humanity decided to talk about what a meter was, there was a convention, and we all know what is a meter. And after that, there was a process that everyone was very eager to work on the units and to define the units. Why don't we do the same? This is an interesting paper, an interesting book by Achim Loske, where he describes how ballistic pressure waves are different from shock waves, and he stressed that bioeffects are related to the pressure waveform, and the therapeutic effects will be different. So we must consider that. He, in another paper published last year, stressed that there are several misconceptions about physical properties, and unfortunately, these have been passed down through the years, compromising clinical outcomes, limiting the reproducibility of treatment protocols, and hindering the optimization of therapeutic methodologies. So, if after this meeting, all of us speak the same language, it would be worth to participate in and to go through the effort that Dr. Di Giorno did to organize this. You can see the comparison of a focus shock wave and a radial pressure waves. The focus waves have 100 times higher peak, and the radial pulse is 1,000 times longer. We know that the radial pressure waves are limited to one specific area, superficial area. There is not a secondary focus, and as you go far from the point of treatment, the level of energy drops. Dr. Achim Loske again says that it would be dangerous if radial waves act as focus wave, because you will be delivering a large amount of energy in a big area. So it doesn't work. But it's not only the area, it's also the deepness. And we know that the deepness is different. And again, Dr. Loske says that using radial pressure waves to treat deep-seated conditions is senseless. And this is the opinion from someone coming from someone who knows a lot about physics. Of course, I don't want to say that radial pressure waves are not good. They are good, And there are some indications in which they are very good, like trigger points and spasticity. There are some other indications in which there is an overlapping between radial pressure waves and focus shock waves. And of course, the experience of each one of us will lead us to make different indications. But there is not also a physical difference, there is not also a clinical difference, there is also a level of risk that is different. The level of risk of the focus shock waves is higher, much higher than the radial pressure waves. That's why the FDA stressed the professional labeling to sell the devices to physicians when speaking about focus shock waves, and also they aware patients that with the patient's labeling that they should look for a certified doctor to be treated with focus shock waves. Even the European community makes a difference, the European Commission, between focused and radial pressure waves. This is a topic that I have a lot of information, and we could speak about this the whole morning. Again, we have the opinion of Dr. Loske, saying that radial pressure waves are much less safer than focused shock waves does not mean that they are they do not have the possibility of producing complications. Because if they can produce cavitation, they can produce complications. And I have seen several patients coming with hematomas and different type of complications. So we know that they have different generation mechanisms, they have different physical characteristics, they have different levels of maximum energy, different depth of action, different indications, or some different indications. There is, of course, some overlap, and different level of risk. So why calling them something that is different with the same name? This is a paper that we published with Dr. Loske a couple of years ago in the Journal of Regenerative Science. That is your journal. You can not only access to papers, but also publish for free in this journal, and you will have more information about this conference. So, if you repeated a mistake, it's your decision. It's not by chance. We must realize that, and we must, I must give you the main take-home message to you. Ravioli are not the same than gnocchi. Thank you very much.
Congratulations, Dr. Moya. I would also like to know whether Dr. Kenneth Craig did arrive. No, he's not coming today. And I would invite Dr. Dan Zinn from Israel to take part, and he will be presenting what happened. That's crucial. When I changed the device I use, my experience with electrohydraulic and electromagnetic shockwave devices. Thank you.
Good morning, everybody. Buongiorno a tutti. Thank you, Dr. Moya and the scientific board for inviting me to speak in this important meeting. I'm really honored and pleased to be here in Rome. I'm Dr. Dan Zinn. I'm an orthopedic surgeon from Israel, and I've been using shock waves for more than 20 years now. And what I wish to do in this talk is to share with you my experience with two focal shockwave devices. Okay, Dr. Moya, you talked about the differences between shock waves and radial pressure waves. We can discuss that later. Why is this confusion? But I use only focal machines, devices. Okay. For many years, I treated my patients with a Medispec Orthospec device. This is the one. Oops, sorry. back. Home. Okay, sorry. This is the Orthospec is an electrohydraulic device that generates shock waves by high voltage spark electrode inside a water tank. A metal reflector concentrates the shock waves to a focus outside the machine, inside the patient body. 3 years ago, I started to use the Storz Dualit SD1 device. This device generates shock waves by electromagnets, where high voltage electrical pulses are converted into mechanical movement, creating acoustic waves that are then focused into a high intensity pressure front. I'm not going to give you now the clinical results of both devices. They are similar and follow the literature. What I want to talk about are the different characteristics of the devices and how it affected my clinical experience, my clinical decisions. These are the numbers of each device. From the beginning of 21, I collected my patients, and from the beginning of 21 until April 23, I had 466 patients treated with the Orthospec, with 599 pathologies, 87 of them bilateral. That means that when a patient comes with bilateral plantar fasciitis, he is counted as one patient and 2 pathologies. On May 23, I started to use the Storz Dualit device, and I took a learning period and collected the data from July 23 until the end of September 25. I had 660 patients with 826 pathologies. Okay. These are the common diagnosis of my cases. You can see that the classic diagnosis for shock waves are also the stars here. Plantar fasciitis, shoulder calcific tendinitis, Achilles tendinitis, most of them insertional, and trochanteric bursitis or tendinopathy. Here you can see that the partial part of each of the main diagnoses is quite similar. I looked on the number of treatment sessions I gave each case. I found that with the Dualit device, I consistently needed more treatments. Now let's talk about the specifications of each device. This is the page in the Dualit manual dealing with the device specification. Now I want to focus on the focal zone. The manual tells us the manual tells us that the height of the focal zone is 30 millimeters. You can change the penetration depth by adding a silicone standoffs, as illustrated here. But how wide is the focal zone? The manual doesn't tell that. If we approximate the cut of the focal zone to a circle, we can calculate its area and its diameter based on the total energy delivered and the energy flux density. This is the screen of the device. You can see the numbers. I took 100 pulses at an energy density of 0.1 millijoule per square millimeters. And this is the total energy. And this is the formula, and I found that the area of the circle is 32 square millimeters, and the focal zone diameter is only 6.5 millimeters, and this is a generous estimation. So this is the focal the size of the focal zone of the Stotz Dooley device, 6.5 millimeters wide and 30 millimeters high. This is the page in the Orthospec manual. Here we don't need any calculation. The manual tells us that the size of the focal zone is 25 millimeters wide and 95 millimeters high. That's a difference. For me, it's very important. You all know it, but let me show you how the treatment looks like. Can we have the audio? I want to do it again. It's noisy. You can see the patient with headphones. I'm too. We should protect our ears. And this is the Stotz. The clicks are very gentle. It's quiet. You can chat with the patient, and the pulse rate is higher. That's good for me. So, to summarize some pros and cons, the major advantage of the Orthospec device is its large head, large focal zone, and large amount of energy it delivers to the tissue. It can cover deep and large pathologies. But this is also its limitation. The Orthospec is not suitable for small pathologies in delicate areas. It is noisy, as you heard, and the pulse rate can reach a maximum of 160 pulses per minute. Before every treatment, you must calibrate the electrode tip and replace the electrode quite often. I have to be fair and add that Medispec is selling now a better model. Its head is somewhat smaller, but still much larger than the focal zone of the Stotz Dooley. The device is somewhat more quiet, and the pulse rate are doubled. The Stotz Dooley SD1 has many good things. Although you must hold it in your hand during the treatment. For me, it is very comfortable to work with. It's quiet and fast, and you can be very accurate with the treatment, both with its location and depth. Its maintenance is only periodical and depends on the number of treatments you do. I found that with this device, I need to give my patient some more treatment sessions. Because of its small focal zone, the Dooley is not suitable for large pathologies. But the Stotz Dooley opened a new set of diagnoses for me. Its small focal zone makes it ideal for superficial pathologies that require small head and for treating sensitive areas where the control of the energy level is very important to adjust it to the pain of the patient. So I began to use it to treat trigger fingers, metatarsalgia, osteoarthritis of the first metacarpal joint, and decavant tendinitis. I still keep the Orthospec device and use it to treat large areas like knee osteoarthritis, frozen shoulder, and large calcifications in the rotator cuff. I'm sure that for fracture non-unions in large bones, I prefer the Orthospec over the Stotz Dooley. This is my take-home message for you. First of all, I don't want to recommend any device over the other. Each device has its characteristics, and the clinically most relevant are the size of the focal zone and the amount of energy delivered. So you should be aware and know your device's advantages and limitations. Remember that shockwave treatment is a medical procedure and not just a technical protocol. In most cases, You use your standard protocol, but sometimes the patient in front of you may need something a little different. Thank you very much.
Here, okay, thank you. And I gather that Professor Pietro Romeo has another lecture for us. Thank you, Professor. Do we have the exact set of slides? Yes.
Okay. Okay, I will explain you the magnetism. Okay, it would be better to change with the other technology because it's important to know the diamagnetism if we consider the technologies that derive from the magnetism. The magnetism is a natural phenomenon and is spread all over the world. Normally, we live under the magnetic field in the heart. But we have also the other form of magnetic energy, and diamagnetic is one of these. Diamagnetism is a repulsive phenomenon of the matter, and to be realized requires an high intensity of magnetic fields. Our machines works with 2.2 Tesla to generate the right energy to produce diamagnetism. The other characteristic is this magnetic subjectivity of the matter. If the matter has a low magnetic subjectivity, is permeable to magnetic fields, and then we can use this movement of the matter for therapeutic purpose. As you can see, the diamagnetic substances are aspect of a closed shell because don't react easily with the other substances. But thanks to the high intensity of magnetic fields, we have the possibility to realize a repulsive effect. The repulsive effect is the basis of the diamagnetism because with this we can change the movement. Okay. We can move the matter. Why this is important? Because the biological matter is diamagnetic. We are diamagnetic because all the main proteins, ions, and other molecules, and mainly the water, are diamagnetic. Water is made by oxygen and hydrogen. Hydrogen is 18% of the entire universe. So it's the same for our body. With the combination of the two hydrogen and the oxygen, we can realize the movement of the water. That is one of the main indications for the treatment with the diamagnetic technology. For example, the water, a great part of people that practice sport has at last one time one problem with edema post-traumatic. And obviously that the objective is to reduce or to resolve the easily and rapidly and easy the movement of the water. Water is diamagnetic. With the high intensity of the magnetic fields, we can move the waters from the area of interest, but it's important that This is possible because all the water is, or the liquids nearby the area of the lesion are diamagnetic. What happened when we use the treatment with this technology? We have the movement of ions and molecules, and the first contact of the movement of the water, all of other ions on proteins are the extracellular matrix and the cell membrane. And all the possibility to generate a positive effect when we treat a pathology is the correlation between the magnetic fields and the movement of ions in the cell membrane. But it's not easy because you know that we have a lot of possibility of movement of the entrance of the molecules, the ions from the extracellular matrix to the intracellular matrix. And so we have a different form of unidirectional, bidirectional, inverse, or mechanical, for example, like the aquaporins, for example. But the main importance of this interaction of this technology, of this flow of magnetic fields with the cell membrane is in pathology, because you know that in the normal function of the cells we have the stimulus, the action potential, and then the depolarization with an interval resting time of hyperpolarization. If we have a long hyperpolarization, we have a problem. And this in the disease that to have a stagnation of the metabolic activity of the cells, thanks to the high intensity of the magnetic fields and the characteristics of the machines, we can interact directly to reset the hyperpolarization and then start with the healing process in the tissue. It's very interesting, the movement of the substance that is possible when we work with this technology is that, for example, the movement of the liquid in the extracellular, but also the movement of biological active molecules, for example. And the difference with the diamagnetic patch with other form of the energy to vehiculate the drugs, for example, is that we have with the conventional treatments only a concentration of the substances, but thanks to the high intensity of the magnetic fields, we have a larger diffusion of the substance inside the cells, and we have a speed, a fast effects. On the other part, we have, as I said, a form of a mechanotransduction. It's not the mechanotransduction we know with the shock waves, but it's something similar, because we have the stimulation of the extracellular matrix thanks to the waves of the magnetic fields that have the possibility to treat in the extracellular matrix selectively by changing the figure of that the machines do for to work in the intracellular mode by a different aspect of the amplitude of the magnetic field. And from the practical point of view, if we work in consideration of the trauma, not only the effect of the movement of the water with the magnetism, but the machine that works in this way works also with radio frequency. So radio frequency can combine with the magnetic fields and have a fast movement of the liquids, as you said, in this sport. The image after 15 days, the complete resolution of the problems, and this is due to the combination of the on-off of the magnetic fields when the machine works in radio frequency, because it automatically choose to work in alternative magnetic fields and radio frequency. Experimental experience demonstrated, in this case, the regeneration of the fin of zebrafish 2 days of difference in the peak of the regeneration between the fish treated with the magnetic fields respect to the other fish. This kind of magnetic fields is quite different from the magnetotherapy, because you know that with magnetotherapy we have the magnetic fields, the interaction with the electric charge of the membrane. This is normal because it's the Faraday law. But with this technology, we have inverse, because delivering fastly the machine high frequencies, and the first frequencies, electric frequency, is the frequency of the water, is the frequency of hydrogen, and then all the others. And in the second moment, we have the peak of the magnetic fields that exerts the biological effect. The machine is able to work in different way, in a specific way, with the various tissue. You can see the form of the various tissues, but you know that each tissue has the proper resonance frequency. As with the same concept of the MRI, the machine can choose the users of the machine can choose the pathology exact with the combination of the resonance frequency of the tissue under the machine. And if we have some experience, for example, in regeneration tissues, where this case of the woman, old woman with the polymorbidity, 1 year after this form of ulcers, 9 weeks of treatment, 1 treatment for week, the complete healing. In this case, the complex regional pain syndrome in patients with intolerance to drugs. And so with this technology, fastly we can resolve the pain, the edema, and the quality of the life of the patients. We worked also in the transcranial stimulation, and we observed in voluntary subjects in the stimulation of the area corresponding to the first muscle interosseous dorsal, a stimulation of the muscles of the fingers, and respect to the sham patients, it's like a sample of activation of the neuroplasticity. Then we treated also in an experiment the vagus nerve, and we observed in the blood of the patients the difference of the behavior of the macrophage 2 and the macrophage 1, because thanks to the effects of the magnetic fields, we observed the shift of the M1 to M2 and inverse for the M2. So that means that the magnetic fields is a proof of the effective effective anti-inflammatory effect, gives that modulation of the macrophages. And also the macrophages you can see a sample of activity of macrophages. And then after the treatment. Okay, Stimulite, thanks to Mary Schneider, that is our scientist in our projects. Stimulation with magnetic fields require precise dosing like all therapies. To work with this technology is like to work with the drugs. It's the same because the exact dose of the treatment and the complexity involve the knowledge of the user of this wonderful technology. Thank you very much.
Thank you for your presentation, Dr. Pietro Romeo, and we still have time for questions from the audience. Does anybody have a question? Dr. Tsin, please, go ahead. Can he have a microphone, please? Yes.
It's very interesting. I mean, I'm very interested in the connection between physics and biology. But specifically about magnetic fields, as you said, it's similar to MRI. And what's the difference? Why the magnetic fields you put in the tissue does something to the tissue, have an effect on the tissue, but MRI is considered a very safe technology that doesn't influence the tissue. What's the difference?
Answer in the microphone, please.
The concept is the same. A radio frequency that read in the MRI and in the machine the resonance frequency. Then I know that I'm working, for example, in the shoulder, in the tendon, okay? I select the machine to work in a selection of energy dedicated to the tendons. Are different. It's the basics, is the same principle of the radio frequency that inform of the situation of the body. But it are all concept of the physics, as you said, because when we have the pathology, the resonance frequency of ions of the tissue is different, and this machine reset because deliver the necessary magnetic energy that are for this aspect of the problem.
Okay. I have a question for Dr. Denzin, please. Thank you, Dr. Pietro.
No.
Eventually, every one of us has to change their device for one matter or the other. What are your suggestions for all of us who have to change devices?
As I said, I do not recommend one device over the other. If you can have 2 or 3 devices that are have different characteristics, so you can choose which device to use for the specific patient in front of you. And I think this is going to expand for magnetic fields and radio frequency and all kind of modalities that you have a toolbox that you use for the specific patient. It's clear that there's no one system that is relevant to all patients. That's for sure. That's medicine.
Okay. Thank you so much. So our time is over, and we are precisely on time. So we will regroup at 11:10, as stated in our program. Thank you so much.
Sa.
Mi sentite? Si sente? Perfetto. Allora invito il professor Maffulli per la prossima lettura. Grazie, prof.
Well, okay, it's a great pleasure to be here, and thank you for inviting me here. The level is extremely high, and I'm very grateful for the organizers to have invited me here, because they had to find a way of lowering the standard, and therefore they invited an orthopedic surgeon. We're going to talk about some aspects of surgery, and to some extent what I do and what I don't do when I undertake surgery in these patients. I do have some conflict of interest. I'm the editor-in-chief of JOSA, the Journal of Orthopedic Surgery and Research, and of the British Medical Bulletin. And I'm the president of the European College of Sports and Exercise Physicians. Now, I hope that by the end of this talk, you will know something about why tendon fails to heal and the biological reality, not just what we read in papers, in newspapers. What to do when conservative management has really failed. And remember, one of the issues that we have as surgeons is that we are biased to operate. Unfortunately, operation is not always the best thing for patients. Remember that we need to apply the Kisso principles. I don't know if you have heard of the Kisso principle, is keep it simple for the simple orthopedic surgeons, because orthopedic surgeons are twice as strong as an ox and only half as intelligent, therefore we have to keep it simple. I will tell you about some of the framework within which we are working at present. This is the ST Diamond principles. We worked them out with Peter Giannoudis, who is a trauma surgeon from Leeds, and the ST Diamond is the soft tissue diamond to tell you how biology should really guide surgery. I'll tell you something about our research program, which really spans from the bench to the bedside. And my vision of orthopedics is not just the technical issue, it's something that should stem from far away. We should end up probably at the bedside of the patient and eventually in the operating room, but it starts from very far away. And also, we are orthopedic surgeons. I know in the audience and in the panel over here, there are orthopedic surgeons. We always think that we are better than average, but please remember that this is not quite quite true, because there are realistic expectations which are far lower than what people think. Now, think about the scale of the problem. Now, about 30% of all injuries involve tendons. The mean time between developing symptoms and coming to an orthopedic surgeon is jolly long. It's anything between 6 months to 18 months. Now, 18 months means 2 full sports seasons, okay? So it means that the career of an athlete may be totally gone by the time they see you. About 10% of all tendon problems are resistant to conservative management. And we're talking about all tendon problems. Now think about tennis elbow, think about rotator cuff tendinopathy and so on. There are some conditions which are more resistant than just 10%, however. And in 50% of cases, if you really use what I call the Occam's razor of biomedical scientists, you will find that that many of those patients whom we think are doing well, in reality, are not doing that well. In reality, they are doing well because their level of activities has decreased, because they found a way of coping, but they're not healed as such. Now, I told you about some ways in which we can understand the biology of failure. Now, please remember that the failed healing is not just an event, it's a cascade. And it starts from training and overuse. Mechanical loading, no doubt, can cause and does cause micro damage, and there are many ways in which this can be exterminated. If you think about when we run a marathon, you've seen only a few weeks ago, there was the first person who ran the marathon below 2 hours. Now, if you think about our core temperature is about 37, but if you put the temperature in the Achilles tendon, it can go up to 42 degrees. Now, 42 degrees, it means that tenocytes are starting to die. And so hyperthermia, which is something that has been only slightly touched upon in the biology of tendon disease, is really coming to the forefront in that respect. Free radicals and hypoxia is something we produce every time we exercise. And in this respect, we are in Italy, yes? Who likes tomatoes? Please eat plenty of tomatoes, because tomatoes are great moppers of reactive oxygen species and reactive nitrogen species. And for our musculoskeletal system, probably reactive nitrogen species are the species that we should really be focusing on. I've told you about tenocyte disruption and if there is intrinsic cell damage, the tenocytes cannot do their job. If they cannot do their job, therefore they cannot produce enough good extracellular matrix. And there is an overproduction of type 3 collagen. Now, by and large, our musculoskeletal system is composed of type 1 collagen. Type 3 collagen is reactive, is healing collagen, which may act as a scaffold, but is not qualitatively as good as collagen type 1. There is this array of the ECM, of the extracellular matrix, and also cells cannot communicate with each other. Now, the audience here is more or less mixed between the same amount of ladies and gentlemen. Now, women are not good at communicating. Tenocytes are a lot better at communicating, so they are more like women. And women have a great network around them because they communicate with each other. They don't go as mad as we do because we are just on our own. Women instead are able to always call up our friends. Tenocytes are very much like ladies. They have to communicate, otherwise things don't go well. If you think about it, it's very hard work being a tenocyte. There is one tenocyte in that corner, the other one is in the other corner, and they can only communicate through sort of digitations through the extracellular matrix. If this communication does not happen, then there are problems. And they communicate using VOC and TREC channels. VOC and TREC are potassium-activated and sodium-activated channels. We're the first the first group in the world to demonstrate that tenocytes in humans do have these channels, and it is possible that during all these stress and strains that are imposed onto us, onto our tendons, through exercise, these channels are disrupted. And eventually, a failed healing response develops. Now remember, this is not a tendinosis, okay? This is not a tendinosis, it's not a degenerative type of condition. Tendons which fail have a clear-cut hypercellularity. They are not hypocellular. We're discussing about the role of neuroplasticity, and something more will come when our Natalia will talk about muscles. But neuroplasticity is important because tendons can only heal through proper neovascularization and, above all, proper neoinnervation. And instead, they produce, because of having gone mad, they produce haphazard type of neovascularization and neoinnervation. And it's not a tendinitis, because by the time we see them, by the time they come to surgery, classical inflammation is just not present. And so inflammatory cells are absent. So the nomenclature is tendinopathy. Tendinosis and tendinitis are fine, but as long as they are classified as histopathological terms, they are not a clinical condition as such. We spoke about a failure in response, and together with Karim Khan, who was the editor-in-chief of the British Journal of Sports Medicine, and with Giancarlo Puddu, who in 1976 in Rome, when he was working for Professor Perugia, put together the paradigm of tendinosis. In 1998, we standardized the terminology and spoke about tendinopathy. one of the other issues that we have to acknowledge is that we really don't know where the pain is coming from. There are theories of pain, but there are no clear-cut answers to it. We don't know why any treatment works. So if you think about, if you have done enough imaging in your tendons of patients, you will know that there is no correlation between what the patient feels and how the tendon looks. So a tendon may look bad and feel good, and vice versa, may look wonderful and feel very bad. The management is very often anecdotal. There's very little evidence-based, and sessions such as this, congresses such as this, are here to try and inject some truth and some scientific truth into this. And science must lead. Now, please remember that a lot of medicine is not necessarily evidence-based medicine. It's very much eminence-based medicine. And beware of that, because eminence can be wrong. You can be very eminent and still be wrong. In surgery, well, I'm a surgeon, I am biased, okay? But I normally consider surgery in patients who have failed 3 to 6 months of appropriate conservative management. So, what does it mean that conservative management has failed? Well, think about it. The first thing that we do when we see these patients is, when we see patients with overuse tendon injuries, is to consider load management in physiotherapy. By and large, the modality for which there is most evidence, scientific evidence, published scientific evidence, meta-analysis, level 1 meta-analysis and level 1 studies, is eccentric programs. However, there are no validated protocols. If you think about it, we know that it works, but there are several published protocols, and none of them is really well validated. As a second line, you can talk about focused or radial. Put it radial because that's the terminology, but we know about it. And there is level 1 evidence for everything that way. We developed a technique called high-volume image-guided injections, HVIGI. It is originally published for mid-substance Achilles tendinopathy, but we've extended to patellar tendinopathy and other tendinopathies as well. You can think about PRP and orthobiologics, and we have here the president of the commission of CICOT for orthobiologics, and so we are working jolly hard at trying to define this new paradigm, and eventually there is surgery. So there's a step-by-step approach, and surgery is the last step. So by the time all these have been exhausted, well, that takes a while. So in my hands, who qualifies? Well, 3 to 6 months, documented tendinopathy. They have to have earned their surgery. They must tell me that they are really affected, that they cannot really perform. You have to have a look at their metabolic status. Now, we were in 2014, so quite a while ago, we're thinking about the metabolic status as, we're thinking really of tendons as being a mirror of the inner self, in that tendons can very much show to the world, and to ourselves obviously, what goes on in our body. So we managed to find out, for example, that hypothyroid patients were more likely to develop tendinopathies, that hyperuricemia was very well associated with Achilles tendon ruptures, and so on and so forth. So please have a look at the patient as a whole and think about conditions such as hypercholesterolemia, diabetes, and so on. Do not wait too long, because we showed in the early part of this century that if you wait too long, the ability, the capability, the biological capability of the tendon to heal just goes down, and you can understand that. It's a failed healing response. That poor tendon is running to stay still, and eventually it gets exhausted. So don't wait too long. And what we know is that if you wait too long, if you wait longer than 18 months from the onset of symptoms, it doesn't matter how good you are as a surgeon, you will end up with bad results. When to pause? Well, think about high BMI, active smoker. Remember, the content, how many of you are smokers or vaping? Come on, hands up. I don't believe that there is nobody of you who doesn't smoke. But please remember that one of my associate professors when I was in Stoke showed very clearly that you only need the nicotine content of 1 cigarette per day to negatively affect your capacity to heal a musculoskeletal lesion. And we are not talking about 1 cigarette. We are talking about the nicotine content of 1 cigarette. So even if you use patches to stop your craving for nicotine, you are still having nicotine and you are still interfering with the ability to heal. I told you about hypercholesterolemia, and consider the insufficient conservative effort. So patients just want to get better. They think a couple of sessions of physiotherapy, that's all they need. It takes a long while. Think about it. 1 single molecule of collagen takes 3 months, 100 days actually, to mature. So you cannot really consider it a couple of sessions, 2 weeks of physiotherapy, and that's all. It takes time. Biology takes time to extrinsicate itself. What to cancel? Well, also, surgery is not the easy way out. It takes a long while to recover. And it is not realistic to tell somebody, don't worry, I'll operate on you, and in 3 months you'll be back to normal. It may happen. It may happen. I had the best patients I've ever had has been Jaap Stam. It's reported in the newspaper, so I can tell you about it. So I operated on him for an Achilles tendinopathy, and he was back playing at about 2.5 months. Okay? He went from Man United to Milan, and in Milan he was done for using stanozolol. So anabolic steroids do work, but in general it takes much longer, 2.5 months, to return to sport. There can be a high level of satisfaction rate, but remember that there are always risks in terms of wound nerve failure and so on. The return to sport is not guaranteed, and please keep it simple, because the more complex a procedure is, the most likely it is to go wrong. And all these factors over here are associated with poor surgical outcome. You can do all these things for Achilles tendon problems, okay? I just listed the Achilles tendon because it's my favorite tendon. At one stage, you will not believe it, I was running. I stopped running for the last time in September 1991 because my joints just gave me signals that they were not working any longer. There are all these things that can be done for Achilles tendon ailments. So you can see we can do really a lot of things are up to can be performed. And obviously, there are other things in the Achilles tendon. There's tendinopathy of the main body of the tendon. There's insertional tendinopathy. There's ruptures. Just last night, I operated on a patient with rupture. Now, in Italy, a big sport now for rupture is paddle. I don't know in your countries. Paddle is very, very common nowadays, and people think that they can get fit by playing paddle. Well, it's the other way around. They should be fit in order to play paddle. Okay, so it's if they play paddle because they are trying to really defeat middle age, well, they're going to get problems. And so all these things can be done, and there are still disputes in whatever you do in this field. Remember that only 10% of patients eventually will require surgery, and revision surgery is something that I'm undertaking more and more, because I see patients that I tell them, look, you got a problem over here, if you want an operation, yes, we can operate on you, but it means that after the operation, I cease to be your best friend. I become your second best friend, because your first best friend becomes the rehabilitation specialist, and you need to have something like, 6 to 9 months of well-performed, well-attended. Your essentially full-time job has to be to rehabilitate yourself. What do? They don't like it. They go to the next guy, and the next guy tells them, don't worry, 3 months and you'll be fine. And therefore, at 3 months, quite rightly, I mean, if you are told that in 3 months you'll be fine, you will try and go back at 3 months. And you end up with a failure, and eventually you come back to me, and then it doesn't take 6 months any longer, it takes 1 year to rehabilitate. So it's not an investment, that way. Remember that we can do open debridement, which is still the gold standard. We describe percutaneous sternotomies, and more procedures have been done arthroscopically and endoscopically. However, beware, because the latest meta-analysis on this shows very clearly that if you do things endoscopically, for example, for patellar tendinopathy, and you go and niggle at the Hoffa's body, which is part and parcel of what we do when we undertake these procedures endoscopically, paradoxically, you lengthen the time to recovery, to return to sport. So beware of what you do as a surgeon that way. Now, surgical principles are just the same, more or less the same along all the tendons. Have a look at them. I will not go into it, otherwise my good friend Professor Foti will tell me that I'm overrunning over the 20 minutes on my stage. But please, I would like you to go down to the right one, to the bottom right. Last night when we were at dinner, we were talking about the adult acquired flat foot, which is one of the things that we are seeing more and more, which is due to failure of tibialis posterior tendon. It's not an overuse injury as such. It is associated with middle age and associated with overweight and with metabolic diseases. When you see some patients of this kind, have a look at their metabolic outlook in terms of T3, T4, thyroid hormones, hypercholesterolemia, and so on. Now, our research program has spanned the good part of 3 decades. Actually, it's coming up next year, will be 40 years since I published the first paper on Achilles tendon problems, published in the British Journal of Sports Medicine. It was a paper on ultrasound diagnosis of Achilles tendon problems. And when I spoke at the time with the editor, I was in the UK already, and when I spoke to the editor of the BJSM, Peter Sperrin, told me that, well, I'm going to publish this, but this is not going to be a big thing in the future. And you know, thank God it was not a big thing, because ultrasound has become one of the gold standard in diagnosis tendon problems. So we, in the decade between 1997 and 2007, we looked at the foundations of cell biology, we looked at the molecular events in tendinopathy, we looked at the role of metalloproteases. I told you about Voc and Trek channels. In the period between 2008 and 2020, we looked at scaffolds and growth factors, and now we're really moving towards a more sort of application type of thing, more really translating all this. For 2 decades or thereabout, we looked at the foundations and the basic sciences behind it, and now we're trying to translate this into medical practice, and we're looking at the bioprinting and the like. And above all, we're trying to reshape some of the ideas in this field. And with only last week we published together with Peter Giannudis this one, the soft tissue healing diamond, ST diamond concept, which is really a translational framework for tendon and ligaments. Now, Peter Giannudis is the professor, is a good pal of mine. He's been a patient of mine as well, but he was the Greek record holder for the marathon in his younger days, before he became an orthopedic surgeon, and he has suffered his fair share of tendinopathies and so on, and that's why we became friends and we collaborated together. And Peter published the bone healing diamond, which is down here. Okay, and from there, when to include soft tissues, then we came up with this other paradigm over here. And when you look at when we expand on this, we have the fact that in order for tendon and ligaments to heal, you really have to have a lot of things working in concert. So you have to have vascularity and integrity. You have to have a mechanical environment which is absolutely perfect, growth factors, scaffolds, progenitor cells, and you really have to be an accurate surgeon in order to produce healing. I told you about the migration from concept to data, and these are the things we are working on at the time, looking at how we can create in vitro, in the lab, models which are reflective of real life. And we are looking at ways in which we can administer drugs if need be. We're looking not so much at cellular madres, at mesenchymal stem cells, but also at going away from harvesting stem cells and instead creating EVs, extracellular vesicles. And we're looking at ways in which we are not really dependent on harvesting stem cells from the patients, but really to a sort of off-the-shelf type of approach in this way. we have the ST diamond at the operating table, and really what we as surgeons should really do in the future is to look at growth factors, progenitor cells. We should look at scaffolds and mechanical loading. Remember, you can do, in order for mesenchymal stem cells and extracellular vesicles for this matter to work, you need to have two elements. You need to have the right cells, okay, but you need to have the right mechanical loading program and the right biochemical signals that have to be administered to the host. And really you have to have a good vascularization and eventually a good host. So outcomes at a glance. As I was telling you, things are not so spick and span. It takes time to heal. And this is one of the systematic reviews we are preparing in order to look at how long it takes to get better. It takes a long while. It takes months to get better. It doesn't take weeks. So I'm happy, you will be happy to know that we are coming down to the end. You can smile again. You can stretch out in a few minutes. So remember, tendons do not heal in nature. They do produce scar, and surgery changes the substrate because biology determines the quality of repair. And in this respect, remember the ST diamond concept. Shockwave and eccentrics and HVI-GI should be tried before surgery. So even though I'm a surgeon, I hold the knife for a while before really plunging in and opening my patient up. I keep it simple for the simple orthopods because the more complex the procedure, the more likely it is to go wrong. The host is the clinical variable. So optimize the host. If you have somebody who smokes 1 packet of cigarettes per day, is overweight, BMI 35, is diabetic, hypercholesterolemic, doesn't want to drink red wine because it contains some great stuff. But if he drinks 2 bottles of red wine a day and they don't want to give up eating 2 kilos of Parmigiano and so on and so forth, then it doesn't matter how good a surgeon we are. It just will go wrong. Preserve the parathenon. Now, I'm not a fan of conserving the parathenon at all costs because the parathenon may be a source of pain, okay? And I'm aware of that. But according to the ST concept, we should try and save the parathenon as much as we can. And the ST diamond gives us a language, and we have to identify the deficient vertex in that particular patient, because unless we correct that vertex, it doesn't matter what we're going to do, it is going to fail. And biological augmentation is not an adjunct in itself. It is the likely next standard of care. And I thank you for having listened to me.
Grazie, Massimo.
Okay.
Thank you, Professor. That was a very, very fantastic lecture.
Thank you very much.
Every time. And,
you know, it's good to have friends. They know,
well,
they know you and they still lie about you.
Yeah. You scratch my back, I scratch yours. And actually go back years, because when I didn't even start my training program in Ireland, we had Professor passing out of the FRC SOT exam from Kappa National Orthopaedic Hospital. So can I take it from Fabio if you want to talk?
Dear Nicola, first of all, once more, great congrats. As you said, we are doing a lot of job on the orthobiologics. So on your last line, what do you think we are missing to have the orthobiologics augmentation become the actual treatment and not the future standard of care?
Well, one of the issues of orthobiologics is that there is very little standardization. We don't necessarily know what we are injecting. We don't know when in the cycle of the fade healing response we're injecting it. We don't know how to administer them properly, and we don't know what mechanical and biological stimuli to continue to administer to them. There is no doubt that there is something there, only we don't know what's going on. Also, please remember that the regulatory environment is different. In Italy, it is fairly stringent. In the Caribbean, it is not. In North America, it is jolly stringent. The European Union is fairly stringent as well. Imagine in Italy, you cannot, who uses PRP in here? Okay, now in Italy, you cannot administer PRP without the help of a hematologist. Okay? without the help of a hematologist. And if you do that, if you don't have a hematologist assisting you, you are against the law. You can be. It is not just an administrative penalty that you are going to pay. You can go to prison for it. Okay.
Very good. Okay. Ram, you want to ask something?
Thank you. Nice lecture. My question is, you said shock wave with eccentric with HVIG.
No, I'm not saying that it's a step by step.
Step by step. But that combination looks good. But
no, it's a step. I'm not saying that all should be administered at the same time. I'm saying that there is a step by step. So in the first, by and large, the first loading is the loading. The loading program is the modality for which there is at present more level 1 evidence. After that, if you exhaust that, then it is reasonable to go on to shockwave, but you have to continue with the loading. And shockwave has great level 1 studies. So we have here, as I told you, the person who really initiated me in the field of shockwave therapy is sitting in this audience, and we've done some great level 1 studies with meta-analysis and the like, which show that shockwave therapy works. HVIGI is something we have introduced in 2001, I think 2002, and again, it can work, but you really have to load the tendon one way or the other. Okay. I don't suggest that you throw everything at the same time, because otherwise you don't know what it works, it may not work.
Okay.
Prof, can I ask you something as a basic science teacher for FRCS? What happens to the oxygen tension at the center of where the shock waves are hitting?
We don't know, is the short answer.
Is there
we do not know. At least I do not know. If you do know, tell me. There are some studies where they've used microdialysis to look at oxygen tension. What we do know. Yeah. Okay. What we do know is that with macrodialysis, it has been shown that tendinopathic tendons shift their metabolism towards more anaerobic metabolism. They produce more lactate. Okay. But there is a by-the-by observation.
Nicola, thank you. I agree with you with the comorbidities are very important in younger patients under 50 years old. And the other idea that we don't know exactly where the pain comes from. And when we get surgery in the tears of the calf, the rotator cuff, we can use a scaffold, and after 1 year we can do an MRI, and we see that the calf is turned again. The calf is turned again,
yes.
But the patient has no pain. What do you think about why the patient has no pain after 1 year, but the calf is turned?
Because God is great. We really do not know that. And if you think about it, now, I'm part now of the older generation, and I'm pretty sure that if we were to take MRI scans or ultrasound scans of 100 people of my age, at least 25% would have torn rotator cuff and not be in pain.
Yes.
There is, as you said, the cells which are absolutely stem, from which everything grows, they are missing in that. The tissue has lost its ability to send signals that it is in trouble, as it looks like probably. Maybe. Yeah. Maybe.
Thank you. Thank you, Nicola. I'm not your friend, but I think your lecture was very, very up to date. Thank you so much. We are joking. One question. According to you, in the future, it will be a preventive surgical treatment in tendons and ligaments? Preventive change?
Oh, okay. Well, this is an excellent question, but in the present climate, okay, in the present NHS climate, can you afford to do this?
Thank you.
Okay.
Thank you, Prof. Professor.
Maria Cristina D'Agostino, già presidente SITO, esperta mondiale delle onde d'urto.
Thank you very much. May I have please the microphone? Microfono? Yes? No. Quello così no? Yes.
Professor Nicolo.
Sorry. Thank you very much. Good morning to everybody. A special thank to Dr. Di Giorno, the ESWT president, chairman, and all of you. It's a very nice topic. I'm talking about the regenerative aspect of shock wave therapy. It's a long history. We started from lithotripsy, but now we are able to do regenerative medicine. Please look at these non-healing wounds. And this is the results that we can obtain with focalized shock wave therapy. And you can see here heart, red cells, stem cells, as this is the key of everything. And since already a long time, we lost the mechanical model to embrace the biological models. We are able to induce biological reaction by mechanotransduction. We apply a mechanical acoustical simulation by mechanotransduction, and we obtain a series and activation of many cellular pathways. Here you can see listed all the reaction and the biological action that we know. For example, changing in cellular membrane permeability and or nitric oxide production focused shock wave, reduction of amyelinated nerve fibers, but in red you can see written the main important reaction. Synthesis of growth factor, VEGF, BMP, angiogenesis and vasculogenesis, they are different. Angiogenesis is the production of a new vascular bed from a pre-existing capillaries, but vasculogenesis is the formation ex novo by the perivascular niche. We can obtain also angiogenesis and, very important, proliferation, migration, and homing. That is specific cellular tissue-specific migration and differentiation of stem cells. But the key factor is modulation of inflammation. So for a long time we were talking about the possibility to reduce inflammation, but not in all the cases we have to reduce. We have to modulate. It's quite different. We know from the literature, from basic science study, that probably we activated the TLR3 receptor. Is a very important receptor of innate immunity that is able to respond to the short DNA strand, and after activation of TLR receptor 3, we have an early phase of pro-inflammatory, and soon after a phase of interplay with the limited inflammation. So a transition, we will see. The key cells are macrophages. We know macrophages as M0 resting phase, and they do not do anything. But usually when macrophages are activated, they can be shifted in M1 macrophages. They are the so pro-inflammatory macrophages in acute phases, and the same cells can be polarized, one phase as M1 and another phase as M2. M2, they are the pro-resolving macrophages. It's very important, the crossroad between M2 and M1 and M2 macrophages, as this is the key for all repair phenomenon and remodeling as well. And this is very important to induce a regeneration, repair, for maintaining tissue homeostasis in almost all the tissues in the body. In 2015, we are able to collaborate with the immunologists of our hospital in Humanitas in Milano. And we are able to demonstrate that macrophages can respond to shock waves stimulation in vitro, and not only. the key factor of stimulating macrophages toward resolution, that is at the crossroad between M1 and M2 macrophages, is the key for induced regeneration. If you induce regeneration with a low-grade inflammation in the early phases, you in part can avoid deformation and to limit fibrosis. So when you stimulate with shock waves macrophages as resting macrophages, you do not have any effect. But if you stimulate with shock waves M1 macrophages, the pro-inflammatory macrophages, you inhibit the activity of M1 macrophages. If you apply shock waves on M2 macrophages activated, you induce the pro-resolving phase. So with shock waves, we are able in some way to control the crossroad between M1 and M2 macrophages. Some years later, these colleagues, Johannes Olfit from Innsbruck, had the same results in animal experiments. They are studying heart regeneration. So in heart muscle regeneration, if you are able to control the early phases of inflammation and to induce a physiological crossroad between M1 and M2, you can have a regeneration of the myocardium. Macrophages, we have to talk about innate immunity, and in innate immunity, modulation of inflammation is the key factor, is crucial for controlling not only tissue regeneration and healing, but also the homeostasis, as we will see. So macrophages are involved in tendon metabolism and homeostasis, bone, skin, myocardium, nervous system, you remember the glia cells, and the MSK muscles. So very important. We have in the literature many other papers talking about the possibility to control it, to positively influence all the processes of inflammation by shock waves. And here, some of our interesting results. This was a keloid. It was not surgical operated on, but was remodeled by shock waves. So, as Output wrote in 1997, at that time they were expecting many enthusiastic results, and now we have passed the so pioneering phases of shock waves, and we are into the field of regenerative medicine. Here, I worked for a long time as a hand surgeon, and one of my patients treated by shock waves with a very good healing of the tissue. Very interesting. Another one here, a non-healing wound, ulcers, many years, but this was open from 5 years. So very, very nice result. This is a very new skin, not healing. This is regeneration. And what about bone? We know that in clinical practice, shock waves are used for improved bone healing, but we know also that without the macrophages, we cannot heal bone. Osteoclasts and macrophages are from the same monocytes in the blood. But we know also from this great paper by Professor Notar Nicola and Moretti in Bari, published in 2009, that we can control also osteoclastic activity by shock wave. In some way, we can slow down the activity of the osteoclast. So we can interfere with the bone remodeling. What about tendon? Also in tendon metabolism, macrophages are very, very important. In the recent years, all the therapeutic strategy we have already heard by Professor Mafuli, there is a new biological interest for the tendon, and also in tendon, macrophages action is very important, and in particular the crossroad between M1 and M2 macrophages. If we are able to interfere in this crossroad, we have an interesting therapeutic strategy. So for Andy, shock waves do not damage tissue. We do a biological process that takes time to heal via mechanotransduction. So we are able to stimulate normal cell functions, we induce biological regeneration, and we are able in some way to restore tissues homeostasis all over the body. So I like to speculate, and in some way from the literature for clinical results, we can say that shock waves seems to induce a tissue-specific trophic effect. Where I apply, I have a good results in controlling homeostasis. So I ask, shock waves can be considered an immunomodulator biomimetic strategy in regenerative medicine. They are not the only one. By modulating inflammation, we can positively interfere with innate immunity, and macrophages are very involved, as if I'm able to shift the M1, M2 macrophages, we can induce angiogenesis to induce stem cell proliferation and differentiation. I'd like to propose our next course in Milano, as I come from Milano, where we will have a special focus on the Achilles tendon. Thank you very much.
Thank you, Cristina. That class is fantastic. Thank you. I know we are running a bit delayed, and I can see Professor Moya having, having a direct look into my eyes that you are encroaching into my territory and all that stuff. So we will move on. If there are any pressing questions, I think we will try to end this session. My colleagues will agree.
One question to my friend and colleague. Have you applied your activity, the shockwave therapy together with the oxygen ozone therapy? In the same patient?
Not in the same session, okay, but timing and protocol you have to decide. But I do not see any problem to apply, but first one and soon after, as for improving not only oxygen therapy, but for example PRP, some are biological, orthobiologic. But I think that the association of different therapy, orthobiologic therapy with shock waves is a very good topic for the future to study, to improve the protocol. But yes, thank you.
Thank you. I request Professor Nicola to come over, and we have a quick picture together, please.
Sì, infatti. Spostare, sì, sì, è proprio questo l'obiettivo mio. Va, grazie.
Okay, in order to catch up with time, we will make this session shorter. We have half an hour. We will begin the first 20 minutes showing different cases, and after that, Dr. Pous from Spain will show you a very special case. So, Can we put my presentation, please? Can we upload it? No. I am not Dr. Pose. Number 2. I have a panel. Is the panel going to stay here, please? Please, the panel, come to the seats here so we can discuss. Asael, are you here? You, Joseph? I will present to you real cases that we face every day in our practice, but sometimes there are small problems that give us some kind of doubts to make the decision of treatment. This first case is a 35-year-old woman with shoulder pain for several months that have not good results with rehab. There is not any kind of trap here, is no significant general medical history. But she has a calcification of the rotator cuff and an angioma in the area of treatment. And of course, this is something that put us in alert. We don't know if we could produce any kind of complications treating this calcification of the rotator cuff. So I would like to ask the panel, what do you think? For you, would be not a problem to proceed with the sessions through the angioma? Would you advise the patient that perhaps different things could happen, or for you it's okay? Asael?
No tengo experiencia en un caso similar. Creo que me quedo corto en...
And what would you do? He has no experience, he says. Joseph?
Perhaps lavage sometimes, but for me it's the shock waves.
Okay. Dr. Sangway, would you be concerned about the angioma?
No, I'm not.
Okay. Okay. So we all agree there is no problem with the angioma. We treated the patient 3 sessions of focus shock waves with a weekly interval, electrohydraulic generator, in this case 2,000 pulses per session, 0.4 millijoules per square millimeter, frequency 2 Hertz, and the calcification disappeared. There were no problems with the angioma, and so this is not a real contraindication for the use of shock waves. Let's go to another case. Partial rotator cuff tear. If someone of the audience wants to speak or to give an opinion, is welcome. This patient had 67 years old, no prior medical history was mentioned by him when we met him. Rehab treatment unsuccessful. He was really in pain, especially during the night. And his son was a lawyer. So he came with this, and we could see this, and he said, "Doctor, I have a rotator cuff tear. 2 surgeons are offering me arthroscopic, another surgeon is offering me open surgery. I don't know what to do. I come to you to tell me what to do. Should I go to open surgery, close arthroscopic surgery, or shock waves?" Let's vote. Those who think that you can apply focus shock waves, please raise your hand. We have 1, 2, 3, 4, well, we have around 10 people. Arthroscopic surgery, raise your hand. Open surgery, so no surgery. The indication would be shock waves. Who would send the patient back to rehab? Okay. Another one would ask more studies. Here we have a couple. Okay. So let's do the same voting. Rehab, go back to rehab, raise your hand. Shockwaves, raise your hand. Arthroscopic surgery. Well, you know this case. Some of you know this case. But yes.
6 meses, ¿verdad? De 6 months.
6 months.
Arthroscopic.
Arthroscopic. Okay. You know, there is things that the pilots, war pilots, describe as being fascinated by the target. This was describing Malvinas War, that they were going to attack a ship and they wanted to destroy the ship, but they don't care about everything was coming against them. They were fascinated by the target. And sometimes we get fascinated by the target because, in fact, I was kind of surprised about the shape of the head, the human head. And I asked this patient an X-ray, and this X-ray was even more unusual. And I asked him a scintigraphy, and as you can see, there is areas of high captation of the scintigraphy, especially in the shoulder. So, but there are other areas. And the second time, I asked the patient, are you sure that you don't have any kind of history? No, I had prostate cancer 4 years ago, but I did well. I quarreled with my doctor, and I never went back to the urologist. So this gave us a very strong message. First of all, we should not get fascinated by the target. There are many other things going on around the injury. Second, not always the patients will tell you all the information in the first consultation. So we need to go back to ask the patients more information every time we met them. Fortunately, no one operated this case. There were 3 orthopedic surgeons, shoulder surgeons, that were looking for surgery in this case, and would have been a big problem. Even shockwaves would have been a big problem. And we were talking about the downfalls of ortho regenerative medicine. And there was one that was not mentioned. Besides the doses, one is that many people is getting involved to treat musculoskeletal pathology, and they don't know about musculoskeletal pathology. It's not just beginning from the treatment. We must begin from a good diagnosis. Another case, acute shoulder pain, woman, 43 years old, right shoulder pain for 6 months that has increased in the last 5 days. Not significant general medical history, but she has a history of breast cancer treated successfully, and she is under follow-up. So I promise there is no, so far, at this moment of the follow-up of the patient, there is no surprises. And what we see is this. She is coming with this MRI, with pain. What do you think? What should we do? More studies? Send her to the doctor who is following up her cancer? Is in the same side of the breast cancer. What should we do? No responses? There is no volunteer? Okay, I agree with you. She got a CT scan. There were no news. Which diagnosis would you want to rule, or which would be the 2 or 3 diagnoses you are thinking about? Of course, we think on a metastasis. The humerus is a very common place to get metastases. Sorry?
No, we need a plain X-ray to correlate. Could be like intralesional, intraosseous calcium deposit.
Prof, what you see is a T2 image, and T2 image, if you see white like this, then it is a lot of edema. So there is activity. And when you look at it, that means you should not. That is, the one on the side is different, but those two are white, is definitely should, you know, make your red flags up.
Any opinion from the panel? No? Well, in fact, we went through that. The scintigraphy was negative, fortunately. And here you can see the X-ray and new MRIs. And you see that there was a calcification. The calcification was pouring into the humeral head. We have just published in Psychot Journal this study related to the findings we got in 100 cases, and because we have two important classifications for calcifications: the size by Bosworth and the evolution of the calcification. But we do not have a classification including the location. And we think that it's important to add this, not to get complications or not to get a wrong diagnosis, or perhaps to perform aggressive studies like punction for a biopsy when it is not necessary. This is the case in this patient, the type 3B, and we follow up this patient. Was not necessary to perform any kind of procedure, even not the shock waves, and 1 year later you can see that the calcification has disappeared by itself and the MRI is completely different. I consider that this is like a type of spontaneous resorption of the calcification. We have one last case of my cases: a man, 65 years old, right shoulder pain for 4 months, consultation with MRI, and he has these shock waves, more let's wait, more studies. What would you do? Shock waves? Not shock waves. I cancel the shockwave device. No, more studies, more studies. Just wait and wait this to happen the same than the lady. Well, in this case, in fact, it was a chondrosarcoma. So as you can see, sometimes can be very tricky. Last case, 42 years old lady, long-standing pain in the right shoulder, shoulder surgery 1 year ago, negative MRI, negative arthroscopic procedure. They perform soft tissue decompression, but after surgery, she kept on with very sharp pain. A neurologist made the diagnosis of fibromyalgia and began to give her pregabalin, and the last MRI was, the diagnosis was tendinosis. She was coming far from my city, so she came with this study. It's not of good quality, a lot of pain, a teacher. She was doing very bad because she could not sleep. His psychological state was not good. What should we do? Shockwave treatment would be an option. There is no, I promise, there is no tumor here. There is nothing besides the tendon. What do you think? Should we perform another study? Should we go to rehab? Should we use your orthobiologics? What does the panel think? Alfonso said? No, I can't hear you. Please use the mic. The mic. Shock waves? Okay. Anyone else?
wants to offer?
I would be cautious about recommending shockwave, especially on this MRI. I think we need more findings.
Good.
Yeah.
Yeah, because it's not common to get sharp pain because there is no bursitis, and to get sharp pain because of a tendinosis. And I asked her arthro MRI, and we saw that she had this type of injury, what is named the paint injury. It's an injury that is going from the greater tuberosity medially into the tendon and making an invasion of the muscle belly. So we operated on her, we resect the tissue that was the degenerative tissue, we repair it, and finally she did well. So what I want to stress with this is the importance of a diagnosis, because sometimes things that look the same are completely different, and we must take that in mind. Now we will move to the case that Dr. Pose is going to present. We change to the other presentation, please, by Dr. Pose.
No, it's not. No. This is. Thank you. I present this case. This is the man, 76, sudden pain, a lot of pain in his left shoulder, with no traumatic history, any. The exploration, there are a lot of pain and limitation, the mobility, in action, abduction, rotation, internal, external rotation, bear a lot of pain. And this is the echography. And then, in the subscapularis, calcific tendinopathy, what is your opinion? Do you perform first shock waves? Shock waves only? All shock waves? And can try another exploration in order to see there are a lot of problems? Yes? Barbotage.
Yes.
For you. Okay. And you?
I know the case, so I cannot.
I don't know.
No?
But my concern is that this patient's limitation of the movement seems greater than the imaging, than normally expected.
Right.
Yes.
Just wondering why we are not showing the plain X-rays first, because sometimes the small speckle calcification might not be revealed on the MRI. So always try to get, in my practice, I insist on getting a true AP view as well as axillary lateral. That will pick up the anterior calcification quickly, easily. So correlation with the X-rays easy clinically.
Is necessary another exploration? Okay. And this is the scopy. The scopy, you see a big calcification around the suprascapularis, and then a lot of calcification, macrocalcification. Okay? And then perform IRM. This is suprascapularis, calcification around the tendon bicipiti, and then important, very important, and can you see a lot of soft tissue, a lot of inflammation.
extracorporeal shock waves, focus, all the patients, another. This is the same, another exploration. You can see a big inflammation, and then shock waves. I performed these 2 sessions of intraarticular laser, photobiomodulation is better. In this type of the laser, in this type, and then the external laser. In order to control a big inflammation and pain, a lot of pain, and limitation, very, very important. And do you perform this? And good result about the pain and mobility. But then, do you perform 3 sessions of external shock waves? Do you see? Bueno, okay. Okay. This is this, and then in order to perform this.
Joseph, one question. What result did you get with the laser? Was the pain disappear or partially disappear?
Is practically disappear the 2 weeks, in 2 weeks. But then when you have a lot of calcification, I believe when you perform shock waves. But the pain is very, very important, disappear practically in 2 weeks.
And you perform it looks that this guy is a young athlete and it's eager to go back to sports.
No.
How long you take from laser to shock waves?
The laser is in order to control a big pain,
yes, but
suddenly acute situation.
Yes.
Is for us is better the laser.
Good.
In order to perform the calcifications and then shock waves.
And after laser, how much time did you take to perform the shock waves?
No.
Immediately?
Immediately. In order to, a big problem, a big calcification, I believe is necessary to perform shock waves. This is the initially, and then finally a little bit calcification, but no pain and good mobility. What is your opinion? Is better this type of correlation of laser, and then because the mobility is good, very good, like this, and this, okay? Because it's my left shoulder. You confirm this a good results. And there are another like this, another, a big inflammation, and then, and the same. You perform interlaser, only one session, disappear the pain and good mobilization. And finally, another 2 sessions in this case, 2 sessions, and good mobility without pain. The last one. Okay.
Do anyone has some experience with intracorporeal laser? Do you agree? Do you use it in calcifications of the rotator cuff?
No, I have the same experience of the, the medical post. I'm sorry, and but in my opinion, I changed the time. First, one session of shock wave. After this, the second week, intralaser, and after, I continue with shock wave. But I use the same approach.
Perfect.
Sir, I don't have experience with intralesional laser, but I was hearing that it is done for pain relief, but then we hear that you give one dose shock wave, then followed by laser. So what is the purpose of laser treatment in your regime?
In my opinion, is first I use shock wave to regeneration, not only to reduce the calcification. And, but it's not possible to reduce edema. To reduce edema, I use intralaser and to make a change of capability of the tissue, the soft tissue, with intralaser. Yes.
Thank you very much. Well, we are on time, so Alfonso, if you agree, we finish here.
Alfonso?
We are on time. Okay, thank you very much. Okay. We go for lunch and we meet again at 2 p.m.
Eccoci, un minuto. Sì. Petrucci non c'è, Vasquez non c'è, dice che c'è Nino Avventuriera. Io inizio puntuale però, iniziamo subito. Cioè nel senso che così cominciamo.
Sì, perché alle 2 bisogna...
Sì, sì. Ok. 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 Welcome to everybody. Good afternoon. This is a session about sports medicine. We have 12 minutes for each presenter. If the presentation is 10 minutes, we can try to do short question. If we are going longer, we pass to the next speaker. So I invite the first speaker, this is Gustav Tutra from Brazil, that is presenting the use of shock waves in athletes. Yes. Can we start with Dr. Dutra?
Oi. Grazie for invitation. Thank you, Dr. Alfonso. Thank you, everyone. It's pleasure for me to be here and talk about shockwave in athletes. I graduated in medicine in 2006, and I started my studies to shockwave therapy in athletes and for treating pain and improve relief for pain in 2009. And I'm a very enthusiastic this technique. And it's my, before my lecture, I'm an orthopedic and traumatology surgeon. I'm a head doctor of Botafogo in Brazil, sports and exercise physician. And I work with the national team, under 23, and I work in sports with MMA and the UFC Brazil. Thank you for everyone. And to start, I ask for you this question. Is the athlete an example of health? No, of course. The athlete, not healthy, not the case. Is athlete training more chances to cardiovascular and musculoskeletal problems. And we have there to solve this problem. Yes. In the graphs, the equal benefits and the risks. And the burden, the first slide, is very impacting, negative or positive impact for us. Tendinopathies are major causes of performance loss, high prevalence in elite and recreational athletes, and chronic overload, injury overload. This, for us, is important because time is money. All clubs, all teams, independence, the modality of sports. And remembering, in the morning, talking with you, the biological mechanism is very important for us who work at sports. Growth factor stimulation, angiogenesis, collagen remodeling, cellular regeneration, and anti-inflammatory modulation. It's important for us to prove this. And the analgesia is important too, and combined substance P modulation, hyperstimulation analgesia, peripheral neuromodulation, and improve pain tolerance. It's important to keep our athletes training at the gym, on the field. Yes? And current evidence in athletes: pain reduction, improved function, faster return to play, strong evidence in tendinopathies, and the best results combined with eccentric exercise. Always. Shockwave therapy, no treatment alone. Every time combined with other techniques. For patellar tendinopathy, common in jumpy sports like soccer, shockwave plus eccentric loading improves outcomes. Effective in chronic tendinopathy, pay attention, mid-portion and insertional disease, moderate to strong evidence, better results in chronic conditions. For plantar fasciopathy in runners, all runners, one of the strongest shockwave therapy indications, reduce surgical needs, effective long-term pain relief. It's important. And for muscle injuries, improved microcirculation, accelerated tissue healing, and potential in-season use. Non-invasive, no doping, important for us using during competition. And bone stress injuries, delayed union and stress fractures, promising non-surgical alternative and potential role in elite runners and soccer players. And during competitive season, important to low down time, because time is money. In sports, it's this way. Reduce need for injections and use for bridge therapy during competition. This is more important. Diagnosis. The correct diagnosis, you can provide the good information for your technical staff, your team members, workers with job with you, and plan together for the athletes and return to training and return to performance. And you can use shockwave therapy in all steps. Before, return to performance, because the return to performance is different to return to training. Sometimes you can put training your athletes in adapting form. It's not to perform or not exactly to training, okay? The protocols, like international recommendation, but you can modify according to need and your practice, of course. But the common used 3 to 5 sessions. Energy level depends on pathology and the tolerance to. Combination therapy is increasingly common for us. Ultrasound, right for us, all days, all times. Improved targeting accuracy, Doppler-guided regenerative approach, and precision sports medicine. This table, why choose shockwave therapy? Because this. In last 5 years, studies important in comparison, shockwave therapy, PRP, cortisone, high power laser, and hyaluronic acid. Low invasiveness, high return to play, high regeneration, and strong evidence in last 5 years. But use cortisone very hard for return to play, but you cannot use during competition because the doping control, yes? It's graphs just for a score. Outcomes in athlete tendinopathy is the best shockwave therapy. You can choose first way, first choice. Return to play profile, less than corticosteroid, but you talked about this. Stimulation capacity, shockwave therapy is the best too. And high quality sports medicine evidence, shockwave therapy in comparison about these other techniques. You can combine, okay, but just comparison each other. And the systematic review in British Journal, significant pain reduction in chronic sports tendinopathies, improved functional performance and sports-specific outcomes, potential acceleration of return to play timelines, best outcomes observed when combined with exercise, always, moderate to strong evidence in other tendinopathies. Increasingly recognizing cornerstone is the principal regenerative modality in sports medicine and high performance. And the based practical applications, non-invasive regenerative treatment, reduce dependence on corticosteroid injections, useful during competitive season, promising application in muscle injuries and bone stress, excellent safety profile in athletes. And mechanical biological stimulation, enhance tissue healing beyond analgesia alone. The future is mechanobiological treatments, and shockwave therapy is the best effects. And these three, for make your decision in your club, in your treatment for you, treatment your patients, or practice doing exercise, academy athletes, not just professional athletes. For sports injuries, tendon, muscle, joint, or bone, just the choice. Choose the shockwave therapy in the first options. In tendons, shockwave therapy in PRP, muscle, high power laser, and shockwave therapy, and for bone stress, shockwave therapy. You can use in joint, but it's not the good option yet, but the future you can use. Future directions, shockwave therapy and PRP, stem cells combination therapies, all guided treatment protocols, and biomarkers drive medicine. And the end of the conference for you, shockwave therapy is cornerstones of regenerative therapy, strong evidence in sports tendinopathies, a safe method for prevent and treat injuries. It made the first choice of treatment. Best results occur with multimodal rehabilitation, and the future is mechanobiological medicine. Thank you for your attention, and I'm here for answer your questions.
Thank you, Gustav. Only one short question. You are involved with the Botafogo o Glorioso?
O Glorioso.
O Glorioso, with the national team under 23. You showed some graphs in which the corticosteroid seems to be very, very effective in return to play, but we have to specify that in sports with athletes subjected by doping, for in-season athletes, there are some limitation to corticosteroid.
Yes,
correct?
Correct, Doc. We don't use all time corticosteroid because the time we need to use, and we can use, and you use sometimes, but out competition. We can't put these athletes inside the pitch, not to training for the competition in next match, for example.
There is a strong difference in favor of mechanical biological properties of extracorporeal shock wave. Okay,
Yes.
Thank you for your presentation.
Thank you.
Now we go ahead with the second, this many thing. We have a video contribution, yes and no, that we invite to start. Thank you.
Good afternoon, everyone. My name is Mani Singh. I'm an assistant professor of sports medicine at Columbia University, in New York City, and I also serve as team physician for Columbia University Athletics. I'm very sorry I couldn't be there in person, but I'm excited to present some of our work on shockwave therapy in sports medicine. I appreciate the committee for giving me this opportunity to speak, and a special thank you to Dr. Daniel Moya for all his help and collaboration over the past few years. I have no disclosures relevant to this talk, and our objectives today are to discuss the role of shockwave therapy and radial pressure wave therapy in the competitive or in-season athlete, as well as to summarize some of the findings from our recent publication in International Delphi study on shockwave therapy and radial pressure wave therapy in sports medicine. Many of you have probably heard this before. The best ability is availability. Incredibly true and incredibly important in sports medicine. Within these high-level elite collegiate professional sports, consequences of individual injuries affect more than just the players. Yes, it affects the games, it affects the team strategy, but the thing that we often don't think about is that it has scholarship or recruitment implications for the athletes themselves. And so a lot of the times now, we're not asking just the question, will this tissue heal, but how can we allow this athlete to continue training or practicing and compete while the tissue continues to heal? And for that reason, when we look at sports medicine literature, you'll see that return to play is a commonly reported clinical outcome. And in sports medicine, for sure, time is a clinical outcome that many of the athletes, care about the most. Usual suspects for these sports medicine injuries in season, generally non-operative injuries, different types of tendinopathies, different types of fasciopathies, or osseous injuries. And while rehabilitation remains the mainstay of treatment, it may not always be enough, given the short timeline and the high physical demands of the athlete in season. Traditional injection therapies are imperfect. We think about doing things in the past like corticosteroid injections or PRP or prolotherapy. Pros and cons for a lot of these different treatments. Downside for many of them to do in season. For corticosteroid, we know the risk to tendon and cartilage, especially higher for load-bearing tendons such as the Achilles tendon. For PRP, still an important part of sports medicine, but many of us know that there's post-procedure pain, there's a significant delayed clinical response, often 6 to 12 weeks, but the most significant part here is the activity modification and gradual return that's required after some of these procedures. Prolotherapy is a little bit of a mix. Oftentimes may require multiple injections, which can certainly delay or spread treatments out. But there's a lack of stronger clinical evidence, there's a lack of standardized protocols, and it may be a short-term treatment effect, and for that reason we need something to fill that gap. And this is where shockwave therapy and radial pressure wave therapy really bridge that gap between biology and availability. How can we address the biologic injury without sacrificing the in-season availability? Advantages of shockwave therapy: it's non-operative, it's repeatable, there's no needle or injection-based tissue trauma, there's minimal downtime, and it's adaptable, meaning we can change the different types of variables that we have at our disposal to treat different types of injuries, be it tendon or bone or muscle or fascia. There's two good studies that I'm referencing here in this slide about the safety and the efficacy of shockwave therapy for athletes and physically active individuals. Systematic reviews that look at different pathologies and show the effectiveness and the safety of shockwave therapy for sports medicine. And this is where we're now starting to get into a mindset shift. It's no longer does shockwave therapy, does radial pressure wave therapy work? Now it's how can we optimize these treatments? And there's variables at our disposal here. We think about the different types of technology, be it focused devices, radial devices, or combined treatments. Now there's a burst of literature on unfocused or EMTT as augments to our traditional devices. We're starting to learn more about the use of shockwave therapy and radial pressure wave therapy across the spectrum of injury, be it acute or chronic pathology. We're doing co-treatment with cellular therapy or orthobiologics such as PRP or MFAT or BMAC or prolotherapy. And we're learning more about the different mechanisms of action for shockwave therapy, radial pressure wave therapy in muscle and tendon, fascia, nerve, bone. But there's still a gap. There's an evidence gap that we have to fill. And this is because shockwave therapy and radial pressure wave therapy has expanded faster than our ability as a field to standardize terminology, dosing, and treatment protocols. And this is where we put our heads together as an international community and tried to come up with best recommendations for shockwave therapy, radio pressure wave therapy in sports medicine. This was a recent publication that I was alluding to earlier. So this was published in the British Journal of Sports Medicine in the past year. Recommendations for use of extracorporeal shockwave therapy in sports medicine. And you can see our objectives here to the left to attempt to reach a consensus on different types of terminology, indications, parameters, and procedural aspects for shockwave therapy and radio pressure wave therapy in sports medicine. I'm really excited to share this slide because I think this is really what this conference is all about, international collaboration. And you can see here we had a diversity of different experts across 13 different countries on multiple continents. We had 41 total experts collaborate for this study. And when we look at the panel characteristics, we see that there's a lot of experience here. Professional experience over 20 years, clinical experience with shockwave therapy over 11 years, and then we have a research experience that is growing over 8 years. We had a great mix of different types of practitioners, sports medicine physicians, orthopedic surgeons, podiatrists, physical therapists, and physical PhDs that were full-time for research. And you see that as a group, we reached consensus on 69 different statements. And the full article is available for public access if you'd like to look at some of these statements in more detail. But I'm going to talk about some of the highlights in the study over the next 6 to 7 minutes. So the first category that we tried to work on was terminology and core concepts. And this is something that I think is really important. And you'll see that I've tried to make a distinction between shockwave therapy and radial pressure waves. As a group, we decided that focus shock waves, the true physical properties of the focus shock waves, are consistent with extracorporeal shock wave therapy. And that focus shock wave therapy and radial pressure waves should not be referred to as high or low energy shock waves. They're two physically distinct technologies, two physically distinct treatments. And for that reason, we should say shock wave therapy is separate from radial pressure wave therapy. You see this little screenshot from the study, and at that time, a year ago, we tried to define focus shock wave energy levels as low, medium, or high. We can see that we use this cutoff of 0.1 to 0.28 millijoules per millimeter squared as medium energy. But you'll see that I wrote this line here. Is this outdated? Because we're learning more now that the different types of focus devices, the different types of generation of sound waves, be it piezoelectric or electromagnetic, creates different physical properties for the focus sound waves. So it may be too simple to think of this as low, medium, and high, and we might also need to think about all the different physical properties and variables along with focus shockwave therapy. Next topic that we're discussing are the different indications. So we as a group, you see, across different fasciopathies and tendinopathies for both the upper and lower extremity, shockwave therapy, radial pressure wave therapy found to be safe and effective, including for those injuries with low-grade partial tendon tears. Similarly, for osseous pathologies, for delayed union, non-union, medial tibial stress syndrome, bone stress injury, sesamoiditis, good consensus for safety and efficacy of shockwave therapy. What we didn't have as much agreement on is shockwave therapy safe to do for higher grade tendon pathology, including higher grade tendon tears. Also still mixed results from our panelists on the safety and the efficacy of shockwave therapy, radial pressure wave therapy for knee osteoarthritis. Certainly an area where there's a lot of evidence growing and certainly a hot topic given the prevalence of knee osteoarthritis across our clinics. When we're looking at tendon treatment specifically, clinical focusing without local anesthesia, doing treatments for intervals of 1 to 2 weeks for a total of 3 to 5 sessions at low to medium energy levels was decided on as a group to be the current standard of practice. Many of us recommended that using both radial and focus devices was critical, as different types of technology and treatments may be more or less beneficial for different types of anatomic structures across the entire kinetic chain. There's still some work to be done for tendinopathies on orthobiologics, including the timing or the order of when we do shockwave therapy, radial pressure wave therapy, alongside something like PRP. And again, on average, 2,000 to 3,000 pulses or strikes using a pain threshold of 6 or 7 out of 10 to guide the titration of energy. When we're talking about osseous treatment, focused shock wave is here recommended over radial pressure wave therapy. There's more consensus for the treatment for joint pathology with orthobiologics, such as knee osteoarthritis with focused shockwave therapy and PRP, and agreement that higher energy levels are better for osseous pathologies. There's still a lot of mixed consensus and work to be done on what is the best type of imaging guidance, or when do we get CT scans or MRIs during treatments, after treatments, to look for improvement. So this is still an area that there's some research needed. When we think about procedural considerations, also recommended to avoid NSAIDs using acetaminophen or other non-NSAID medications for analgesia. Outside of standard of care, the group did not recommend additional weight-bearing precautions or range of motion restrictions. Again, this is probably something that most of us agree on. Fluoroquinolone should be avoided whenever working with tendon pathology. ICE, less consensus, but less than 50%, around 46% here, agreed that ICE should be avoided. In general, this was something that we didn't have as specific information for, discussing avoiding NSAIDs for 1 to 2 weeks prior to the initiation of shockwave therapy and for 2 to 6 weeks after the treatment is completed. Aspirin was a lot more mixed, but general consensus was holding it either for a week or not at all related to shockwave therapy. So what's next? We think about shockwave therapy not just reducing pain, but to optimize performance. We need to continue to learn more about the different types of effects on different types of treatments and tissues. We need to learn about how acute, subacute, or chronic injuries may respond differently. We need to learn about integration for our cellular-based therapies and the myocyte. A lot of work still that we're doing for the muscle injury. Here you'll see that, again, standardization is important, and not all shockwave therapy, or even not all focused shockwave therapy, is the same. How can we use shockwave therapy to prevent injury? And I think the most important thing here at the bottom of the slide is continued international collaboration. So with that, I thank you for your time. Here's my email. Again, very sorry that I couldn't be here in person, but I'm hoping to see you all next year for the next Congress.
Thank you for the presentation. It's an important message for international cooperation in order to organize the terminology and the kind of intervention that we are going to do with the extracorporeal shock waves. And now we call the Italian experience of Sergio Gigliotti that talks about focused shock wave treatment in sports injuries. Sergio.
Buongiorno, benvenuti a Roma a tutti. Parlerò in italiano, ma le diapositive sono tutte in inglese e la traduzione è in inglese. Io in pratica in italiano dirò solo quello che vedrete in diapositiva. Sì, no, questo qua. Le indicazioni al trattamento delle onde d'urto focali nell'atleta sono le tendinopatie croniche, le fratture da stress, la sindrome mediale tibiale e le calcificazioni o le lesioni fibrotiche dei muscoli e dei legamenti. Le generali controindicazioni sono le stesse che nel nonno sportivo, ma chiaramente sono controindicazioni che controindicano l'attività sportiva in genere, e quindi uno sportivo agonista chiaramente non può essere affetto dalle patologie indicate. Ci sono anche delle controindicazioni peculiari però dell'atleta, ed è in particolare una fondamentalmente la scarsa compliance dell'atleta stesso, del suo entourage, a fermarsi, a riprendere gradualmente l'allenamento per tutti i condizionamenti che derivano dall'allenatore e dal suo manager e dalla società. Prima di iniziare la terapia, quindi, l'atleta deve essere convinto che le onde d'urto sono una parte di un accurato programma terapeutico che include non stressare la zona interessata, usare dei supporti se necessari, escludere l'area, associare una riabilitazione specifica, un recupero graduale dei carichi che devono essere progressivi e una correzione di possibili cause, quindi gesti atletici scorretti, attrezzature. Tutte le tendinopatie croniche possono essere trattate con successo con le onde d'urto focali. Io uso una macchina, un'apparecchiatura elettromagnetica, e il mio protocollo di trattamento negli atleti è lo stesso che nei non atleti. Un'energia variabile da 0,20 a 0,25 mJ per millimetro quadrato, un numero di colpi fra i 2000 e i 2005 per sessione, una frequenza di 3 colpi al secondo, un numero di sessioni fra le 4 e le 5 e 1 o 2 sessioni per settimana. In questo congresso si parlerà tanto di tendinopatie croniche e quindi io tralascerò tutti gli aspetti, sarebbe impossibile in 12 minuti parlare delle diverse tendinopatie croniche, e concludo che sicuramente la tendinopatia, le onde d'urto sono il trattamento di scelta nelle tendinopatie inserzionali croniche in associazione con l'esercizio eccentrico. Un altro argomento importante nello sportivo sono le fratture da stress. Quali sono gli sport a più alto rischio? Vedete la corsa su lunga distanza nel 30%, la sprint, i salti, gli ostacoli nel 25% e via dicendo tutte le altre, compreso anche il baseball nel 2%, in questo caso fratture esclusivamente di gomito. Il sito delle fratture da stress sono questi: la tibia fra il 25 e il 59, i metatarsi fra il 10 e il 25, e vedete tutte le altre, compresi i sesamoidi, mentre ulna, costole e radio sono abbastanza rari. Qual è il trattamento in una frattura da stress? Nella letteratura c'è consenso sulla valutazione preliminare del rischio di frattura da stress a evolvere in una frattura completa con possibilità di dislocazione o addirittura di pseudoartrosi. Le fratture a basso rischio sono quelle nelle quali i margini di frattura sono soggetti a forze compressive, quindi la tibia posteromediale, calcaneo, cuboide, cuneiforme, secondo e terzo metatarso, diafisi. Frattura ad alto rischio perché soggette a forze di taglio, la testa del femore, la parte dentro della tibia, la patella, il malleolo mediale, l'astragolo e gli altri. Vi è consenso in letteratura sulle scelte terapeutiche in relazione al rischio. Fratture a basso rischio possono essere trattate modificando le attività, ad esempio fermandosi dallo sport, correggendo i fattori di rischio e utilizzando terapie biostimolative. Nelle fratture invece ad alto rischio, sicuramente il divieto di carico, le terapie di biostimolazione o la chirurgia. Fra le terapie di biostimolazione, i campi magnetici elettropulsati sul PubMed hanno soltanto 2 studi. Il lipus ha soltanto 5 studi comparativi in confronto alla terapia conservativa. Le onde d'urto hanno molti studi che provano l'efficacia delle onde d'urto stesse nelle fratture da stress, e questi sono una serie di articoli pubblicati su PubMed. Il mio protocollo di trattamento è questo: un'energia media mai superiore ai 0,25 mJ per millimetro quadrato, 3.000 colpi per sessione, 3 come numero di sessioni, una sessione a settimana, divieto di carico per 3-4 settimane, un follow up a un mese. Vi faccio vedere un caso clinico: un calciatore professionista di Serie A di 26 anni con un dolore al metatarso, al secondo metatarso del piede, per un mese, fin quando non si fa una risonanza magnetica e si scopre una frattura da stress della diafisi del secondo metatarsale. La TAC e la risonanza magnetica, un mese dopo il trattamento con onde d'urto, mostrano la guarigione completa della frattura con il callo periostale che si vede bene sia in TAC che in risonanza. Un'altra patologia tipica dello sportivo è la medial tibial stress syndrome, dovuto a una periostite, in pratica, un'infiammazione del periosteo tibiale per eccessiva trazione del tibiale posteriore del soleo per una iperpronazione del piede. Tipicamente occorre nei runners e in altri atleti che fanno molti salti. In PubMed ci sono 6 articoli scientifici fino dal 2012 al 2025 che riportano l'efficacia delle shock wave in questa sindrome. Questo fu il primo del 2012, per arrivare nel 2017, ad esempio, in questa pubblicazione in realtà non si trattava di atleti ma era cadetti militari, quindi in pratica facevano la stessa attività degli sportivi, con una singola applicazione associata a un programma specifico per accelerare il recupero funzionale. Il mio protocollo è leggermente diverso, prevede 0,20 mJ per millimetro quadrato, 2000 colpi per sessione distribuite su 3-4 punti in tutta l'area, tre numero come numero di sessioni e una sessione a settimana. Nella mia esperienza il trattamento con ondodurto associato con plantari e un programma di ripresa graduale della corsa ha portato risultati migliori rispetto a una sola delle singole terapie effettuate quindi singolarmente. Adesso vi farò vedere un po' di atleti che sono stati trattati, quali sono le regole, che il tempo di risposta dell'atleta tissutale non è differente rispetto a quelli che non sono gli atleti e quindi questo deve essere per forza osservato. L'immediato ma transitoria riduzione del dolore e della contrattura muscolare dopo una sessione di ondodurto può portare a una riduzione dei meccanismi di allerta e quindi di stress funzionale dei muscoli, delle strutture muscolotendinee e quindi può portare a un incremento del rischio di lesioni. Il sintomo dolore non deve essere usato come il solo indicatore per il miglioramento della malattia. Durante la terapia le attività sportive devono essere sospese e comunque è necessario evitare gli stress sulle strutture interessate. Deve essere inserito in uno specifico programma terapeutico riabilitativo o di correzione dei fattori eziopatogenetici e il ritorno allo sport deve essere graduale, incrementando progressivamente i carichi di lavoro. Da quanto io ho detto, sembra che non sia raccomandato l'uso dell'ondodurto nelle fasi acute, utilizzando l'effetto analgesico e decontratturante, ma la terapia con l'ondodurto è raccomandata nelle patologie croniche, rispettando quindi i normali processi di guarigione. Tuttavia, in occasione di eventi molto brevi ma molto importanti per la vita di un atleta, come ad esempio la finale di un campionato mondiale, quando il recupero, la velocità di recupero da una lesione acuta o da una esacerbazione di una lesione cronica è di primaria importanza, può essere giustificato usare le onde d'urto come terapia. Questa è la mia esperienza che si riferisce agli anni nei quali la nazionale italiana di calcio era fra le più forti nazionali del mondo, ahimè, non più come adesso. Si riferisce quindi a dei campionati del mondo e campionati europei, dei protocolli modificati e personalizzati per i singoli atleti, calciatori, un numero più alto di colpi fra i 3.000 e i 4.000, un'energia molto bassa, meno di 0,05 millijoule per millimetro quadrato e un numero di sessioni anche 2 al giorno prima e dopo l'allenamento. Questi sono i casi che abbiamo trattato in quell'occasione: 14 esacerbazioni di tendinopatie croniche, 8 contratture muscolari, 9 artralgie post-traumatiche, 6 fibrosi muscolari dolorose, 4 contusioni osteoperiostali, 4 tendiniti acute, 2 borsiti, 2 sesamoiditi, 2 fasciti plantari e 2 dolori metatarsali. I risultati furono soddisfacenti in termini di riduzione del recupero e di riduzione dell'uso di antinfiammatori. Grazie.
Thank you. Just a moment. I believe that you say one very important warning, because healing requires time. So when we use to assist in the team, that is the 1 or 2 days of rest, and in a patellar tendinopathy, in example, the player do the focused shock wave, and after wait 1 or 2 days only. Is correct? Which kind of stimulation are we doing in football, in soccer?
Tu ti riferisci a un evento particolare, tipo un campionato del mondo? Ti riferisci...
Normalmente, parlo in italiano,
sì.
Normalmente al di là della parte teorica e scientifica, spesso nel calcio frequentemente si assiste che dopo la partita della domenica c'è un giorno e mezzo di recupero e quindi la squadra e il team medico scelgono di trattare quella tendinopatia cronica con soli 2 giorni di riposo e poi si torna all'allenamento.
No, io non sono d'accordo.
Martedì, mercoledì.
Io non sono d'accordo perché quando
corretto.
si ha un campionato che dura 8 mesi c'è tutto il tempo per fermare l'atleta e farlo per un mese, fare il trattamento e fare il recupero.
That's important for the physician because we pass to the concept of injury burden, not on the injury treatment. So the risk to re-injury of the risk or not to treat. Ok, thank you. E quindi passiamo la parola to Natalia Murao from Brazil. Natalia Murao, that shows shock wave therapy for muscle injury.
Grazie. Grazie Alfonso e Moya por la invitazione. I'm going to speak in English. So I'm Natalia from Brazil. I'm orthopedics, foot and ankle surgeon, but I love the conservative treatment and sports medicine physician. Nowadays, I'm the vice president of Brazilian Shock Wave Society, and I work in Brazilian Futsal Confederation and Comebol. So here. And what I want to show around the muscle injuries, it's that more a concept than exactly cases. So let's go. I'm going to compare, like most of us are orthopedics, we are used to say that the fracture is just the one side of the iceberg. It's maybe sometimes the fracture has more soft tissues damage than only the fracture for itself. And the connective tissue is very important, and we might not are looking with the importance that the connective tissue deserves, because 30% of the strength of a muscle, it might have contribution of the connective tissue is important, because we have a lot of the incidence of the re-injury in 2 months of the muscle injury is very high. So there are something that we are not looking, and so why is something is missing? And who is the villain here? Of course, we have the risk fractures, the great risk factor. Sorry, I'm a little bit nervous, but let's go. It's a previous muscle injury. So it's because we know the fibrotic scar, it's the problem, it happens. So with the fibrosis, the scar, we lose the tensegrity of the tissue, and then we are maybe just looking the MRI, the lesion, just the lesion closing, but something is missing. Why this happens? So we want to go from this to this. We know the scar tissue will be there, but if we have less, it's better. So I'm going to show you that we can do that with our treatment that we love. So when we have more necrotic fibers, we have an overexpression of the profibrotic cytosine. So it's a cycle. More scar, it perpetuates the fibrosis, and we thought that the intramuscular tendon was the reason we have re-injuries. So it's new that this author, O'Sullivan, is studying that it might not be. Okay, the hamstring lesion with intramuscular tendon problem, they need more time to recover, but no, it's not the higher risk of re-injury. It's not there. So why I'm saying that? Because we are trying to look just the muscle, but the epimysium, it's just around the muscle. They do not work separated. And they have the hyaluronic acid around it, so we need this gliding tissue. And the bones and the muscle, they are all connected. So there are a few Italian authors that already said that. So we need to treat, we need to look not just for the muscle, we need to look this hyaluronic acid reduce the friction to zero during contraction. And if we do not look that, we have a consequence that 20 or 52% reduction of the gliding capacity. So immobilization, trauma, it raises the viscosity of the hyaluronic acid at the fascia, so reduce the gliding. And the Bordoni author, it's saying that we have to think not only the fascial as a solid, but we have the liquid fascia. What he wants to say is everything's connected. So we have a lesion that is in the inferior member, but we if we do not treat the body as a whole mechanism, we are going to have a re-injury. It might increase. So we need to treat everything, and we call this RAIN, Rapid Adaptability Internal Network, and it's very interesting. And they call the stacking fascia. If we do not treat, we just look for the muscle, we are going to have a persistent mechanical stress that induces a signaling pathway that induces more fibrosis, and then we have the stiffness of the tissue. And what is this? The authors are saying that the constant mechanical stress, so if you have the scar, it induces the cycle, more proteins, YAP and TAS. So these proteins do a epigenetic change, so they cause a memory. And it perpetuates the cycle. They induce the nucleus of the cells, more secretion of the collagen type 1 and fibronectin. We want collagen, but we need the balance between 1 and 3. So we have more collagen type 1, we have more fibrosis, thence the stacking fascia that they call. So, and the fibrosis induces a neurological change. So if we look just for the muscle, remember, we are going to have the scar tissue. So it sends a message, the afferent message, and we need to reorganize the rehabilitation, not only specific at the muscle. It's not just eccentric or hypertrophy look. We need to treat the central scar also. And this is a very interesting concept, and we have some new authors saying about it. So if we do not change the motor, the central nerve system, the proprioceptive, we are going to, maybe this is the problem of the re-injuries and not just the gap. So why I'm saying that? Because we need a machine that helps in every part of this loop. So it is incredible what we can do with shock waves. So I might put the concept of shock waves that even we have time to the muscle injury heal by itself, even we have the perfect time, the perfect rehabilitation, if we use shock waves, it will be better. The papers are showing us that. And because of why, no? Restoration of hyaluronic dynamics. So we have a few studies that shows that almost immediately at the first day, we have more hyaluronic acid. So the mechanical effect of shock waves already helps the vesicles of hyaluron, but it also helps in other points, as the epigenetic reprogramming, that it's saying that when we use shock waves, we produce a negative modulation in this protein, YAP and TAS. So we are also treating the neurological scar, remember? And reduction some of the cytosines that induce more fibrosis. And so shock waves does not perform mere mechanical stretching. It's just not just relaxing and stretching the muscle fiber. It modulates the genetic root of pro-fibrotic behavior through mechanotransduction. And other concepts that we already know, our colleagues already said, but we have the stimulation of metalloproteinases that works like scissors, cutting the collagen type 1 only and balance the collagen type 1 and 3. So it helps to heal and make the scar more flexible and natural. And the muscle regeneration by itself, which stimulates the satellite cells. We see in the papers that PAX7, it's a biomarker that induces more production of fibers, muscle fibers. So shockwave does not break the adhesions. It structurally rebuilds the fascial and muscular structure. And this is one of the images of the work of Dr. Zisler. And we can see that the picture above are with shock waves 4 and 7 days after. And under, we can see more connective tissue, extracellular membrane. And they also say that they reduce the fat infiltration. And the doctors, in the conclusion of the paper, the new fibers formed during the repair phase grow to their mature size more rapidly, leading to complete functional recovery in a short period of time. So these other effects we already know, the microcavitation, angiogenesis, so shock waves also do everything that we already know. And the other important effect of shock waves are the if Botox-like effects. So we decrease some the markers at the neuromuscular junction. So we help to relax the muscle, and relaxing we have improving the localized ischemia instantly, and the sensibilization peripheral. So we need to treat also the neurogenic inflammation. So shockwaves does the cellular work and also the neurological. And so we need the synergy treating the fascia and the muscle. So what I say here is we have to focus around the region of the muscle lesion. So we do not stop our machine in one side where the rupture of the fibers are. And close to the conclusion, so they call the acoustic reset. So when we use shock waves, we help this scar, the memory of the scar, but we also need the sensorial motor training to reduce the re-injury incidence for the optimal tissue gliding. And then, what are our functional goals? So we need to know that the fascia is not just involves, it helps in all the dynamics of the muscle contraction, and erasing the pathological memory is important, so shock waves work in that. Fluid precedes the strength, so if we don't have a gliding at the region of the muscle, we cannot increase the strength. So if we do not treat the memory, the nervous system will send the message like the region has a scar. So we'll not recruit all the fibers to the natural movement. And the effect, the local effect that we know of the shock wave. So that's why it's a very nice treatment for muscle injuries. So I thought it was more, it was better to show the concept and the importance to treat everything. But this is my personal protocol. I prefer radial pressure wave. So if I have both, I prefer radial. And the some of the papers shows that we have a very wide range of the number of pulse because depends the size of the athlete, which muscle we are going to treat. I don't use high frequency. I start with 4 because I understand that if we start at 10, 15, we might have the effect at the same, but we didn't even find where to treat, where the pain is. So we are putting pulses to nowhere. So we don't know where we are treating. So I start with low frequency to see the region that is painful and the target. And if we treat well, the patient will clear and immediate have improvement in pain. So sorry, I was a little bit nervous, but that's it. Thank you.
Thank you, Dr. Morao. Very well, very recent illustrated important literature about this topic. And about the epigenetic reprogramming, do you believe that this means not only the shock wave only, but for rehab, it's synonymous of early rehabilitation, like a mechanotransduction on the muscles? So the future is an early activation of the muscle injury in order to reprogramming all the scar or the tissue with the mechanical transduction, not rest for 15 days, activate immediately.
Not immediately, not immediately, but faster than maybe we are doing. Yes.
Okay.
And
maybe it's a topic in which we can open a round table very, very long. We have no time, but we can have one question from
Thank you.
the audience.
Just a comment on this, it's such an august gathering, and I see this pattern constantly, patient trying to control the timeline of recovery. There are stresses, they want their spouses to listen, and they want the children to listen to them. They keep pressure on the consultants that the illness should resolve. But remember, the body has its own way of resolving itself. And I feel that sometimes what you talked about brain, so the dichotomy has to be there, that we have to understand at certain stages we can treat something very well, and certain stages the disease itself has to take time. In modern, as a fellow faculty of the Sports and Exercise Medicine College surgeons, I find that there's a lot of pressure on the physiotherapist, the physiatrist, the surgeon, the consultants, that you resolve this disease as soon as possible because they want to go back, return back. But I think disease itself has a timeline of resolving, and we can only help. We cannot, otherwise you get very stressed about it. So I think it's a philosophy. I think I understand that you all understand that certain things will take their time, and you cannot just control it. It's beyond control of a surgeon or a physician or anybody. Thank you.
Can I comment that? And the Morgan studies in muscle injuries in football athletes, he do not put them immediately to return to play. It's not that I was trying to say. It's the comparing to the season that the muscle injuries were not treated with shock waves. They gain 1 month. The athletes return 1 month before. It's the medium time. It was not immediately. It's not that I'm sorry if I didn't mean to say that. It's not immediately, but we can reduce the time of return. That's it. The time of return depends the classification of the lesion, and the scar tissue form will be better with the shock wave effect. So it will be, it might, I just can say it might reduce the re-injury proportion. That's it. That's all I can say from the papers.
Thank you, Natalia.
One question.
Very, very
just
short.
very short question. When is we said there is a modification of scar tissue by shock wave. When is the best timing to give shock wave after a muscle injury?
We don't have this exactly answer, but Dr. Morgan from German, the paper, sometimes he did it at the same day of the lesion, the diagnosis, but he do not treat with high energy. It's the energy tolerated. So in the beginning of the time of the lesion will be just for pain, just for myofascial treatment. You might not have biological effect.
Thank you.
So thank you. It's very interesting. High energy, low energy, focal, radial. It seems to us that we need to cooperate and bring our experience on the field. Okay, thank you. So the last paper is from Martin Turco from Argentina that showed the impact of shock wave therapy on treatment of stress fractures in athletes.
Okay. Buenas tardes. Bueno, la idea es hablar un poco de la medicina deportiva, retomar un poco de ciencias básicas, hablar de esta terapia para la indicación de lo que es medicina deportiva, focalizar en un caso especial como es la fractura por estrés y hacer una revisión para finalmente discutir un poquito el caso. Las lesiones en deporte son muy frecuentes y el haber tenido una lesión, como recién referenciaba la doctora, es la que predispone con mayor riesgo a tener una nueva lesión en ese mismo lugar o en otro lugar. Y eso genera muchas veces conflictos en los cuerpos técnicos, en los armados de los equipos. Muchas veces esos conflictos se generan por mala información, por desconocimiento, y eso termina generando un mal abordaje, un mal manejo de la situación. La forma de que se generan las lesiones deportivas es igual para todas las lesiones deportivas. Básicamente hay factores predisponentes, intrínsecos y extrínsecos. Algunos intrínsecos son los propios del deportista, lo que traemos de la cuna, como así aquellos extrínsecos son los ajenos al deportista, y un evento determinado es lo que determina que se genere una lesión deportiva. Nosotros describimos la lesión deportiva como la ausencia de entrenamiento o competencia que tenga el deportista, y fíjense en los tiempos. Cuando nosotros tenemos una lesión que lleva unos 30 días, que es bastante común de ver en cualquier consultorio para el deportista, es una lesión severa. Entonces, lo que busca la medicina deportiva es acortar esos tiempos de rehabilitación. ¿Y cómo se toma esa decisión? Bueno, la gran mayoría de los tratamientos en medicina deportiva son ortopédicos, algunos hay lugar para lo quirúrgico. Lo que todavía no queda claro es cuánto, cómo, a quién, en qué momento, que muchos pacientes nos quedan como en el medio de la situación. Y allí es donde tenemos las fracturas por estrés, que básicamente es cuando el hueso no tolera una cierta cantidad de sobrecarga que supera la capacidad. Son como fracturas por necesidad, es decir, entre la destrucción del hueso y la formación del mismo prevalece la destrucción. Estas fueron descritas hace muchísimo tiempo, principalmente en reclutas, luego mucho más cerca en esta parte por atletas. Son muy bajos en frecuencia dentro de las fracturas, pero tienen una incidencia en aumento. Muchas veces son diagnosticadas tardíamente, es más, se habla en muchos artículos de unas 16 semanas de retraso diagnóstico, y muchas veces son subestimadas, tienen una complejidad variable, generan gran complejidad y ansiedad en los deportistas, y bueno, a veces también incluso conflicto de responsabilidad médico. La clínica es muy sencilla, básicamente lo más importante es el antecedente que recabamos en la consulta de un deportista que aumentó en forma significativa o muy rápida su fuerza, su intervalo, su frecuencia, su intensidad, o que haya disminuido el descanso o la respuesta al descanso habitualmente. Esa cronología del dolor es lo que nosotros principalmente le damos mayor valor a la consulta. Después, el dolor palpatorio, percutorio sobre el hueso afectado. Y la forma de diagnosticarla es bastante sencilla. Con la cronología del dolor que nosotros tenemos, automáticamente vamos por una radiografía. Si esta es negativa, allí tomamos una resonancia magnética, que si vemos el edema óseo, hacemos el diagnóstico precoz, dejando la tomografía para los controles posteriores. En eso de encontrarlo de forma intermedia, de buscar acortar los tiempos, aparecen los ortobiológicos de hace muchas décadas con sus potenciales beneficios, algunos ya muy descubiertos, otros en vía de descubrirse, pero básicamente en reducción de dolor, en potencial regenerativo, acelerar recuperación, regeneración, y sobre todo tiene algunos puntos a mi criterio que son importantes, que son no invasivas o mínimamente invasivas, que son de terapias ambulatorias, son bastante seguras y que en el deporte profesional no son considerados doping. La forma de tratar esto ortobiológico, en el caso nuestro, que es el de las ondas de choque, bueno, ya está muy claro por todos los expositores cómo es una energía mecánica que transforma respuestas biológicas. Y dentro de las patologías a tratar tenemos todos los tejidos. Dentro de los mismos, hoy nos ocupa el hueso y dentro de ellos la fractura por estrés. Como decía el doctor anteriormente, tenemos fracturas por estrés de bajo y de alto riesgo. ¿Y el riesgo a qué se refiere? A la posibilidad que esta fractura por estrés vaya a la refractura una vez consolidada o que no consolide o que sea un retardo en la misma. Las que son de alto riesgo muchas veces pueden ser de decisión quirúrgica como primera medida, ¿sí? Ahora, en todas las otras y en algunas de las de alto riesgo nosotros podemos utilizar ondas de choque. La forma de utilizarlo, como lo ven allí, a veces es muy difícil llegar a esos valores de energía, pero bueno, hay que tratar de hacerlo. Y yo en este caso no le agrego al paciente un reposo extra del que ya tiene en el momento del tratamiento. Es decir, lo único que hacemos es retirarle el impacto, que no corra y que no salte. Este estudio Delphi es muy interesante, trata de juntar, como ya saben, la forma del estudio, de consensos, se les da a muchos especialistas, se dan los tópicos y después se revisan los mismos. La realidad es que en todos los tópicos que han encontrado sigue habiendo controversias y eso es lo que nos lleva a veces a por qué no es tan concluyente la utilización de esta terapia. Muchas veces es por factores propios del deportista, enfermedades asociadas, por factores propios de la lesión o, lo que es más difícil, factores del profesional, que son cuando se da una mala indicación de la terapia, cuando se confunde el diseño metodológico, cuando hay conflictos de intereses o cuando no se tratan las causas predisponentes o las causas subyacentes. Entonces la discusión está orientada básicamente en mi criterio en 3 pilares: qué equipamiento utilizar, el número de aplicaciones, número de disparos, la intensidad, la frecuencia y el intervalo de los mismos. ¿Qué hacer con el post-aplicación? Si le damos un descargo, un descanso, un rest extra al deportista, y qué hacemos cuando tenemos el primer tratamiento versus un paciente que ya tuvo tratamientos previos. Y por último, y no menos importante, es lo que hablaban los doctores anteriormente, el retorno al juego, al deporte y sobre todo lo que yo creo que es el más importante es el retorno a la performance en el deportista profesional o de alta competencia. Porque de no nos sirve nada hacerlo que vuelva al deporte o que vuelva a jugar si el jugador no puede volver en condiciones similares a las que había estado antes de la lesión generada. Entonces, lo que nos queda ahora es tratar de juntar en estos eventos ideas, intercambiar y ver en las discusiones cómo podemos llegar para hacer la metodología un poco más concreta. No olvidarnos que en todas las patologías hay como un pico de entusiasmo, luego hay una mala indicación y eso lleva a un pico de frustración hasta que en algún momento la meseta se estabiliza y nos da la verdadera indicación o la que ofrece mayores resultados. Para finalizar, entre las conclusiones, las lesiones deportivas son constantes, la terapia de onda de choques en estas y en fracturas por estrés tiene muy buenos resultados clínicos, tiene muy buenos resultados funcionales. Quizás nos queda un poco la duda de cuándo es el tiempo adecuado para ver esos resultados en la parte clínica y cuándo es el tiempo adecuado para evaluarlo en las imágenes, mucho más difícil. Si se puede utilizar como terapia ayudante, tanto el ortopédico como al tratamiento quirúrgico, recordando que tiene buenos resultados como monoterapia. Lo más importante en esto termina siendo, como siempre, que el profesional esté entrenado, hacer un correcto diagnóstico, seleccionar bien al paciente con una apropiada técnica y ser muy cuidadoso con la indicación. Por último y para finalizar, lo dejo siempre, las lesiones deportivas son procesos dinámicos. No siempre vamos a encontrar daño estructural en lo que busquemos y muchas veces cuando encontremos en las imágenes daño estructural quizás no tengan un correlato con el daño clínico que nosotros observamos. Lo que hay que entender que el deportista lo más importante es la integración de todos los tejidos. Muchísimas gracias.
Thank you, Dr. Turco. If is there no any question, we pass the session to Dr. Di Giorno Alfonso, that introduced the lecture of Professor Catani, I believe. Thank you.
Allora, adesso c'è un video del professor Fabio Catani che non è riuscito a venire per la questione dei treni, e quindi vai pronto il video? Quindi c'è un video e poi ci sarà la discussione sul professor Catani.
Good morning, everybody, and thank you so much for the giorno invited me to this important meeting. I'm going to talk about hip and knee and food overload pathologies. As an introduction, it's very important to understand how the functional overload pathologies are related to repeated microtraumas. And this is progressive accumulation of mechanical stress, particularly for the tendon, but also sometimes for the ligament. Biomechanic joint alteration, and this is performed on abnormal distribution of joint forces. Excessive loads that are directly or indirectly due to the muscle function, and this is related to inadequate volume and intensities of the loads through the joints. Neuromuscular deficits, very important, because this is not only to pathology to the nerves, but also deficits in the control of the motion and the performance on the motor task. And also insufficient recovery due to trauma that can cause muscle dysfunction and deficits in the muscle performance. The concept overload is very important, and how to understand that is looking at the force elongation curve. We know that the tendon and ligaments can recover in length and in the structure if the relationship between load and elongation is in the safe zone. If the safe zone is demonstrated in the blue line exceed the level of the tendon that is specific to the tendon of the ligament, then it can break the structure that are making and are in the tendon or in the ligament. And this depends also not only of the force elongation curve, but also the frequency and in the velocity of the applied load. The pathophysiology of this degenerative and chronic lesion on the tendon or the ligament is not a simple inflammation. It's not only inflammatory condition, but is also due to the loading condition, as we saw before. And so this is due to the reparative response. It's a fibrotic tissue that is happening inside the tissue of the ligament, and so this is ineffective, the reparative response, and so the pain results from imbalance between the applied load and the tissue adaptability. So we can have even sometimes that the pain is coming at the beginning of the degenerative phase, but then the pain is ceasing, is not more present, but the problem, the degenerative changes in the tendon ligaments continue. And so this is a very, very frustrating condition, because then it's very difficult to apply the appropriate treatment. And so this is the workflow: excessive load, repeated overload, insufficient recovery, high training volume. And so this is the sequence of the problem in the tendon or in the ligaments. And also there is an insufficient adaptation of the motion, because when we have the change in the degenerative changes in the tendon ligaments, then there is a failure in repairing, so persistent pain or persistent failure in function. That can be different clinical scenario. So the sequence is collagen degeneration, fibrillar disorganization, neovascularization, that can be detected, as we're going to see with the ultrasound, and ineffective restorative response. The kinetic change of the joint that is in the lower or upper limb is so important. So functional overload results from movement mistakes or dysgenetic, muscle weakness, poor neuromuscular control, overtraining, and insufficient recovery. Overload injuries often represent the clinical expression of a dysfunction of the entire kinetic change. So this is important when you're assessing a painful knee, for example, that we should assess only the trunk pelvis, lumbar pelvis kinetics, and also hip, knee, and ankle and foot kinetic change, because the problem can be upper or lower joint in referring of the pain. And so a proximal or distal problem affects the intermediate structures. So this is so important, particularly clinically. So the assessment should be global, not limited to the site of the pain. And so if we look at the lower leg, for example, this is a very complex structure and function structure, because is related to the biomechanics of the lumbar spine, hip, so pelvis and femur, and then tibiofemoral and the ankle. And so this is the stability of the pelvis is one of the major control and the causes over loading condition even in the knee and in the ankle. And so stability of the pelvis first, dynamic valgus control or varus control in the tibiofemoral loading condition, load absorption, so this is very important, so the ability to dissipate impact forces, and this is due to the muscle function and also on the biomechanics of the joint, and of course dynamic alignment. And so this is segmented coordination during the gesture, during the locomotor task is fundamental, because a valgus knee, a varus knee, a valgus or varus hip, or a pronated foot are generated different loaded distribution in the whole lower limb. And so the crucial role of the hip, because it's balancing the whole lower limb, for example, is very important, because and you can see here in the figure how is important that the balancing of the pelvis is related to the hip. It's not only one muscle, but there is a synergetic muscle function that are determining the appropriate coordination of the lumbar spine and the pelvis and the hip motion. And so is equilibrium, functional equilibrium, neuromuscular control equilibrium between the adductor, the abductor, and eventually the iliopsoas, and also the muscle connecting the trunk and the painful. So the hip overload pathology are related to the great trochanter pain syndrome, the gluteal tendinopathy, snap hip, abductor deficit overload, pubalgia, and sacroiliitis. The great trochanter pain syndrome is characterized by lateral hip pain, more frequent in women, runners, and patients with abductor weakness. So this is very interesting, because always with this pain is always associated with the weakness of some of the synergetic muscles stabilizing the joint. And so it includes a pathological continuum affecting tendons and trochanteric bursa. And the muscle more affected are the gluteus medius, the gluteal minor, and of course the bursa in the trochanteric area. And so the instability is a major reason, giving lateral instability of the pelvis, manifesting in the contralateral sign in the more severe cases with the trigeminal positive sign. Then there is an overload of a gluteal tendon, because it's not sufficiently tensioned by the muscle weakness, lateral hip pain, and then functional limitation transmitted also on the down joints on the whole lower limb. The treatment of trochanteric syndrome is, of course, a conservative approach, and the physiotherapy can be, of course, defining the pain control inflammation, but is mostly due to the abductor reinforcement, and try to understand how to represent the and recover the synergetic function of the adductor and the abductor, and eventually also the flexor and extensor of the hip. So the therapeutic exercise is a cornerstone of conservative treatment. Very important. So we need to associate always pain control, even with the physical therapy, but also with the recovery of the muscle function. Athletes, pubalgia, very complex, very difficult to treat and to the clinical solution to avoid pain is mostly a functional pathology, The structure involved are the adductors, abdominal wall, pubis symphysis, and the hip flexor. And this is very a syndrome, and so is affecting more than one structure, and as you can see, the multifactorial nature interaction between muscular joint and biomechanical factors. Sometimes it's very difficult, and it's very important to go in the knee in the key centers where are specialized in that kind of pathologies. This is, the description of the synergetic muscle function on the pubis and the mechanism of unbalanced and weakness of the adductors, abdominal muscle, and core or stability of the pelvis. Conservative treatment, of course, sometimes can be the surgery, but very limited indication. And the aims in the active rehabilitation is load reduction, targeted physiotherapy, mostly focused on the adductors and abdominal muscles increasing in the force, and pelvis reinforcement for stability and neuromuscular control is key. The functional sacroiliitis, very difficult to treat also because often can develop in a chronic pain, is usually unilateral buttock pain. If it's dynamically caused, if it's bilateral, is more often related to the inflammatory disease. It can be low radiated from the back, but also the pain can be irradiated to the posterior region of the thigh, not surpassing the knee. The pain when running is key and is always induced by monopodalic loading. Mostly runners and sprinters, and on the eccentric load, particularly on the function of the hamstrings, on the insertion on the pelvis. And the symptoms are lower gluteal pain, very easy to palpate directly on the sacroiliac region, and the mechanism, as we told before, is repeating eccentric overload of the hamstrings with proximal insertion stresses. Hamstrings is the key point, and so mostly try to balance, but not only with the flexor, but with the extensor muscle, and so is equilibrium between the two groups that are biarticular muscles. And so this is very important. So mostly is eccentric exercises, and try to recover a lumbopelvic control of the motion, particularly monopodalic condition, and understand and improve the range of motion that most of the time can be reduced about stiffness on the hamstrings. The knee, very interesting pathologies, and the most frequent causes in pain in athletes, particularly in the jumping sports. And it's very important to understand the biomechanics diagnosis in that pathologies. So it can be a painful patellofemoral syndrome, patellar tendinopathies or jumper's knee, iliotibial band syndrome, and the past sensorineural tendinopathy. Patellofemoral syndrome is very complex, very difficult to treat, and usually is affecting the young athletes, runners, and repeated jump sports. The main biomechanical cause can be the dynamic knee valgus or abnormal abductor on the hip function, and with the neuromuscular deficiencies, abnormal patella tracking, and pay attention on dysplasia on the patellofemoral, and also on patella alta and patella baja. So we should really look at the patella tracking in order to understand not only the entire biomechanics of the lower limb, but also the biomechanics of the patellofemoral and tibiofemoral joint. And also can be related to excessive pronation of the foot. This is causing problem and pain during squat run and stair climbing. Symptoms is anterior knee pain that can be diffused, is very difficult sometimes to localize, and can be also associated to pain in the quad or in the quad tendon or in the patella tendon pain, proximally or distally. Pain, of course, related to the function. You can have, if the pain is quite associated also for the peritendonium structure, can be also present during no activity, so at rest. And so the diagnosis is, I think, is very simple, localizing the pain, but the most difficult is to understand why and the anterior knee pain is causing. So the biomechanical aspect of this. And so the treatment objective strategies, load reduction, biomechanical improvement, but you need to understand which kinetic chain you need to change, and also neuromuscular recovery. And so often also here you can have weakness in the gluteus or in quadriceps, and not synergetic function between the extensor and the flexor. And so neuromuscular exercise, particularly eccentric exercise, is very important. Jumper's knees, very frequent, coming from the Modena area where we saw quite a bit of athletes having the jumper knees is really related to chronic high tension overload of the extensor mechanism. And so the equilibrium between eccentric exercise and strengthening of the muscles is key in order to avoid this kind of pathology. Most of the time it's very important to check hip alignment and also the pronated or cavus foot in order to understand the loading condition of the patellofemoral. But mostly we should look at the hip pathology or hip weakness on the muscle that is affecting the control in varus valgus in the knee. Here, load management is related to the function and the loading condition, and so the targeted physiotherapy is looking and addressing the knowledge of the biomechanical pathology of the lower limb. Eccentric exercises for most of the lower limb, also upper limb, is key because we have a tendon adaptation. So there is a direct stimul of collagen synthesis and remodeling of the extracellular matrix in the muscle, and also distally on the tendons, and load tolerance, progressive increase in the load capacity of the patellar tendon. This is key for recovery in not only in function and strength of the muscle, but also in the structure of the muscle tendon unit. Iliotibial band syndrome is particularly quite frequent, particularly in runners, cyclists, and is mostly related to varus knee on the patients, because the iliotibial band is related to try to compensate the varus of the knee in order to get a more valgus torque, and this is causing pain in the knee, in the lateral side, and also closer to the journey insertion of the band, iliotibial band. So IL is global diagnosis, is a syndrome so it's fundamental really to have a biomechanical evaluation of the kinetic chain study. Most of the time the correction is on the foot side, and so you can change the torque and the load condition in the knee and try to reduce the load and function of the iliotibial band. So this is very important because with the eccentric and loading condition, in extensor and flexor, but mostly is trying to make with the insole in the foot a valgus torque on the knee, reducing the iliotibial band function. Pes anserinus is another very frequent pathology that is affecting runners, overweight subjects, and particularly females. And this is always associated with a weakness of the quad. So is a dysfunction between extensor and flexor. So this is very, very, very important. So the structures that are involved, sartoriogracile and semitendinosus, are because there is overfunction due to a weakness of the quadriceps. This is very important. And so the mechanism is very simple, as I mentioned before, and the treatment approach is mostly focused on the quadriceps and stretching on the hamstrings, whole hamstrings, in order to reduce the overload and to improve the synergy between the extensor and the flexor. Foot and ankle mostly are plantar fasciitis, Achilles tendinopathy, posterior tibia tendinopathies, metatarsia, stress fracture, but mostly are the first three aspects. Achilles tendinopathy. So remember that the Achilles tendon and the short musculature of the foot are the same functional structure. So the Achilles tendon functionally is attached through the short musculature of the foot to the metatarsal. And so this is another issue, is the mid-third of the Achilles tendon is very poor vascularized, and so often is very difficult for itself to recover the injury, the chronic injury of the tendon. The plantar fasciitis, as you can see here, is directly in connection with the Achilles tendon, and is usually in the more posterior aspect, closer to the posterior area and dorsal area of the calcaneus, and is associated most often on the cavus foot, but can be also present in the flat foot with the retraction of the Achilles tendon. Posterior tibial tendinopathy is affecting particularly the adults in the severe second, third degrees of flat foot, and because the function of the posterior posterior tendon and muscle is to make a correction of the plantar arch, and so try to avoid the flat foot and have a cavus foot, and so try to increase the arch of the foot. So this is a dynamic overloading close to the malleolus, medial malleolus, in the tarsal tunnel, and going also to the scaphoid osseous, so the bone. And so this is a functional pain related also to the bursa and synovial tissues that are close to the tendon, and this can be very painful, and the only way is to treat the flat foot, and treating the flat foot having with the insole posteriorly try to reducing the load on the Achilles tendon, but also in the posterior tibialis. Very, very easy. And in 90% of the cases, you can solve the pain problem with a good insole and a good shoe with the posterior hole of the shoe rigid in order to let the insole working. The medial tibial stress syndrome, particularly in very difficult to treat, but we can see I have currently one patient affecting with this, just a runner, and is friction and is on the muscle of the bone and causing the pain is on the periosteum. Sometimes you can have also some edema in the in the bone and the muscles. And this is often related to foot problem, foot dynamic problem on the foot during the sports activity. And so very important for a global diagnosis of overload injuries. Very important to have the diagnosis that can be at the beginning of the pain, and so with no absolutely damage of the tendon, or you can have a late diagnosis that can lead to a more difficult diagnosis on the pathology of the tendon. And so X-ray is not the first diagnostic procedure. We look at the X-ray only if you have, for example, in Osgood-Schlatter disease, patella tendon problem, or you can have, like in Ollier disease, friction of the bone on the tendons. And so this is a second or tertiary condition. Ultrasound is the first evaluation, very important, particularly not only to assess the quality of the tendon, the anatomy of the tendon, but also to identify the inflammatory condition of the tendon with the color ultrasound and all the new technology that is fantastic. Magnetic resonance, the MRI is important because you don't see only the tendons, but you can see also the other structure in the joint, and so you can assess also other region of the joint where the pain is coming from. So you need to understand if the pain is mostly coming from the tendon or not on the other structure. Clinical history, fundamental clinical assessment, very important, because the first thing is to understand the kinetic change problem. So the principle of treatment is key on the biomechanics, motor control, and load management, and functional deficits. And so mostly is to recover the function, the biomechanics of the kinetic chain. So this is the key point. Then associating with all the treatment option, physical treatment, treating the tendon or the ligaments and so forth, this can gain the 100% treatment of the area. But most of the time, the treatment is on the kinetic change of the whole limb. It's not related only in one side. And to understand the pathomechanics of the kinematic change problem. And so you can see here in the exercises, in the physiotherapy, very important that the exercise is structured because depending, as we said before, on the overload pathology and the abnormal kinetic change of the limb, strength recovery, very important. Mostly of the problems are associated with weakness of the muscle and dyssynergy of the function of the muscles. And so we need to improve the neuromuscular control, dynamic control, and of course, if you obtain this, you prevent the recurrence of the pathology. Very important to recreate the kinetic change, particularly for the athletes, is to have re-education, physiotherapy, mimicking, and returning to sports. And so this is key because the function is related, the pain is related to function, and is specific for that athletes during the specific sports. And so the prevention is a key for everything, and particularly in overload condition. And so this is why we need to assess very early the kids during sports, or routinely assess the athletes during the year in order to detect early dysfunction of the joint biomechanics, and then try to prevent overloading condition in the tendon. So as a take-home message is treating the cause, not just the pain. Load management is key. The kinetic chain is so important and so very difficult clinical sometimes to define, because you also need to understand the specificity of the kinetic change in sports, of the athletes, and in all the condition. And so the therapeutic exercise is central because it's strictly related to the kinetic change that is affected, and the prevention is part of the treatment. And so in conclusion, I think this is a very difficult but very fascinating area in where the overused and pathology of the tendons is absolutely multifactorial and biomechanically complex, and often you need a multidisciplinary assessment with more than one people, physiotherapist, a surgeon, and eventually sports medicine doctors, and working together and facing the problem of the athletes or the pathologies that are involved. And so the overall pathologies are not simply the results of excess load, but the inability of the musculoskeletal system to adapt properly to the load. Thank you very much.
Adesso c'è un collegamento da Israele con Palmanovic, Ezequiel. Eccolo lì, può andare.
Can you hear me? I'm not sure you can hear me.
Ma è online o no? Sì, perfetto.
Can you hear me now? Hello? You can hear me?
Yes, we can hear you.
Oh, perfect, perfect. Thank you very much.
Okay.
I'm really sorry that I can't be in Rome today. My flight was canceled, so I'm here and trying to do my best. I would like to thank you very much for the committee organization, and especially thank for Silvia that it's helping me to do this strange connection from the other side of the world. So as you see, I'm a foot and ankle surgeon. I don't know about shock wave therapy that you was talking all the day. It was really crazy stuff. I'm learning a lot about the lecture they're giving me. And I want to talk about something that probably already you hear sometime about the use of ultrasound previous to the shock wave therapy. So why to combine ultrasound and shock wave therapy? We all know, and you know more than me, that the focused shock wave therapy can be very useful in many musculoskeletal conditions. You have here the list. Probably there's much more than the list that I put it out here. But this is the most of the treatment that I'm giving today in my practice. But the treatment success depends exactly on the accurate diagnosis and localization of the pathology of the tissue. That is very that is very clever, because if you're doing the shock wave, the focused shock wave therapy in the wrong tissue, in the correct, in the not incorrect tissue, so it's not going to work. So this is funny. This is not a real person. This is AI, because you have to keep in the patients in the good aspect, if you can say like this. So I don't know sometimes where is my target, and I think I'm doing the treatment in the wrong position or in the wrong localization, because of course there's huge difference between those patients. I don't know exactly where is my target. I don't know where is exactly the deepness of the tissue that I want to treat. So I think that I can do it with ultrasound. Ultrasound allows me to make a dynamic diagnosis. Of course, I can make a diagnosis to understand the soft tissue localization, where is the pathology, where is the point of degeneration that I could treat. Telling you that follow-up is important, yes, of course. In my hands, follow-up evaluation in ultrasound, it's very poor, because I'm not a radiologist. I'm just for an ankle. I understand a little bit the anatomy, we can say, but I have no enough experience to see if we have in the 3 weeks or 6 weeks, of the treatment, if there any improvement of the pathology or not. What happens if you are trying to make a ultrasound not in correct position? We are treating blindly. So probably the referred pain is not exactly the location that the pathology is. There's obviously anatomical variability. There could be multiple painful structures, and it could be sometimes, if you understand that the pathology is in the area, what is exactly the focal degeneration that I want to treat. And of course, we can just miss the area that I want to treat. The consequences probably reduce the efficacy. We're probably going to need more sessions for the treatment, and the inconsistent outcomes. This is our problem, because we want to give our best treatment to our patients. The key message, palpation, probably in my hands, it's not enough. What is the advantages of the ultrasound? For me, in my hand, another area of the medicine, ultrasound for me it's part of the physical examination. I understand where is the pathology, where is the focus of degeneration. For example, For example, this is the Achilles tendon, the calcaneus, the retrocalcaneal wall, the retrocalcaneal bursa, the precalcaneal bursa. So sometimes the patient say, I have pain in my heel, and I don't know exactly where it's located. So we have to understand that it could be precalcaneal bursitis, it could be tendinitis, it could be insertional tendinitis, it could be non-insertional tendinitis, and it could be retrobursitis. So even if a small area, the pathology is totally different, and we have to focus our shock wave therapy exactly in the area that we have to treat. Of course, ultrasound, it's a real-time imaging. It's perfect because you can talk with the patient. Say, this is the area that invited you. This is the pain. It's non-invasive. There's no radiation, and it's today ultrasound. It's very cheap. It's not the ultrasound that we used to see for thousands of dollars or hundreds of dollars. That was in very, very expensive equipment. The principle of the focus shock wave therapy, that we have to make one shot in exactly the correct area. You know about the the principle of shockwave therapy much more than me, much more than me. You understand more the kinetic of the shockwave therapy. But what I'm trying to do is that we have to treat exactly the tissue that is our target. What is the role of the ultrasound for me during the treatment? And I'm going to show you here, for example, this is a plantar fascia of one of my patients. It's a huge plantar fascia, right? You can see it's much more than 4 millimeters. We're going to see after that. And I don't know exactly where the focus of the degeneration is located into this huge plantar fascia and the deep. You can see here a ruler into the ultrasound, and they can tell me exactly the deepness of the pathology. So for me, it's in diagnostic confirmation, target selection, deep measuring, and of course, identification of attendant structures. I can be very precise in the treatment. And of course, if you have more experience, you can make a follow-up. Plantar fasciitis, for example, this is another patient. Thickness more than 4 millimeters, hypoechogenic, fascial degeneration, neuromuscular neovascularization, and how can help me to make exactly, to identify exactly the genetic point. Of course, we can see it here, we can see the deepness of the pathology, where exactly have to be. And in this arrow can show me during the evaluation where exactly have to be the focus is the shock wave. Achilles tendinopathy, we already talked about that. It could be in the mid portion, insertional, but it's not only in the insertional or in the middle portion. It's much more pathology in the area. It could be retroperitoneal bursitis, enthesopathy, anglon deformity. There's a bunch of pathologies that it can be evaluated and localize it with the ultrasound in order to give the exactly location of the pathology in order to get my shockwave therapy treated in the correct area. So what I am doing, of course, we have to evaluate the patient. Anyway, we have to ask, to touch, to see, to evaluate the patient. I'm doing ultrasound diagnosis, and I'm doing precise target identification. You can see here in this monitor that we have an arrow that is the same arrow here. So I can see exactly where is my target. I mark the target in the foot because I want to see exactly where the arrow with the coincidence with the monitor and evaluate the deepness. And then I'm doing the focal therapy. So we can evaluate the deepness and exactly the area of the treatment. Evidence, because we are we all love about the scientific evidence. So I bring to you what the literature says. So evidence say that shockwave therapy is very effective in multiple tendinopathies, precise targeting improve outcomes, ultrasound increase diagnostic accuracy, and ultrasound follow-up provides objectivity. Is ultrasound and shockwave therapy improve the treatment? There's no. So there's no evidence that if I use an ultrasound, I'm going to get better result in my patient. I say, wow, I don't understand. If I'm doing the correct treatment in the correct area, and I help it by the ultrasound, the evidence say, the medical evidence say that I'm not going to be better doctors than the doctors that they don't using the ultrasound? Well, I think when I become older, I understand less and less and less. But this is the literature that's not avoid there are not there's no evidence that using ultrasound in the shockwave therapy can help you to get a better treatment. So we have to understand that when we have to be realistic, right? Ultrasound is not easy. You have to be operator dependent. Have to learn how to do that. There's no always correlation with pathology and symptoms. May reveal asymptomatic deteriorations that is not significant for the patient, but there's no evidence that ultrasound can give me a better treatment. So if we think that making a correct diagnosis and give the treatment in the perfectly positioned area, giving me the better result, so the literature say no, you are wrong. And it's very embarrassing because you are talking about how to use the ultrasound in order to help my patients to get better results. In the future, probably going to need some more AI, maybe ultrasound, maybe some automatic tissue mapping, and try to correlate the result of the ultrasound and the biofeedback of the patient, because sometimes we have to make a treatment into the area that the patient, localization pain of the localized pain, and not in the pathology, that it's not really clever, because we are treating pathology and not symptoms, but sometimes this happen and probably have to combine. So a combination of imaging and therapy represent more precise regenerative medicine in the future. Probably it's going to be in the next years. In conclusion, my final message is ultrasound, it could be very important, it can improve my diagnostic precision, can give me the targeting for the focused shockwave therapy, can give me some information to follow the patient, help to personalize treatment protocols, and it could be improve the outcomes. Well, probably not. So in my conclusion, ultrasound transform shockwave therapy from an empirical treatment into the guided and targeted therapy that probably is not clinical relevant. Thank you very much. I want to show you the next Congress in the Foot and Ankle Future Forum that is going to be in Bulgaria. It's going to be a great pleasure to have you all of them there. We are going to talk about the future in the foot and ankle, not only surgery, most of the technologies that, of course, shockwave therapy have to be present there. Thank you very much. I'm sorry that I'm not in Rome tonight, and hopefully next year we can be more peaceful time and be with you in the next Congress. Thank you very much.
Do we have any questions in the audience for Professor Palmanovich? We have time for one or two short questions.
I'm here.
In the meantime, we'd like to congratulate Dr. Palmanovich for a concise and clear demonstration of the applications and uses of ultrasound for guiding the application of shockwave therapy. It was an excellent presentation, sir.
Thank you very much. I think it's very important, but the bibliography is not giving me the correct answer, right? That it's incredible.
Dr. Sin, please go ahead.
Yeah, thank you, Professor Palmanovich, for the really great and interesting presentation. Just several remarks. In the previous presentation, we heard about the complexity of the lower limb problems. It's not always, the symptomatology not always comes from one specific pathology, one specific place. That's one remark. And the other is we treat the patient, not the imaging. So the ultrasound really helps us, but just for example, in my experience, you treat plantar fasciitis, and after a while, the patient, the pain moves from the bottom of the heel to the insertion of the Achilles. So you must move your the place that you treat you must listen to the patient and treat him accordingly, because we know these problems are connected. But
Dan, I totally agree with you.
Thank you again for a great and interesting presentation.
Thank you very much. I totally agree with you, Dan. And I think that the complex of the gastrocnemius soleus plantar fascia, it's a huge complex, and we have to treat it. The literature say if you're doing just shock wave therapy, it's about 60%, and if you add successful, and if you add physiotherapy into the gastrocnemius, you get more than 85%. So of course we treat the patient, we're not treating the images, but sometimes images can give you an approximation with the pathology in order to give the correct treatment. Thank you very much. It's a great honor to be there. I'm really sorry, I really want to be there with you. It's the first time they invited me to this Congress. Dan is one of the persons that is pushing me to go into that. And thank you very much again, and hopefully next year I'm going to be with you.
Good afternoon, everyone. Io vorrei fare brevissima introduzione because we have a change in the program, and probably you don't understand. This model is treatment protocol, location of the area to be treated. I'm Dr. Fabricio Vergese from Ushuaia, Argentina, at the end of the world, and I'm honored to be shared this session with my friend and colleagues, Dr. Egric Tortosa from Panama, Dr. Laura Mourinho from Brazil. It's really important item because it sounds simple, but actually it's the most important item, the location of the area. If you have the best technology, but you don't know where to be trained, probably you miss the target.
Okay.
Let's begin. Thank you so much. Grazie mille.
Well, good afternoon, everybody. Wake up, and I will speak in Spanish because I feel more fluent, but you can see the translation on the monitor. First of all, I am a physiatrist. Soy médica especialista en rehabilitación y medicina física, lo que es fisiatría. Vengo de Uruguay y les voy a presentar esta propuesta de un posicionamiento estandarizado para el tratamiento del manguito rotador mediante las ondas de choque o de presión radial, y va a ser mediante una correlación anatomo-imagenológica. Si recién hablábamos de que la fascia plantar era compleja, el hombro lo es mucho más. Y aquí vemos el problema en la práctica clínica. Les voy a pedir que miren a este video con atención. Lo difícil que es tratar el hombro correctamente. Esta es una propaganda que sale en Instagram de un consultorio de fisioterapia donde no hay médicos. Y bueno, irán sacando sus propias conclusiones a medida que pase la charla. Pero como vemos, el hombro es una estructura muy compleja, y en esta propaganda se insta a los pacientes a concurrir a tratarse el dolor del hombro. Y como aprendimos o repasamos en el último fellowship del doctor Daniel Moya, él nos aclaró que hay más de 250 causas de dolor en el hombro, por lo tanto, esto dificulta aún más el problema. Como podemos ver en esta animación en 3D, vemos cómo influencia la posición del miembro superior o del hombro en lo que es la exposición de los tendones que vamos a querer tratar, porque si no están expuestos a la superficie, si están con overlap de estructuras óseas, nunca vamos a llegar a entregar la energía donde nosotros queremos. Ven aquí cómo se mueve. ¿Tá? Y esto es muy importante. Acá vemos en la vista anterior cómo está el subescapular que se inserta en el troquín por dentro de la corredera bicipital, rotador interno de manguito rotador, y en la vista posterior vemos los tendones supraespinoso, infraespinoso y redondo menor que van a confluir, van a pasar por debajo del espacio subacromial y van a insertarse en el troquíter. ¿Tá? Lo importante es que pasan sobre que el techo es el acromion. Entonces no va a estar accesible muchas veces estos tendones a un cabezal de tratamiento. Entonces, para exponerlos, vamos a ir explicando las diferentes posiciones que debemos tener que usar. Entonces, como decíamos, la región del hombro es muy compleja, es la articulación más móvil del cuerpo humano y es difícil de tratar. Entonces, aquí vemos también otra imagen donde... Ay, perdón. Acá quiero usar el señalador. Como también estamos en estas fotos de propaganda donde se está localizando el área a tratar. Entonces nos surgen varias preguntas. ¿Sabemos realmente qué estamos tratando? ¿Cómo debemos posicionar el miembro superior? ¿Y dónde y en qué dirección vamos a aplicar el transmisor en nuestro cabezal de tratamiento? Bueno, es por ello que para contestar estas preguntas, junto al doctor Moya, hicimos este trabajo en Uruguay, que es una propuesta estandarizada donde el objetivo era describir la mejor posición del miembro superior y estandarizar el abordaje para tratar la patología del manguito rotador, pero basado en una correlación radiológica y ultrasonográfica, pero obtenido por una médica especialista en imagenología. ¿Tá? Sabemos que como esta charla viene de la mano de la anterior, ¿tá? Y es importante, el examen ecográfico, ultrasonográfico es operador dependiente. ¿Tá? Y los otros que intervenimos somos médicos especialistas en lo que es las ondas de choque. Bueno, entonces, siguiendo el hilo del trabajo, una de las claves para el éxito del tratamiento con ondas de choque o con ondas radiales de presión es entregar la energía al área correcta. Y esto ya se vino diciendo hoy varias veces en lo que es la Shock Wave Medicine y Precision Treatment. Pero debemos tener una atención, y es lo que habló Aaron hoy en la pregunta del otro colega, es que esta es la precaución, hay una disociación clínico-lesional, o sea, hay una alta prevalencia de lesiones asintomáticas en lo que es el manguito cortorrotador. Entonces, nuestras decisiones terapéuticas van a tener que estar basadas en la clínica, en la patología, y no solamente en los hallazgos imagenológicos. Como decíamos, no tratamos imágenes, tratamos pacientes. Entonces, hasta ahora en la literatura aparecieron varias propuestas para determinar el área del tratamiento. Una fue mediante un marcaje anatómico sobre la piel, la otra guiándonos por el biofeedback del dolor del paciente, o por aplicándolo en el punto de máximo dolor a la palpación. También hay protocolos que utilizaban el posicionamiento y otros métodos apoyándonos en imagenología como la fluoroscopía, la ultrasonografía y la tomografía computada. existe bastante evidencia en lo que es el tratamiento de la tendinopatía calcificante, tanto utilizando la ecografía, utilizando algunas posiciones estandarizadas, apoyándose en la radiografía simple y también en la fluoroscopía. Pero por el contrario, en lo que es la tendinopatía no calcificante, iba a decir tendinosis y hoy aprendimos que no se debe usar, los grados de recomendación no son tan buenos como en el caso anterior, que son grados de recomendación A y en algunos B, pero aquí hay bastante literatura, hay revisiones sistemáticas y metaanálisis recientes donde obtienen resultados no concluyentes en cuanto al éxito del tratamiento con ondas de choque, ondas de presión, o en cuanto a los resultados en esta patología no calcificante. Es así que el grado de recomendación es C, o sea, es inconcluyente, no está ni a favor ni en contra o contradictorios en usar esta tecnología, estos dispositivos, en lo que es la tendinopatía no calcificante. Sí voy a recalcar este estudio en el cual estuvo involucrado el doctor Kilof, ya retirado, donde se aplicó en pacientes que ya tenían lesiones del manguito rotador y que iban a ser intervenidos por artroscopía o por cirugía abierta, y se les aplicó solo una sesión de ondas focales un mes antes de la cirugía, y allí se tomaron muestras anatomopatológicas y se muestra en esta imagen de la izquierda cómo hay una linfangiogénesis y neoangiogénesis, pero solo lo obtuvieron en las tendinopatías de grado 2 y 3 de la escala de Riley, que corresponde a degeneración leve o moderada. Ya cuando era una degeneración, un tendón con una degeneración muy importante, no vieron estos cambios biológicos. Nos inspiramos, y aquí está o estuvo presente Sangwei, uno de los coautores de este trabajo, porque nos inspiramos en este trabajo donde los cambios en la posición de la cadera hacían más accesibles a un cabezal de tratamiento el área de la necrosis femoral. Hicimos el estudio en el Hospital del Banco de Seguros con un dispositivo de General Electric para ultrasonido, con el hombro de un voluntario que era un fisioterapeuta, y utilizamos radiografías simples con marcas de metal, y participamos especialistas en ondas de choque. Para realizar el examen ultrasonográfico se utilizó el abordaje anterior, como está acá, el paciente sentado en la camilla frente al examinador que permanece de pie, y se utilizó una sonda de entre 12 y 15 MHz, que son las que se utilizan para explorar las estructuras más superficiales. Aquí tienen, y si quieren copiarlo, el código QR, porque yo, por razones de tiempo, lo voy a decir más rápido, lo que es el posicionamiento, y está bueno que lo tengan. Les doy unos segundos. Bien. Bueno, para dibujar los reperes óseos, las marcas anatómicas sobre la piel, se apoyó la sonda en esa posición tangencial sobre el acromion, y se ve de medial a lateral la clavícula, la articulación acromioclavicular y el acromion, y así fue como fueron dibujadas sobre la piel. Después se colocó la sonda en esta posición, como se ve en este dibujito, y topografiamos con el miembro superior en esta posición, de medial a lateral, el troquín, la corredera bicipital donde transcurre el tendón del bíceps largo, y por fuera el troquíter. Y para identificar la apófisis coracoides fue en esta posición que se obtuvo esta imagen y la marcamos sobre la piel. Entonces, para exponer las fibras más posteriores del supraespinoso, Lo que hicimos fue que el paciente hiciera una rotación interna por detrás del tronco, ¿tá? Con la mano en esa posición, y obtuvimos esa imagen que despliega las fibras posteriores del supraespinoso. Con el transductor en esta posición, colocamos la marca de metal, y esta es una imagen ilustrativa con una onda de choque de presión radial, y estos fueron los enfoques obtenidos con el marcaje de metal, donde vemos aquí cómo se expone en el sector más anterior del espacio subacromial, en esta radiografía de perfil escapular, donde estaríamos tratando, se va a exponer estas fibras más posteriores del tendón. Si no, no vamos a poder acceder a ellas. Aquí nada más mostrar un poquito cómo hicimos los enfoques, que fueron de manera tradicional, son proyecciones sobre la piel, no es 3D, por tanto acá se hacen con una inclinación de 15 grados cefalocaudal, y obtuvimos de esta forma estas imágenes. Para mostrar un poquito cómo lo hicimos. Para exponer las fibras medias del supraespinoso, utilizamos también la rotación interna, pero esta vez con la mano sobre la cresta ilíaca, también en rotación interna. Y vamos a desplegar las fibras medias, ¿tá? Y el abordaje básicamente es el mismo, ¿tá? Nada más que el marcaje está un poquito más inferior que en el caso anterior. Y aquí, para acceder a las fibras más anteriores o insercionales en el troquíter del supraespinoso, acá lo vemos desplegado y la marca de metal está en esta posición, que es donde aplicamos la onda de presión, y está enfrentado al troquín lo que es las fibras anteriores. Por tanto, las fibras más posteriores van a estar inaccesibles porque van a estar debajo del acromion y nunca vamos a llegar a ella. Y la posición es esta, con el miembro superior neutro y la palma hacia arriba. Y así es que hicimos la proyección. Para el infraespinoso, la posición es esta, con la mano en el hombro contralateral, también rotación interna, pero por delante del tronco. Obtuvimos esta imagen del infraespinoso y el abordaje es un poquito más lateral, con la sonda colocada en este lugar, fue que obtuvimos esta imagen, y en este caso ejemplificamos con un aplicador focal. Y aquí está el marcaje de metal sobre la piel. Estamos terminando. Para el tendón subescapular, la posición es esta otra, porque es un rotador interno, lo tenemos que exponer. Por tanto, vamos a hacer una ligera abducción, una ligera antepulsión y una rotación externa muy leve de 60 grados. Y aquí es donde se van a exponer estas fibras del subescapular. Entonces, recordamos, la coracoides por dentro, ¿tá? Y el tendón subescapular, y por fuera va a quedar la corredera bicipital, porque es muy doloroso aplicarlo sobre la corredera. Y aquí está el marcaje sobre la piel, que queda directamente sobre el troquín, sobre la inserción. Entonces, terminando, ¿qué es lo importante acá y el mensaje para llegar a casa? Es que, bueno, vamos a establecer primero que nada un diagnóstico correcto, no basándonos solo en las imágenes, sino haciendo una correlación entre la clínica, la sintomatología, el examen físico y las imágenes. Y después tenemos que reconocer cómo debemos posicionar el miembro superior para que realmente, para tratar y exponer la estructura que realmente queremos tratar. Entonces, a través de este abordaje, nuestro objetivo es mejorar y estandarizar la técnica, la aplicación técnica, y que no pase lo que vimos en el video al inicio, especialmente cuando no tenemos un aparato de ultrasonografía como tenía el doctor de la presentación anterior, que si bien sería ideal tenerlo, no es siempre que lo vamos a tener. Y con esto, bueno, mejorar los resultados, tal vez pasar de un grado de recomendación C a uno mejor. Bueno, muchas gracias.
Before questions, I want to say it's a pleasure to share with the doctor Michelle Bocanera from Italy. It's here, and the other doctor who stand up and go and move, Dr. Alfonso. And we are finished. Thank you so much.
We are going now for the coffee break, and we return in 15 minutes. Okay. Coffee break.
Coffee break. Signori congressisti, doctor, adesso daremo la parola a Roland Emi Sultan della France.
D'accord. Et ça, c'est pour S. Mais va benissimo. Ça, c'est pour avancer. Ça, c'est pour avancer. Reculer. Ça, c'est quoi ça? Non, non, non. Non, ça, c'est ça. D'accord.
Thank you for all. Please sit down, and in this way we can start with the session. With this session in this afternoon or evening session, we are in the middle. The first speaker is Dr. Emi Sultan, with a presentation, ultrasound, an indispensable complement to ESWT. Thank you so much.
Voilà. Merci beaucoup. D'abord, merci Alfonso pour ce lieu magnifique. Tu nous as invités. Je ne sais pas si ça traduit. Yes. Et je vous rassure, je ne vais pas répéter les deux brillantes présentations qui m'ont précédé, hein, qui parlent à peu près du même sujet. Alors, depuis le développement des ondes de choc, surtout pour les calculs rénaux, le repérage échographique et radiographique est obligatoire. De même, pour moi, dans l'expérience, l'échographie est obligatoire dans l'appareil musculo-squelettique. D'abord, on va parler des traitements des calcifications. Il est obligatoire de bien cibler la calcification de l'épaule. Bien sûr, quand on a comme moi un épaule d'ornier avec échographie in-live pour le repérage, c'est très facile. Malheureusement, je crois que c'est moi qui ai acheté la dernière machine qui existe. Donc maintenant, on n'a plus que des pièces à main. Et donc, il faut faire avec. Alors, il faut donc identifier la calcification, la marquer avec l'échographie. Alors, ce qui est important, c'est que beaucoup de personnes qui font des repérages chez vous font la même erreur lorsqu'ils font marquer d'abord, des fois ils ne le font pas directement, ils font marquer l'endroit chez un échographiste, chez un radiologue. Ça, c'est l'erreur. Parce qu'il faut savoir, l'erreur, c'est qu'on doit savoir déterminer dans quelle position était l'épaule, dans quelle position on a appareillé la lésion, la calcification, pour l'épaule. Donc, on doit savoir si on voit bien la classification en rotation interne, en neutre, rotation externe. La démonstration. Voilà cette personne. Voilà. Elle est en rotation interne. Là, on voit la classification apparaît. Maintenant, je vais la mettre en position neutre. Et là, la classification disparaît. Maintenant, je passe en position rotation externe. Toujours pas de classification. Donc, si vous faites, on a marqué, vous avez mis en rotation interne ou externe, alors que votre cible est en rotation interne, vous allez rater la cible. Alors là, je vous pose une question. On revient à la patiente que je vous ai montrée. Voici cette classification. Qu'est-ce qui vous dit qu'on peut traiter par onde de choc ou par ponction, lavage, aspiration? What do you think? With this image, you can see shock wave is okay, or PLR is okay. You see? L'échographie est très performant dans l'étude de la dureté des cailloux, des classifications de la coiffe des rotateurs. Donc, on peut dire que lorsque la classification est dure, c'est l'indication des shockwaves. Si la classification est molle, ce serait l'indication des PLA. Mais moi, je vous dis honnêtement, avec 40 ans d'expérience, les classifications molles, ça marche bien avec les ondes de choc. C'est surtout pour éliminer, là, c'est surtout pour savoir l'heure à laquelle on peut faire une ponction lavage-aspiration. Alors, comment on analyse? If the classification without posterior acoustic shadowing, it can be considered as soft. Les qualifications sont molles, and PLA can be considered. If there is, s'il y a a posterior shadow cone, un cône d'ombre postérieur, la classification est considérée comme dure. Donc, la PLA ne marchera pas. C'est l'indication pure des ondes de choc. Et intermédiaire, si vous avez simplement une atténuation du mur postérieur, mais pas de cône d'ombre, donc on peut dire que la classification est entre les deux. Il est très difficile de savoir la dureté. Peut-être une image, un scanner pourrait le déterminer, mais par expérience, moi je considère que cette image-là, on ne peut pas faire de ponction lavage-aspiration. Le mieux, c'est les ondes de choc. Là, on revient à ma patiente. Donc, qu'est-ce que je voulais analyser là-dedans? C'est là, je crois. Enfin, l'image, oui. Là-dedans, c'est que vous regardez la classification, vous avez une atténuation du mur postérieur, là, et après, par contre, il n'y a pas de cône d'ombre, c'est-à-dire que le reflet de l'épaule est continu. Il n'y a pas de cône d'ombre, il n'est pas effacé. Donc, j'avais dit, c'est une image intermédiaire et cette patiente est sujette aux ondes de choc. Et alors, une chose que je vous dis, cette patiente a déjà fait des ondes de choc. La première image que j'ai eue, c'est un cône d'ombre. Qu'est-ce que ça veut dire? Ça veut dire qu'il y a eu un changement depuis la première séance, de la consistance du caillou. En plus de cibler, ce qui est important, on travaille dans 3 dimensions, c'est la profondeur à laquelle vous allez envoyer votre onde de choc. Si vous allez faire du radial qui ne dépasse pas 2 cm, vous n'avez aucune chance d'avoir une lésion qui se trouve à 5 cm. Donc, là, vous avez soit le choix, vous pouvez régler, ajuster la profondeur directement avec l'appareil, ou certains constructeurs peuvent vous donner des stand-up, c'est-à-dire des têtes en silicone qui vont vous donner la profondeur. Là, ici. Alors, autre chose, quel est l'apport du power Doppler, du Doppler couleur, dans les tendinistes et quel rapport avec les ondes de choc? Alors, il faut savoir qu'on va parler de néovascularisation. Alors, on parle de tendinisme, mais les études d'Alfredson disent qu'on ne doit plus parler de tendinisme, puisqu'on ne trouve pas de cellules inflammatoires à la biopsie. Et pour Alfredson, ce serait des néovaisseaux qui se constitueraient. Et ces néovaisseaux donnent seraient la cause des douleurs. Et donc, dans son étude, il voit bien que 80% des patients avec symptomatiques du tendon d'Achille avaient une néovascularisation. Et tout ceci est corrélé avec la douleur. Alors, je vous rappelle l'étude Manu's Study of Alfredson. Il avait pris des athlètes suédois. Il a injecté un sclérosant pour les veines, les polydocanoles, sous échographie, et exactement dans les lésions. Voilà. Et il a eu des très bons... voilà, c'est ça. OK. Il a eu des très bons résultats, il a eu 50% de bons résultats là-dedans, mais injecter du polydicanol pose un problème vu le produit qu'on injecte. Alors une autre étude qui agit aussi sur les néovaisseaux, parce que nous on part du principe que si ça marche, c'est qu'on réduit les néovaisseaux, d'accord? Alors c'est l'étude du travail excentrique, les trainings excentriques Achilles training, avec 3 grandes études. Donc là, pendant 2 ans, les sujets sont suivis. On surveille donc le changement au niveau des néovaisseaux. Voilà. Et on voit qu'il y a vraiment un effet du excentrique sur les néovaisseaux. Alors, qu'est-ce qu'on se pose? Si ça marche, l'excentrique marche. Si les injections de polycanol marchent, est-ce que les ondes de choc font la même chose? Donc, c'est l'étude que j'avais proposée il y a quelques années. Alors, ça, c'est l'étude que j'ai faite à l'époque. Donc, on prend 2 paramètres, l'image échographique, les néovaisseaux, et la VAS, scar. Okay. Alors, donc, voici le traitement. Il s'est fait avec un dornier épaule à l'époque. Et on avait bien repéré la région à traiter. Et donc, l'important de cette étude, c'est de comparer, de voir si on a les mêmes résultats sur les néovaisseaux, comme les travails excentriques et comme les injections de polydocanol. Alors ça, c'est un exemple de cas qu'on a fait. Donc, on voit que avant et avant. Oh, pardon, je me suis trompé. Voilà. Que la VAS est corrélée avec les néovaisseaux. Donc vous avez vu d'abord 8 de VAS sur 10 et les néovaisseaux en profusion. Et à la fin du traitement, aucune douleur et plus néovaisseaux. Alors on pense que cette étude montre qu'il y a un effet des ondes de choc sur les néovaisseaux corrélé avec la réduction de la douleur. Comme le fait, l'a dit Alfredson avec son étude sur les polydicanols. Donc, il arrive à réduire les néovaisseaux en agissant sur, d'après lui, les degrés du glutamate, les récepteurs à glutamate. Mais est-ce que nous, le problème, c'est qu'on a beaucoup évolué, vous avez suivi les ondes de choc. Au début, on pensait que les ondes de choc détruisaient. Or, maintenant, on dit que les ondes de choc, au contraire, ont toujours un effet biologique régénératif. C'était surtout qu'il y avait des problèmes notre ami Richard Thiel. Donc, il s'est passé une chose pendant l'étude. On a eu un cas où la néovascularisation est revenue un petit moment et est redisparue. Donc, ce qui veut dire que peut-être qu'on n'agit pas en détruisant. Et peut-être qu'on a une action biologique sur ces néovaisseaux. Ça reprend le schéma de notre regretté professeur Wang de Taïwan, hein, qui montre bien, vous avez tout le schéma que vous devez tous connaître, hein, des effets des ondes de choc. Donc, une autre chose, c'est que pour moi, les power Doppler peuvent être un outil pour savoir l'intensité sur laquelle on va traiter un tendon. Donc, pour moi, si le tendon n'a pas de néovaisseaux, je ferai de la basse énergie. Si le tendon a beaucoup de néovaisseaux, je ferai de la haute énergie. La même chose hein, ici pour le jumper knee. Ici, vous voyez l'échographie. Là, avec le power Doppler, il n'y a pas de néovaisseaux. Cette patiente, j'ai traité en basse énergie. Là, par contre, ce patient, j'ai traité en haute énergie. Alors, je vous rappelle brièvement la présentation que j'ai présentée à Sao Paulo il y a 2 ans, où on utilise aussi l'échographie. On va pouvoir classer, c'est-à-dire que d'abord, on va étudier l'épaisseur de la ponévrose à 3 endroits, avec une normalité. Voilà. Et on va faire un algorithme avec 2 facteurs, l'épaisseur, thickness, et l'hypoéchoïde, l'aspect de l'hypoïque signal. Et on arrive à déterminer 4 cases, et on va pouvoir orienter si on veut faire un traitement conservatif, un traitement agressif ou une intervention, non, pas d'intervention. Alors là, vous avez, et on détermine 3 groupes, le groupe A, B et C. Alors, groupe A, c'est les traitements normaux, de kiné, etc., y compris les pressure wave. Groupe B, les ondes de choc, le PRP. Groupe C, la fasciotomie. Alors, vous voyez bien, là, on voit ici les ondes de choc, dans ces 3 cases-là. Les PRP dans ces cases-là, et à la fin, vous avez, là, quand c'est vraiment grave, c'est la peste de la fasciotomie. Alors, autre chose, est-ce qu'on a besoin de faire aussi de l'échographie au niveau rachidien? Hein, beaucoup de gens pensent que l'échographie dans le rachis, ça ne sert à rien, d'accord? Alors surtout, là je vous montre l'étude qu'avait fait l'école de Prague, les Nedelka, hein, où ils ont beaucoup travaillé sur les facet joints, de facet joints. Et je crois qu'il est très important, lorsqu'on fait les facet joints, de bien repérer la facette. Surtout, essentiellement, si on utilise des focales. Alors pour repérer, d'abord, il est important de savoir le niveau. Alors vous me direz, moi je suis capable de savoir le niveau avec ma main. On a fait la même étude avec les très perfectionnés anesthésistes. On leur a proposé de faire des péridurales. Et en faisant des péridurales, on s'est aperçu, dans 25% des cas, ils n'étaient pas là. C'est ce qui est important. Donc, des fois, si votre femme fait une épidurale et pendant l'accouchement, votre femme dit, elle hurle à la douleur, en fait, je crois qu'ils ne sont pas dessus. Voilà. Donc, c'est pour ça qu'il est très important, de repérer. Alors, nous, on appelle ça le camel signe, le signe du chameau. Voilà. Et là, on peut, à partir de là, compter les vertèbres, avec l'échographie avec précision. Après, maintenant qu'on a we have the level, maintenant on doit être une sight sur la facet joint. Alors pour ça, voici la coupe échographique. Voilà. Nous, on appelle ça le signe de Batman, pas de Christopher Nolan. Hein. Voilà. Voilà, le signe de Batman, voilà, on dessine ça. Et il faut savoir que vos facettes, elles sont sur l'oreille. La facette, c'est l'oreille de Batman. Voilà. La facette, c'est l'oreille de Batman. Alors, vous n'avez pas besoin d'être précisément dessus. Alors, lorsqu'on fait les blocs pour les facet joints, vous avez le choix, soit vous allez injecter dans l'articulation, ce qui est très difficile, douloureuse, ou vous allez injecter autour. Et autour, il y a un paquet nerveux. Et il n'y a pas plus de meilleur résultat qu'on est dedans ou autour. Donc moi, je vous conseille d'être autour. Alors, je vous remercie et bonne cible.
Thanks so much for your keynote lecture. And now I would like to present Dr. Tonatiuh Avila, please. He speaks radial pressure waves in carpal tunnel syndrome, a bridge between evidence and clinical practice. Please.
Gracias. Bola, bola, si sa, sempre più in alto si va. It's okay with the sound, with this microphone. Yeah? Bola, bola con me. Il mondo è matto perché? Buenas tardes. Grazie mille per l'invito, è un onore, è un piacere essere qui. I will discuss the latest scientific evidence and our clinical experience regarding the effectiveness and clinical implications of radial pressure wave therapy in patients, There we have. Thank you. In patients with carpal tunnel syndrome. My favorite sport is baseball, and even though Italy defeated Mexico in the last World Baseball Classic, it would have been great if the national team of this beautiful country had won the championship. I have no conflicts of interest or financial relationships to declare. Carpal tunnel syndrome is the most common entrapment neuropathy of the upper limb. It is caused by compression of the median nerve at the wrist and mainly affects middle-aged women. Patients usually complain of pain, numbness, weakness, which may significantly affect daily activities and quality of life. Let me try it again. Several risk factors have been associated with carpal tunnel syndrome, including repetitive hand activities, obesity, diabetes, pregnancy, and rheumatoid arthritis. Because of its high prevalence and functional impact, CTS represent an important challenge in musculoskeletal rehabilitation. Serious diagnosis. Are you projecting from your computer? Okay. Thank you. Before discussing clinical evidence, it is important to understand that radial pressure waves, as Dr. Daniel Moya said this morning, are not true shock waves. Radial pressure waves are generated by a ballistic projectile accelerated by compressed air, producing radially expanding mechanical waves. The waves are characterized by lower peak pressure, longer rise time, and more superficial tissue penetration, usually around 3 to 4 centimeters. Despite these physical differences, radial pressure wave therapy may still induce important biological effects through mechanisms such as cavitation and mechanotransduction. These concepts are important because they mostly explain the clinical effects observed in patients with CTS. The biological mechanisms underlying radial pressure wave therapy in carpal tunnel syndrome are still not completely understood. Mechanical stimulation generated by radial pressure waves may induce different biological responses that could eventually translate into clinical improvement. From a clinical perspective, these effects may be grouped into three major categories. First, analgesic effects, including reduction of substance P, modulation of nociceptive activity, and hyperstimulation analgesia. Second, potential neural effects, such as improved nerve conduction, Schwann cell activation, and axonal regeneration. And third, vascular effects, including neoangiogenesis, nitric oxide release, and improved microcirculation. Together, these mechanisms may partly explain the symptomatic and functional improvements reported in patients with carpal tunnel syndrome. Several randomized controlled trials have evaluated radial pressure wave therapy in patients with mild to moderate carpal tunnel syndrome. Despite difference in the study design, dosing protocols, and comparison groups, most studies consistently reported improvement in pain, functional outcomes, and in some cases, electrophysiological parameters. Some trials compared radial pressure wave therapy with corticosteroid injections, while others evaluated different application sites or combined therapies such as kinesiotaping and exercise program. Importantly, although treatment protocols varied substantially across studies, favorable clinical outcomes were repeatedly observed in patients receiving radial pressure wave therapy. These findings support the potential therapeutic role of this approach, but also highlight a major limitation in the current literature, the lack of protocol standardization. This updated meta-analysis included 19 randomized controlled trials with more than 850 patients. Overall, both focused and radial waves demonstrated improvement in symptom severity, hand function, and electrophysiological outcomes in patients with CTS. However, substantial heterogeneity across studies remained one of the main findings. Different authors use different application sites, pulse numbers, frequencies, pressures, and outcome measures. Therefore, although current evidence supports radial pressure wave therapy as a promising non-invasive treatment option, important questions regarding optimal dosing remain unanswered. And that is precisely where our research group is currently focusing its efforts. Currently, no universally accepted application site or dosing protocol exists. Across published studies, authors have used different targets, including the median nerve and the carpal tunnel, distal palmar regions, the flexor retinaculum, and more diffuse pisiform-based approaches. Substantial variability exists in the number of sessions, pulse delivery, pressure levels, and treatment frequency. Despite this, many studies still reported favorable clinical outcomes. Radial pressure wave therapy may have therapeutic flexibility, but it also highlights the need for future studies focused on protocol standardization. Our research group designed a double-blind randomized control trial comparing two different dosing strategies in patients with carpal tunnel syndrome. This study is currently being conducted at the Hospital Civil de Guadalajara, one of the largest public referral hospitals in Mexico. The control group, and I was talking about the complexity to design the control group with Dr. Simplicio, received a constant radial pressure wave therapy protocol with fixed parameters across all sessions. The experimental group received a modulated protocol with progressive changes in pulse delivery, frequency, and pressure throughout treatment. Both groups completed 3 sessions and received the same home exercise program. Outcome measures included pain, functional status, hand grip strength, and nerve conduction studies, with follow-up evaluations up to 6 months. Both protocols demonstrated favorable clinical outcomes in enrolled patients. Across follow-up evaluations, we observed improvement in all outcome measures. However, one of the most interesting findings was that no significant difference between groups were identified over time. In other words, both the constant and the modulated dosing strategies appear to provide clinical benefit. In high-demand public healthcare systems, such as ours, shorter and resource-efficient treatment strategies may represent an important advantage for musculoskeletal rehabilitation services. At the same time, our results reinforce the need for future research focused on protocol optimization. What can we take home from the current evidence and our clinical experience? First, the available literature supports as a promising non-invasive treatment option for patients with carpal tunnel syndrome. Second, important variability still exists regarding application sites and dosing strategies. Different protocols may achieve favorable outcomes, but protocol optimization and standardization remain major challenges for future research. And finally, from the perspective of a large hospital in Latin America, radial pressure wave therapy may help improve access to efficient musculoskeletal rehabilitation in high-demand healthcare systems. In this context, bridging evidence and clinical practice is not only a scientific goal, but also a clinical necessity. I'm so sorry because of the technical problems. If you scan this code, where you will find my complete presentation and most of the cited references. Thank you very much for your attention. Grazie mille, muchas gracias.
Many thanks for Dr. Tonatiuh. And I would like to ask some question for Professor Amisultane, please. Have you some question? Yes, please. Madam.
Voy a hacer en español. Con respecto a los hallazgos ecográficos ya de una tendinosis aquiliana, nosotros en la clínica donde trabajo utilizamos polidocanol, pero nos percatamos que el efecto analgésico del polidocanol no era tanto por llenar los vasos sanguíneos, sino que era por disecar de una forma hidráulica el paratendón del tendón. Ese era el efecto, digamos, analgésico que se producía. Y lo que me llama la atención es que los patrones que se mostraron ahí era de una hipervascularización intratendínea. Lo que siempre encontramos como patrón ecográfico en tendinosis aquiliana era un patrón de hipervascularización peritendínea con un patrón avascular intratendíneo. Y lo que mejoraba en el tiempo, después de la aplicación de las ondas de choque, es que el patrón hipervascular peritendíneo desaparecía para dar lugar a vasos de penetración dentro del tendón. Eso es al menos los hallazgos que nosotros desarrollamos. El polidocanol ya no lo utilizamos porque nos dimos cuenta también que esa disección hidráulica de la peritendinitis aquiliana se podría alcanzar también con suero fisiológico, que es mucho más barato y accesible.
Gracias. Do you understand?
La risposta deve schiacciare il microfono. No, il problema è che lui non ha capito, non entiende l'espagnolo. There is some colleague that can translate from. Okay, perfect.
No, resumiéndolo, el patrón que encontrábamos en tendinosis aquiliana era una hipervascularización periférica con avascularidad intratendínea. El patrón que encontrábamos en tendinosis aquiliana era hipervascularización periférica y avascular, un patrón avascular intratendíneo. No encontrábamos una hipervascularización intratendínea, porque ahí el tendón estaría sano.
There are no vascularizations. We speak about neo-vessel. My purpose is, I think that the problem is when there are a traumatism, ça traduit là? Oui. C'est quand il y a un traumatisme, le corps essaye de réparer. Donc le tendon, il se crée une néovascularisation pour guérir. Mais comme il n'y arrive pas, c'est la néovascularisation qui entraîne le problème. C'est pour ça que ça devient chronique. D'accord.
C'était traduit là.
C'est traduit là.
Oui, voilà. Está traducido allá. Sí. ¿Entendió todo?
Sí, perfecto.
No? ¿Perfecto? Sí. ¿Duda?
No.
Perfecto.
C'est bon?
Sí.
Thank you so much. We are sorry for this kind of problem of translation, but we try to solve. Thank you so much for the translator. Thank you. And some question from the second presentation from Dr. Avila. Please.
I'm sorry. Please, mister. I'm sorry. Are you listening to me? Yes, with the sound. The slide with the dosing protocol that we used on the experimental group was just in the time with the technical trouble, but here you have it. So our constant radial pressure wave therapy, 2,500 pulses, 10 hertz, and 2 bars. And the experimental group that we decide to name it like that, also 3 sessions First stage with 800 pulses, 5 hertz, and 1.5 hertz. The second part, the second stage, 900 pulses with 10 hertz and 2 bars. And the last stage, the last phase, 800 pulses with 12 hertz and 2.5 bar. We are almost publishing this article right now. We are waiting for the response of the first journal, and our discussion and conclusion are based on no significant difference. If you do it or apply it constant or modulated, the result is going to be the same. Almost 50 patients with 20 or 22 patients per group. Okay.
Thank you so much. The next speaker is Dr. Smerli from Bologna, and the topic for his presentation is secondary knee osteonecrosis treatment option.
Good afternoon to you all. Thank you, Alfonso, for the kind invitation. We are going to talk about the treatment option for secondary osteonecrosis of the knee. Secondary osteonecrosis of the knee is a rare but debilitating progressive disease characterized by bone ischemia. It can lead to death of the tissue, necrosis, and progressive joint destruction. It can be bilateral or multifocal. The knee osteonecrosis is generally classified into 3 types: the primary or idiopathic one, which appear without any risk factors. The secondary osteonecrosis is generally related to predisposing condition, and the third type is the post-arthroscopy osteonecrosis, which arises after knee arthroscopy due to cartilage damage. The predisposing condition for secondary osteonecrosis include steroid use, alcohol excess, obesity, chemotherapy, organ transplantation, post-COVID disease, and other conditions. The secondary osteonecrosis generally manifests in young people, unlike primary osteonecrosis, and present an anatomopathological characteristic that is the extension in the metaphysis and the diaphysis. And the diagnosis is based on MRI, that is the method of choice in the early phases of the disease. But X-ray is very important in the advanced stage and for monitoring of the disease progression. It is important to evaluate the collapse and subchondral fracture and the advanced osteoarthritis. So, on MRI, we can find a serpentine-like lesion with different area of bone marrow, with inside area of necrosis surrounded by reactive bone. The differential diagnosis is with all form of subchondral insufficiency and fracture of the knee, osteochondritis dissecans, the degenerative disease, and tumor and tumor-like lesion. The treatment depend on the stage of the disease. In stage 1 and 2, the initial treatment is a conservative one and consists of lifestyle modification, the use of medication, bisphosphonate, and physical therapy. The physical therapy consists of extracorporeal shock wave, pulsed electromagnetic, and oxygenotherapy, hyperbaric oxygenotherapy. And when the conservative treatment fails, we can think about surgical option. The extracorporeal shock wave is able to promote blood supply. So the aim is to improve the vascularization of the lesion. The surgical options are a challenge due to the young age of this person. In stage 1 and 2, we can do a joint preservation surgery. Generally in arthroscopy, we can do debridement, drilling of the subchondral bone. We can employ autologous chondrocyte transplantation, mesenchymal stem cells, and scaffold. But in stage 3 and 4, the solution is the knee arthroplasty. This is a case we treated a young woman with secondary osteonecrosis in the lateral femoral condyle. We treat the person with drilling of the subchondral bone and application of scaffold. Generally, the preservation surgery can lead to a good result in more than 70% of cases. When we have a complete destruction of the joint, the solution is the knee arthroplasty, like in this case. In literature, we have good results with total and uni knee arthroplasty, but our preference is for the total knee arthroplasty. So, extracorporeal shock wave therapy is a non-invasive treatment. It is important in the early stage of the disease. However, the role is not well defined. In the MRI, we can see a case of an extension in the epiphysis, metaphysis, and diaphysis. So, in literature, we have a different study. In this recent preclinical study in animal, the authors found that extracorporeal shock wave can lead to regeneration of cartilage and bone. And also in this study, is this a systematic review of randomized controlled trial? The authors conclude that extracorporeal shock wave is a useful conservative treatment for all vascular lesion of the bone. So in conclusion, it is important in early diagnosis and an appropriate management of secondary osteonecrosis. Extracorporeal shock wave show promise effect, but we need randomized multicentric study to better define the treatment. Thank you.
Thank you, Dr. Smerli. Some question from all? Some question for Dr. Smerli, please.
Thank you. It was very interesting. I must share a case I had recently. 20 years old male who appeared with a hip pain that eventually diagnosed with Hodgkin lymphoma of the bone. And the hematologist says that now he's cured from lymphoma, but he has secondary osteonecrosis of the femoral head, exactly as you showed with the geographical border of both hips. Mostly, the main pain is in the side where the lymphoma was diagnosed first. What do you advise? Do you think it is logical to do shock waves?
No, if we have adopt of tumor lesion, we have to do biopsy. This is a lesion in the knee. It is characterized lesion in the tibia and the femur. Generally is multifocal, and in this case we can do shock wave. But if we have adapt, it is important to do biopsy.
Thank you.
But this is characterized, the board is sclerotic. In the lymphoma, there is no...
Going into the diaphysis.
In lymphoma, I think there is no sclerotic bone around the lesion.
It's secondary osteonecrosis.
Yes,
but that's the difficult question, what to do now.
It is more, less defined, the lesion is more osteolytic, I think, and without border.
I think that when we have some doubts on diagnosis, we need to perform CT scan and biopsy, because it's impossible. It's not completely exact to track or to this kind of lesion if you don't are sure to diagnosis, because it's impossible to treat. Otherwise, we can do worse another additional problem to the patient.
It is a very important and educative question that you are proposing.
My compliments, Professor Smerli. In your experience, how many times lives the benefit of this treatment in osteonecrosis? How many times long?
Secondary osteonecrosis is very rare. In primary osteonecrosis, when we don't have the collapse of subchondral bone, the effect is good. The problem is when we have a collapse of subchondral bone. In this case, in young people, we can do a conservative surgery, but in older one, the solution is the arthroplasty.
Thanks.
Other question? No. We go ahead. The next speaker is Dr. Cruel from Brazil, ESWT and neck pain systematic review.
Good afternoon, everybody. Go on. We start off with our presentation now in English. We're going to talk about the efficacy and safety of extracorporeal shock wave therapy for neck pain, because we saw there's something missing in the literature. It is a universal problem. Everybody, I got some nodding there. Everybody is having this kind of problem because of posture, and everybody here in this very room is using those cellular telephones every single day. And of course, 30 to 50% of prevalence of neck pain in the general population are frequently driven by myofascial pain syndrome, and 40% is the proportion of patients who experience inadequate efficacy and relief from conventional chronic pain management. The current standard is exercise, ultrasound, medication, that do offer relief sometimes, but lack deep tissue regeneration capability and show limited long-term efficacy. High-energy acoustic pulses conduct mechanical single-sonic pulses into targeted myofascial tissue, which provokes cellular activation and pain modulation and repair. Of course, there is the input of either radial pressure wave treatment or focused therapy, shock wave therapy, of course. We have actually looked into the literature, and there is absolutely no consensus regarding the usage of shock wave therapy regarding neck pain. That's why we have examined several publications. These are the most interesting ones, and we have seen that even radio shock wave therapy is better regarding some aspects, including pain and regarding the standard care, of course. We have seen comparisons in the literature regarding as well low-level laser therapy, to which shockwave therapy demonstrated better changes in pain tolerance compared after a few weeks. And not only that, shockwave therapy does ameliorate the characteristics of the deep facial tissue regarding elastography. And also, there is expanding indications regarding cervical spondylosis, in which shockwave therapy does promote reduction of pain, improvement of range of motion, and SF36 of everyday activity gains. But this is the landscape. We have several propositions of protocols. And as it is not standardized, we have filed a prosperous protocol so as to make a systematic review with meta-analysis to show which would be the best protocol for our patients with neck pain. Of course, we have sorted out 4,272 initial records, and we have narrowed down to 60, which all of us have read those papers, and we have had to exclude some of those. Unfortunately, this is not ready for this presentation, so you may look forward for the publication in 1 or 2 months' time. So we have some comprehensive endpoints: subjective pain, functionality, objective biomechanics, mental health, quality of life, and safety profile. And we are confident that the adjunct therapy and the modality matching and objective tracking will be further down the line favorable to shockwave therapy. From fragmented trials, we actually don't want a clinical consensus. We want a systematic review with meta-analysis, and that's why it's our initiative from the Brazilian Shockwave Therapy Society to go ahead and promote this kind of study. I told you, Doctor, it would be swift, and as well, I would like to invite each and every one of you to our 25th annual Congress that will be held in São Paulo, 24 to 26 September next. Thank you very much.
Thanks, Dr. Truel. Some question? Have you some question about? Okay, thank you. Many compliments, and now I would like to invite Claudio Simplicio. He speaks shockwave therapy and low back pain, please. Dr. Simplicio, we are able.
Perfetto. Pendrive. Pode, perfeito. Vou botar o pendrive.
Some minutes of relax for everybody after a very strong day full of interesting papers and presentation about this technique. I am an orthopedic surgeon, but for me it's a new field. The shockwave therapy, but it's very interesting, and I opened my mind. I will open my mind because Alfonso, it's a pleasure to be here from you. And I think that is very important for orthopedic, for one orthopedics or surgeons to improve knowledge about this kind of therapy, because in young patients, when Dr. Smerli show us in many cases, we think that the only strategy, the only strategy is a surgery, but the shockwave therapy called shockwave therapy open other way in treatment for this patient.
Ok. A presentazione vai essere in italiano, também tem a versione in inglese, ok? Bom, onda de dorto e lombalgia. Apresentação de exposição em inglês e italiano também, né? Shockwave, low back pain. A lombalgia é a primeira causa que desabilita em mundo e há pessoas em 80%, onde as pessoas numa faixa resista em 45 e 50 anos, uma prevalência. Tá? Representa um dano econômico, maciço e sanitário da produtividade. Anatomia patológica de dolor. Todo artículo tem uma evidência. Este tem uma evidência 5, uma revisão onde apresenta o processo degenerativo de disco, um processo degenerativo da síndrome de faceta, de fáscia torácica e atrofia de músculo multifídio. Essas lesões têm uma frequência muito grande de dolores na coluna lombar. Quando pensa em tecnologia de onda duro, radial e focal. Onda radial tem esse artigo de evidência 1, esse artigo com evidência 1, onde onda radial, tratamento de trigger point e musculares. Quando pensar em onda focal, convergente profunda, principalmente em disco, intervertebral, faceta e artículo profundo, principalmente em onda focal. Quando pensamos em sinergia híbrida, pensamos principalmente em disfunção miofacial, que tem um melhor resultado quando associado radial com focal. Este é um outro artigo que tem uma evidência 1 de uma meta-análise, um artigo importante de meta-análise com evidência 1, onde mostra o tratamento convencional, exercício terapêutico e onda de dor, onde faz uma redução de média de dolores em 3 meses, vendo que terapia, onda de dor, muito maior em relação a pontos, em relação a exercício e tratamento convencional, uma diminuição maior de dor. Cirurgias e tratamento convencional em lombar. O que temos? Parâmetro, resultado. Também é equivalente. Mas quando pensa em complicações, em fusões, pensa em 20 vezes maior em relação ao tratamento conservador. Intervenção. necessidade de reintervenção em pensar em função lombar é muito maior em conexão conservadora. Então, também uma evidência de meta-análise número 1 de evidência. Quando pensamos ação anti-inflamatória, que seria exercício como terapia biológica, seria onda de dor juntamente com exercício. Também tem uma ação muito mecânica e diminuição de toxina pró-inflamatória e aumenta o fator regenerativo. Então, é uma sinergia de onda de choque muito importante, principalmente em exercício de estabilização de cor. Em relação à probabilidade de sucesso clínico, também uma evidência 1. Tá? Superioridade de onda de dor. Paciente é tratado onde tem uma probabilidade de 3,84 de melhora em sucesso em tratamento convencional. Tem uma resposta melhor. Também é um trabalho de evidência 1. Quando pensamos em intervalo em fase aguda e crônica, pensar em onda de dor não mostra superioridade quando faz em paciente um comparativo com grupo placebo. Então, na fase aguda, não. Pensando em dor crônica, 3 meses, mais eficiente. Também é evidência 1B. Esse artigo, importante. Lembrando que a indicação clínica focalizada é um caso persistente e resistente. Então, na fase aguda, não para a onda de dor. Em relação à síndrome miofascial, trigger pointers. Temos mais frequente em quadrado lombar, temos em glúteo médio, piriforme e eretor de coluna. Estes são 4 músculos envolvidos. Onda focal como GPS do diagnóstico. Este é um outro artigo que tem evidência 2, que uso de onda focal, barra energia, pequena energia, permite que localize o ponto trigger point profundo, glúteo médio, quadrado lombar, que a palpação não consegue reacionar. Então, o mapa de dolor com GPS diagnóstico é o reconhecimento quando a onda e a patologia onde o paciente reconhece sua dolor habitual, que é outro artigo com evidência 2. E fibrose epidural e o falecimento cirúrgico. Ação antifibrótica. Também, onda dura, formação de tecido cicatricial excessivo, uma redução de TGF beta 1. Tá? Tratamento seguro para tratamento paciente operatório, apresenta dores persistentes. Também é um artigo de evidência que é visto em relação à fibrose epidural. E síndrome facetária profunda, alta energia também com aparato focal, alta energia, de 0,25 a 0,35 milijoule, guiada por ecografia, redução de 70% de dolor. Superior à infiltração convencional e melhora de flexibilidade. É outra evidência 1A. Infiltração. A massa perdida da massa muscular e infiltração adiposa e paravertebral são corretas em dolor neuropática e escapa estabilização. A onda Douro estimula a regeneração muscular e prepara e melhora a função. Também evidência 6 nesse artigo. Esse artigo de evidência 1 é saúde mental e dolor crônica, redução da depressão. Paciente com depressão, uso de onda de choque reduz a dor física, ganho significativo de depressão. Um ciclo de dolor inativo e estressante, redução da dolor e também de física, mantém a onda de choque com efeito de cascata para sua mental. Paciente, principalmente com depressão. Parâmetros de prática quinta, também uma evidência 1+, nesse artigo, onde usam energia radial de 1,5 a 3 bar, focal de 5 a 25, em relação à frequência de 8 a 12, a 4 a 8, impulsos de 2.000 a 3.000, e focal de 1.000 a 2.000, sessões de 1 a 2, e focar uma sessão. Isso é um artigo de evidência 1+, também, de 2026, onde apresenta esse parâmetro de prática clínica. A biomecanomodulação. Onda focal, que é uma medicina regenerativa, representa a nova fronteira. Sempre falando de exossomas, que acelera a angiogênese e tecicular e reparação. Para a conclusão, a onda de pressão radial tem sessão de 3 a 6 sessões em intensidade de energia de 2 a 4 bar, frequência de 10 Hz, são modalidade de tratamento eficaz. A onda de pressão radial é defocal, eficaz, termina dolores, destabiliza, que essa aparece barra, e a dotofocal também demonstra superioridade em relação às infiltrações, eficácia, intensidade, dolores e sensibilidade da pressão de diopontes e miofacial. Onda dotofocal, um número de impulso entre 1.000 e 2.000 impulsos por aplicação. Já pensando em disfunção miofacial, onde duto de 1 a 3 sessões, uma energia de 5 a 30, uma frequência de 5. Graças pela atenção.
Thank you very much for your presentation. Some questions from colleagues? Please.
The subject of low back pain and neck pain is part of myofascial pain syndrome, and it's very interesting. I'm sorry I didn't understand anything. It was Italian, both speaking and both in the slides. It is disrespectful. And what I want to ask is, if you use focal shock waves, where do you aim them? 1,000, 1,500 shocks, where do you aim them? In the low back pain, in the lumbar spine. Please answer in English.
The microphone, please. Thank you.
Vou falar um pouquinho em português. Vou falar em português. É muito importante, quando vê um tratamento, intensidade e frequência. Intensidade e frequência. Os pontos miofaciais. Primeiramente, ponto miofacial. Encontrar através de a intensidade e frequência onde devemos modular para encontrar esses pontos miofaciais. O próprio aparelho hoje, ele te dá o diagnóstico em função da energia que você utiliza. Se você aumentar a intensidade, você consegue aprofundar a energia e achar o ponto miofascial que você não consegue na palpação. Esse é o primeiro tratamento. É fundamental a dessensibilização na primeira sessão de tratamento. A dessensibilização se faz com aumento da frequência e diminui a intensidade. Após conseguir a dessensibilização, você aumenta a intensidade e diminui a frequência. Segundo parâmetro, a ultrassonografia, que você utiliza para achar os pontos miofasciais, as lesões. Você pode guiar para chegar até a lesão. Esse seria o segundo parâmetro para você usar. A ultrassonografia é um parâmetro que ajuda que você encontre o ponto miofascial. Se você deseja saber se realmente no tratamento houve eficiência ou não, podemos utilizar o Doppler da ultrassonografia para saber se houve aumento da vascularização no tecido profundo. Isso teria a melhor resposta terapêutica. Quer falar, Daniel? Quer traduzir para ele?
Other questions? Okay.
Okay, please. Okay, thank you. Thanks so much. My compliments, because I have appreciated your presentation. And now, a preliminary experience with dental lesion, Professor Daniel Moya. Please.
Thank you very much. Do we have any dentists here in the audience? No. Okay. I guess that in the future we will have dentists, because we have learned that the shock waves have the potential to be a very good tool to help us to treat patients with dental problems. So the dentists usually are supposed to face different problems, like periodontitis. I will keep it simple, as Dr. Mafuli asked us today to do. So I will just give you some of the situations that dentists have to face, and then I will show you our small but interesting experience. As you see, periodontitis is a problem, especially the emergence of antibiotic tolerance and resistance because of the biofilms is a major cause of concern. There are several papers that have stressed the potential use of shock waves to treat this kind of pathology, because we know that shock waves has a bactericidal effect, so it's a good option. And to use it in combination with antibiotics, it makes it a very important option. We see that there are several papers stressing this good outcome, and another big problem is the osseointegration. The shock waves can be used to treat peri-implantitis, that is a process that is going against the osseointegration. We see that some authors many years ago, several years ago, have already suggested the use of shock waves for this kind of pathology. And with its anti-inflammatory effect, osteogenesis and antimicrobial advantages could be of use for peri-implantitis. Another problem is endodontics. And again, shock waves can have a role in the treatment of this pathology by increasing and improving the pulpal blood flow. Also, we have information related to orthodontics, but some authors have reported not good results. The point is that we still don't know which is the best dose to treat these patients, and while several authors like this group from Austria reported not good results, another authors, for instance, from Chile, have stressed their good results in experimental studies. Again, no result by the Austrian group, and they find that other authors have found that in rat models they have good results. This is a study in rabbits that found that shock waves could accelerate orthodontic tooth movement, so could be a good option. We also have results in bone healing and inducing the bone healing in fractures in the area of the dental pathology. So I think that we need to put a focus on these options and consider what is in the literature to work with these shock waves. There are even other options, other pathologies like treatment of temporomandibular joint disorders, sialolithiasis, and teeth desensitization. Well, I found a way to convince my dentist, that is a good friend, to work on a preliminary study, and this is our result. We have 16 patients, 9 women and 7 men, with different type of diagnosis that were treated. Of course, I was just the operator of the device, the one who was making the diagnosis, and the follow-up was the dentist. We use a single crystal piezoelectric shockwave device. We applied 2 sessions following the protocol that was designed by the Chilean group, and applying 4,000 pulses at a high level of energy, 0.5. I was one of the specimens, and I can tell you that it's not comfortable, but I really consider that if I was going to treat my patients in that way, I also should endurance that treatment. And it was possible. It is not heaven, but you can tolerate this. Our results were that 12 patients, that represent 75% of the cases, had favorable clinical and imaging changes after treatment. In 1 case, there was a partial response, and in 3 cases, there was no response. But this did not alter the treatment of the cases. The tolerance, as I said, was not perfect, but it took time to the people to get used to the session, and finally, in most of the patients, we could reach the level of energy we needed. We had 2 patients, as the one I'm showing to you, that was an orthopedic surgeon, by the way, that developed a transient skin rash after application. It was not me. Sorry. So, I don't know what happened, sorry. I go back to this slide, okay? So, our results coincides with what is already published, that it is considered that there are no risk. Of course, you must know where is the dental nerve and avoid the area of the dental nerve. Of course, my dentist, the doctor who was working with me, was of good help to find where the dental nerve was and avoid treating over the area of the dental nerve. Here you can see our first case. He was, as I told you, an orthopedic surgeon with a periodontal disease, a sequel of periodontal disease. You can see there is a disorganization and decreased density of the bone tissue. And 12 weeks later, you see that there are really clear differences, and there is bone remodeling and osteogenesis. Here,
the dentist was the reviewer of the result, and I just follow his points of view. But it is clear for us, most of the orthopedic surgeons here will realize that there is an increased presence of bone. Here we have another case, a 53-year-old lady with implant mobility and insufficient osseointegration of the implants. You can see the CT scan before and after shock waves, and there is an important phenomenon of osteogenesis. You will see it better in the next slide if we compare several details. You see there is a remodeling of the maxillary sinus floor with cortical formation. You will also see that is an increased palatal cortical thickness. Here you can see the presence of alveolar crest and a vestibular table thickening. So there are clear differences before and after. Here you have another case, a 41-year-old male with a peri-implantitis disease. After shock waves on the right side, you can see increased intrasinusal and peri-implant bone density and improvement in the peri-implant bone architecture around the healing cap. Here you can compare one side and the other side. Another case, this is a 40-year-old female with poor nutrition in areas to be grafted. On the left, the preoperative bone height in the floor of the maxillary sinus of 3 millimeters is insufficient to place a dental implant. A sinus lift approach was performed and an allograft was placed and treated with shock waves. After 4 months, we can see the gain of bone and the vascularization and organization of the graft area were improved. This initial study has allowed us to obtain positive responses without major complications. There are still several issues regarding extracorporeal shock wave therapy that have to be addressed, such as high versus low level of energy, number of sessions required for a therapeutic effect. It will be necessary in the future to carry out studies with a randomized control group to draw definitive conclusions and define whether the use of this method on a massive scale is justified. But we think that the characteristic of the shock waves and the biological response after shock waves is enough to justify studying this because what we have seen is very positive. Thank you very much.
Thank you. I am agree about your data. Very interesting. Yes, thank you. And some question about this presentation? Vidette about biofilm.
Let me say some words about this presentation. Thank you, Dr. Moya, for this presentation. It's very, very interesting because it's an uncommon, for me, I am orthopedic, uncommon use and common indication for this kind of treatment. And I hope that the pilot study will be followed by other study because I am aging, become aging, and probably I might necessity of this kind of treatment in the future, maybe.
Okay, so we have the conclusion, and now I would like to invite Osvaldo Valle, please. Beautiful. He speaks why extracorporeal shock wave therapy can fail to treat heel pain. Very interesting. Please.
Perfecto. Bien, soy el doctor Osvaldo Valle, soy cirujano ortopédico, traumatólogo, trabajo en la clínica de medicina deportiva más grande de Chile. A ver, ¿por qué pueden fallar las ondas de choque en el tratamiento de un dolor de talón? Primero, porque el diagnóstico es incorrecto. Segundo, porque hay una aplicación técnica inadecuada. Tercero, porque la patología es demasiado aguda. O porque no se consideraron condiciones biomecánicas de base para tratar ese dolor de talón. La terapia con ondas de choque, y aquí ya se ha dicho, en combinación con ejercicios excéntricos del tríceps sural, es la forma más efectiva de tratar esta condición en la actualidad. Onda de choque más ejercicio de elongación. Todos ya conocemos estos números en términos de que es una condición bastante prevalente y que genera una gran cantidad de consultas, sobre todo en población laboral activa. La terapia con ondas de choque es el tratamiento que puede ser más efectivo para el dolor de talón causado por la fascitis plantar. Llega a tasas de éxito del 88% en algunos trabajos. Sin embargo, a pesar de esta alta efectividad, hay un 10 a 20% de los dolores de talón que no responden a la terapia con ondas de choque. Y este grupo refractario habitualmente considera pacientes que están con un alto nivel de disfunción. El dolor de talón no siempre es causado por una fascitis plantar. Las otras causas más comunes pueden ser el síndrome del túnel del tarso, tanto proximal o distal, la atrofia del cojinete graso del talón, fracturas por estrés con edemas perilesionales masivos. El síndrome del túnel del tarso, alguna vez referido como disfunción de nervio tibial o neuralgia del nervio tibial posterior, es una neuropatía por atrapamiento que se origina por la compresión de estructuras en el túnel del tarso, particularmente el nervio tibial. Esta condición es análoga al síndrome del túnel del carpo en la muñeca, sin embargo es mucho menos frecuente. Habitualmente el paciente con un síndrome del túnel del tarso se queja de un dolor irradiado al arco o a la planta del pie, y el dolor también puede tener una distribución retrógrada hacia el gemelo, a la región gemelar. El dolor es agudo, con parestesias, y se agrava con la dorsiflexión-eversión del tobillo, porque obviamente el nervio tibial se elonga en esa posición. La clasificación anatómica del atrapamiento del nervio tibial, del síndrome del túnel del tarso, tiene dos variedades. El síndrome del túnel del tarso proximal, cuando el nervio tibial es atrapado en su paso a través del túnel del tarso, o el síndrome del túnel del tarso distal, cuando la compresión ocurre a la salida del túnel del tarso. El túnel del tarso, perdón. Aquí va, ¿cuál es el puntero? Pointer. ¿No hay puntero? Bien. Bueno, aquí podemos ver en la imagen de abajo que está el nervio tibial posterior, PTN, que se divide en dos ramas, una rama medial y una rama lateral. Tenemos el nervio tibial posterior, que da las ramas calcáneas, que son bastante variables en su distribución anatómica, y se divide en el nervio plantar medial, en el nervio plantar lateral y en el nervio calcáneo inferior o nervio de Baxter. Este es el retináculo flexor. Aquí es donde se produce el síndrome del túnel del tarso proximal. Acá, a la salida, es donde se produce el síndrome del túnel del tarso distal, en especial por compresión de esta ramita, que se llama nervio de Baxter. Estas son piezas de cadavéricas. Hice un trabajo de 35 disecciones de piezas cadavéricas para evaluar la anatomía del nervio tibial posterior. Y de acuerdo a la causa o etiología, pueden haber causas intrínsecas, extrínsecas o ser idiopáticos. En las causas intrínsecas, lo más común que uno se encuentra al operar son gangliones o quistes sinoviales y lipoma. Los tumores de origen neurológico son bastante menos infrecuentes, son más infrecuentes. Músculos accesorios también son comúnmente encontrados. Y el trabajo que hice, me encontré con un plexo venoso, que es este que se ve aquí, que se llama plexo venoso de las ortes, que es bastante infrecuente y sin embargo lo encontré en mi trabajo. Las causas extrínsecas, habitualmente, la más importante es el valgo severo del retropié. Y las causas idiopáticas dan cuenta de un 20 a 40% de los casos. Otra forma de clasificarlo considera el daño neurológico. Puede ser leve, sin deterioro sensitivo, moderado, donde ya hay un deterioro sensitivo, pero sin atrofia muscular, y severo, cuando hay atrofia muscular. En mi opinión, es el síndrome del túnel del tarso distal el que origina el mayor desafío en cuanto al diagnóstico diferencial con la fascitis plantar. El síndrome del túnel del tarso proximal tiene síntomas que son muy distintos. Es el síndrome del túnel del tarso distal el diagnóstico diferencial de la fascia plantar. Es ahí donde está el problema. Aquí lo tenemos esquemáticamente, como ya lo había mostrado. Este es el nervio de Baxter, que se llama nervio calcáneo inferior también, o nervio al abductor digiti minimi. Y es una causa que habitualmente no se diagnostica. Yo la cantidad de casos que veo de síndrome de Baxter son muchos, porque habitualmente no se piensa en eso, ¿ya? Y llega un paciente que ha pasado por 2, 3, 4, 5 traumatólogos sin que nadie detecte el problema. El atrapamiento del nervio plantar medial es bastante menos común, ¿ya? También puede ser una causa de dolor de talón, pero yo en mi vida he visto alrededor de unos 10, ¿ya? Y llevo casi 20 años como traumatólogo, 25 años como traumatólogo de pie. Y me ha tocado liberar unos 5 a 6, no más que eso, siendo sincero. Ahí está la primera rama del nervio plantar, del nervio de Baxter. Como ustedes ven, aquí está el nervio tibial posterior, se divide esta, que es la rama calcánea, nervio plantar medial, nervio plantar lateral, y esta ramita chica es el nervio de Baxter. Cuando uno opera, muchas veces, y me ha tocado, que es la vasa nervorum lo que me permite detectar ese nervio. Es pequeño, incluso trabajando con lupa, y en un par de oportunidades, si he de ser sincero, he liberado anatómicamente en el sitio en donde debería estar, sin ver el nervio, a ese nivel de pequeño. Este nervio provee la inervación al abductor digiti minimi y ocasionalmente al flexor digitorum brevis y a la mitad lateral del cuadrado plantar. Tiene inervación sensitiva también al periósteo del aspecto medial del calcáneo, al ligamento plantar largo y a los vasos sanguíneos adyacentes. Como ya les dije, la vasa nervorum me ha guiado muchas veces en disecciones de estos casos. Aquí tenemos un corte coronal, viendo los dos puntos donde se puede atrapar el nervio de Baxter. El cuadrado plantar que está ahí y el abductor alucis que está ahí. Cuando uno opera, habitualmente lo que encuentra es una fascia gruesa del cuadrado plantar, que es lo que verdaderamente está atrapando al nervio. Y a veces cuesta seccionarla, realmente, es difícil. Y este es el segundo punto, entre el flexor digitorum brevis y la tuberosidad posteromedial del calcáneo. Yo al esporón calcáneo no le entrego nunca un papel como origen del dolor, salvo en esta situación donde muchas veces hay que limar esta prominencia para generar la liberación. En la cirugía lo que yo hago es llegar acá, libero entre el cuadrado plantar y el abductor alucis, y de ahí me voy al flexor digitorum brevis, que lo diseco y raspo, secciono lo que es prominente a la palpación. Este es un corte transverso, ahí va el nervio de Baxter, ahí está la fascia plantar. Uno se puede percatar por qué se confunden los diagnósticos. La prevalencia exacta de dolor de talón secundario a causa neurológica en la población general no se conoce como dato. Sin embargo, entre un 15 a 20% de los dolores crónicos del talón en atletas están relacionados a compresión neural. Por lo tanto, en atletas hay que tener ojo con esto. De hecho, la compresión del nervio de Baxter es considerada la principal causa de dolor crónico de talón en este grupo de pacientes. Se puede sospechar clínicamente el atrapamiento del nervio de Baxter con una prueba clínica bastante simple. Aquí se le pidió a la paciente que abdujera, hiciera una abducción de los ortejos, y esto es lo normal, que el ortejo menor se separe. Aquí está funcionando bien el nervio plantar medial también, y acá no. El ortejo, el quinto ortejo, no se separa. Acá tiene una compresión del nervio de Baxter. El signo de Tinel puede estar, puede no estar, pero para mí este es el signo más útil que encuentro clínicamente. El electrodiagnóstico en casos del Baxter es frecuentemente negativo, sí, pero por una situación. Hay que hacer un estudio electrodiagnóstico muy detallado, en especial colocando agujas para medir en la electromiografía en el abductor alucis y en el abductor digitiquinti. Y eso habitualmente, ese test muscular no se hace. Y ahí viene el problema. Desde el punto de vista diagnóstico de imágenes, lo más importante para mí es la hipotrofia, atrofia, degeneración grasa del abductor digitiquinti, que en una imagen ponderada en T2 se ve blanco. Aquí hay un caso que tiene el doctor Kobayashi publicado, pero creo que es él el que puede explicar mejor, pero básicamente se refiere a que junto con la fascitis plantar puede coexistir sintomatología neurológica en relación a un atrapamiento del nervio tibial. Y por tanto hay que tratar y pensar en ambos diagnósticos. De hecho, tratando médicamente el dolor neurológico y tratando con ondas de presión radial en la fascitis plantar, consiguió un 90% de mejoría a los 3 meses de tratamiento. Sin embargo, creo que estos 3 meses son cortos para lo que uno ve como dolor de talón. Hay que dar más tiempo. Desde el punto de vista para crear controversia, yo cada vez estoy viendo que la hidrodisección, es decir, aplicar bajo ecografía lo que puede ser corticoides más anestesia, bajo control ecográfico, alrededor de una rama neural, es un tratamiento poco invasivo y altamente efectivo. Yo soy traumatólogo y he operado muchos síndromes del túnel del tarso, y hay retináculos flexores que son realmente una dureza, realmente duros, realmente gruesos. Entonces, yo cada vez voy hacia una cirugía, hacia una causa más de resolución del problema mecánico en este tipo de casos. Y para evitar la cirugía como tal, creo que la hidrodisección es una variante bien significativa acá. Ahora, esto es para aplicarlo desde el punto de vista neurológico en los síndromes del túnel del tarso leves y moderados. Aquellos que tienen deterioro motor, no, son quirúrgicos de entrada. Ahora, otra causa también como diagnóstico diferencial es el síndrome del paquete graso del talón, que en muchos estudios se considera como la segunda causa de dolor de talón, que no es fascitis plantar. Si bien en estos trabajos se presenta como la segunda causa, en mi experiencia personal yo he visto 5 atrofias del paquete graso del talón a lo largo de toda mi experiencia como traumatólogo. Los 5 han sido asociados a inyección de corticoides previa. Habitualmente se diagnostica por los siguientes parámetros: menos de 3 milímetros de espesor al ultrasonido. Lo que uno ve clínicamente es que la superficie del calcáneo se palpa absolutamente clara, no hay nada de grasa. Dolor en el centro o en el margen del calcáneo y empeoramiento del dolor cuando se camina descalzo. En un 9% de los pacientes del dolor de talón, la fasciopatía plantar y la atrofia del paquete graso pueden coexistir. La irritación de este paquete graso puede ser causada por trauma agudo o sobreuso crónico, habitualmente el correr o caminar sobre superficies duras. También se ve que esto puede estar asociado a la edad, a enfermedades reumatológicas, diabetes u obesidad. La degradación o reducción del paquete graso del talón puede ser también un efecto colateral de inyecciones de corticoides, y es esa causa la que yo he visto en forma más frecuente. Hay evidencia insuficiente en la literatura para definir un tratamiento óptimo de esta condición, definitivamente. Yo personalmente creo que no hay un tratamiento actual para ello. Se utilizan estas copas viscoelásticas, se infiltra plasma rico en plaquetas. En los pacientes que tuve yo de atrofia del paquete graso, inyecté plasma rico en plaquetas. Resultado, 0. No hubo ninguna respuesta. Y hay alguna evidencia débil, desde mi punto de vista, para el injerto de grasa autóloga, que habitualmente lo toman de la región abdominal. Pero los trabajos son de una calidad metodológica al menos discutible. Otras causas son las bursitis, que esas las conocemos todos, y el calcáneo es una localización rara, menos mal, para desarrollar tumores primarios de tipo benigno o maligno. Lo importante también es que un 15% de los casos de fascitis se asocian con enfermedad autoinmune sistémica. Espondiloartropatía también puede ser en artritis reumatoidea, y esta presentación es más común cuando el dolor es intenso, simultáneo y ocurre en pacientes más jóvenes de lo habitual. En mi experiencia, lo que he encontrado asociado es la espondiloartropatía a fascitis plantar, y han sido pacientes jóvenes y de presentación bilateral. Bueno, aquí están en términos de aplicación inadecuada los parámetros que ya hemos visto, pero que no creo que haya necesidad de repetirlos. Siempre se dice que la aplicación de las ondas de choque debería ser en el punto de mayor dolor de la fascia, hasta con la mayor densidad de energía que el paciente pueda tolerar. En mi experiencia, yo considero que los pedículos vasculares arteriales adyacentes al segmento injuriado de la fascia son puntos de referencia para la aplicación de ondas de choque. La fascia plantar recibe su mayor irrigación de la arteria tibial posterior a través de la arteria plantar lateral, que es la más importante. Aquí podemos ver, ahí está la arteria tibial posterior. Ramas pequeñas también vienen de la arteria dorsalis pedis, pero esas son bastante insignificantes en mi opinión. Cuando uno observa el punto de mayor dolor en la fascia plantar, aquí en la inserción de la fascia plantar, lo que encuentra en estudios angiográficos es que son vasos pequeños, de escaso diámetro, frágiles, de mala calidad vascular. Y ese es el punto de mayor dolor. Ese es el punto donde debería aplicarse, en teoría, la onda de choque. Pero yo me pregunto, ¿vamos a aplicar en un territorio arterial de baja calidad? Por mi cuenta, he comenzado a aplicar en los sitios donde el pedículo se origina. Esta es la arteria plantar lateral, que es la principal, y habitualmente yo he comenzado a aplicar en estas bifurcaciones las ondas de choque, de modo tal de generar angiogénesis a partir de pedículos de buena calidad vascular. Si volvemos atrás, uno puede ver también acá que tal vez no se aprecia tanto, pero la zona insercional tiene mala vascularización y mejora bastante hacia la zona preinsercional. Entonces, lo que yo hago es que de la región preinsercional de la fascia aplico ondas de choque, y también desde los pedículos donde se divide en arteria plantar lateral y medial. Y si bien no tengo tabulados datos, mi impresión es que me ha respondido mejor desde ese punto de vista. Creo que considerar los pedículos anatómicos arteriales es un precepto más racional en términos de aplicar las ondas de choque e no irse a la zona de mayor dolor, que me parece una explicación más bien folclórica. Todos sabemos que la anestesia local influencia negativamente la aplicación de ondas de choque. Se dio la discusión en el chat hace unos días atrás con respecto a esto. Yo creo que sinceramente el efecto, perdón, fue con los corticoides, el efecto de resistencia a la anestesia en los tejidos es importante. De hecho, la anestesia inhibe los nociceptores esenciales para la mecanotransducción. Hay una pérdida del feedback del operador, es decir, el operador, de acuerdo a la teoría del punto de mayor dolor, se vería limitado por esta situación, y también hay una suerte de impedanciometría alterada con la interferencia en parámetros de transmisión de energía por una condición física. La aplicación de corticoides más de 3 veces en un año también altera la respuesta a las ondas de choque, y si bien se dan algunas explicaciones de tipo impedanciometría o resistencia de tejido, yo creo nunca encontrar en la literatura el dato exacto con respecto a eso. Lo que sí he encontrado es que el efecto biológico del corticoide, en términos de inhibir neoangiogénesis, en términos de inhibir factores de crecimiento, es lo que explicaría esto. En términos generales, si uno examina los trabajos con aplicación de ondas de presión radial para fasciopatía plantar y aplicación de ondas de choque, tiene el parámetro que es más costo efectivo, obviamente, aplicar las ondas radiales. Pero a mí me va mejor con las ondas focales aplicadas en fascia plantar. Otra situación a no considerar es la falta de elongación del tríceps sural. Aquí todos conocemos, me equivoco siempre, el test de Silverskill, donde se genera una dorsiflexión del tobillo con la rodilla estirada. Como están tensos los gemelos, no se produce una dorsiflexión adecuada. Si uno dobla la rodilla y hace la misma prueba y logra una mejoría de esto, quiere decir que son los gemelos los que están produciendo el acortamiento. Sin embargo, no considerar la rigidez, la falta de elongación del tríceps sural en el tratamiento de una fascitis plantar o en el tratamiento de una fascitis plantar es una condición que puede llevar a malos resultados. Todos lo han dicho, la terapia de combinación mejor es ejercicio excéntrico más ondas de choque. El grosor de la fascia plantar es un predictor si la respuesta a ondas de choque va a ser positiva o no. Los estudios son todos mezclados. Mi experiencia personal, ¿cuál es? Que aquellas fascias cuyo grosor es mayor a 6 milímetros tienen una respuesta a tratamiento con ondas de choque peor. Pero intuyo que el parámetro mecánico más importante es la capacidad de elongación de la fascia plantar más que su grosor. Ahora, lo que tengo que hacer es pensar un modelo de cómo lograr eso. Eventualmente con la elastosonografía yo creo que sería una alternativa a investigar. Pero yo creo que es la incapacidad de elongación de la fascia plantar el predictor mecánico más importante. Muchos trabajos demuestran que la onda de choque aplicada en fasciopatía plantar crónica tiene mejor resultado que la onda de choque aplicada en la fasciopatía plantar aguda. Fasciopatía plantar aguda, menos de 3 meses de evolución. Crónica, más de 3 meses. ¿Hay algún rol de las ondas de choque en la fasciopatía plantar aguda por rotura? No hay nada en la literatura que sea fundado para esto. Yo he visto alrededor de unos 10 roturas de fascia plantar en mi experiencia como traumatólogo, agudas, todas en pacientes jóvenes, todas en eventos atléticos. Y como la literatura no es significativa al respecto, lo primero que hacía era infiltrar, aspirar un poco de hematoma, infiltrar un poco de plasma rico en plaquetas. En la clínica donde yo trabajo, tiene un laboratorio biológico grande, seguro, que me da seguridad en términos de la concentración de plaquetas encontradas. Y después aplicaba ondas de choque. Resultados buenos, se recuperaban. Y con quine desde la entrada, aunque les duela. Elongar a como dé lugar. Como conclusiones, un diagnóstico acucioso es esencial para alcanzar una buena evolución en el tratamiento de un dolor plantar con ondas de choque. El diagnóstico diferencial de patología neural es de particular importancia y errores en la aplicación de la técnica son bien identificables. Gracias.
Very good. Thanks. I would like to explain about this. I appreciate more the abductor digiti quinti. This is fundamental for heel pain. More people has plantar fasciitis and abductor digiti quinti, but this is biomechanical problem about the instability of translation of foot-ground reaction. Yes, okay. But in related to this, what do you think about to insert in this your plane of treatment? Very, 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 very good. I appreciate all. The normalization of foot-ground reaction with viscoelastic personalized initial, because heel cap is not very good to absorb vertical forces and shear forces, and the problem is the shear forces during the impact. So, and I ask.
Sí, la fuerza de cizallamiento se refiere usted. Es un componente mecánico, sí, en mi opinión, importante, sí, en la inserción, pero difícil de medir, difícil de establecer cómo lo hacemos clínicamente. ¿Ya?
Another question is about the treatment of nerve abductor digiti quintis, because you treat with anesthesia, no?
Sí.
Yes? Also me.
Sí.
Yes, also me, because this is the better.
Lo que yo hago habitualmente...
But not to use alcoholic or other.
A ver, manejo dos herramientas cuando hay un atrapamiento del nervio de Baxter, ¿ya? Cuando veo que hay un compromiso motor asociado a un gran edema en el abductor digiti quinti, envío a un ecografista intervencional para que haga una hidrodisección del nervio de Baxter, ¿ya? Cuando veo que los parámetros son más sencillos, hago yo una liberación percutánea en abanico de la inserción de la fase plantar y me resulta, ¿ya? Abarato costos, enviarlo a un ecografista. De hecho, siempre me he preguntado por qué no hago el procedimiento yo, porque vale como 10 veces lo que yo hago con una desinserción de la fase plantar. Pero bueno, legalmente está así. Son ecografistas intervencionales los que hacen el procedimiento de hidrodisección.
But when do you have the myofascial pain of adductor hallucis related with compression of nerve abductor digiti quinti? You make a stretch, mechanical stretch, or operative stretch of myofascial abductor?
Operative. Creo bueno, operativo.
Okay, thank you.
Soy traumatólogo.
I understand very well. So, another question?
Neuritis de Morton es muy parecida a todo lo que nos has explicado.
A ver, en mi opinión, el neuroma de Morton da una metatarsalgia que es evidente, clara, no da una talalgia, no da un dolor de talón, ¿ya? Y la prueba más sensible desde el punto de vista clínico es hacer una palpación directa entre las cabezas de los metatarsianos del tercer espacio, o si no, comprimir medial y lateralmente el antepié. Esas dos pruebas generan dolor en primer lugar y muchas veces, no siempre, una sensación de resalte evidente para el paciente, ¿ya? Y en el fondo, lo que hay que tener claro también con el neuroma de Morton es que obedece a un cuadro mecánico de sobrecarga del pie. Por lo tanto, hay que evaluar también esas condiciones físicas de sobrecarga para manejarlo con plantilla, o eventualmente en un neuroma que es refractario a tratamiento conservador, comenzar a evaluar algunas osteotomías de metatarsiano que mejoren la condición de carga del antepié.
I'm sorry.
Yo en mi vida solo he visto 2 neuromas reales. Todo son neuritis, engrosamientos. Esto hay que matizarlo, ¿no?
Es importante definir que el neuroma no es un tumor en sí, es un pseudotumor, y que en la base es una fibrosis que rodea una neuritis en realidad, ¿ya? Es eso. De hecho, actualmente, como la imagenología es más sensible, hay muchas resonancias nucleares magnéticas que se deben pedir de antepié, no del pie, tiene que pedirse del antepié para que tenga una buena visualización, asociada con medio de contraste permiten establecer que hay una neuritis nada más, que el nervio sufre un pequeño ensanchamiento y nada más, y eso es la causa.
I suggest to use the intralaser for the neuritis because he has, yes, yes.
Sí, pues.
No, laser, external laser, but also it is possible to make intralaser around the neuralgia.
Sí, pero puede ser un método bueno, analgésico, pero no olvidemos las condiciones mecánicas que llevaron a esa neuritis.
The instability, yes, the instability of the neural pulse.
De acuerdo.
Please, now, Dr. Kobayashi. Yes, please. Thank you.
Possiamo andare.
Buonasera a tutti, grazie Alfonso e l'invito. It's all my Italian, so it's Finnish. I don't try to speak as Italian. I have a huge challenge because I'm between you guys and the wine that I already seen there. So I have 11 speakers to debate with me. If you are here, please come. Naik, Raffaele, Vincenzo, Gabriele, Dario, Riccardo, Gianluca, Fedele, Emanuela, Gianluca, Falcone, Ana Maria, and Filippo. So I'm going to ask for all you guys because we are here in 11 persons, so we can try like this, okay? My name is Ricardo. I'm ex-orthopedics. Gracias por citarme en mi estudio allá. And now I'm pain specialist. And usually I like ice breaks, so as we are in home, I will talk about Marcos Aurelio. I like to study shockwave, was my PhD, and I like to study of Stoic philosophy. So let's make a survey. It's one correct answer. So who thinks that 6 is the right answer? And as fast you answer, as fast we're going to the line. 6. 9. The 9 was the correct answer because the 9 is the wife, and the wife always right. So here's my wife yesterday in Castel Gandolfo, and we were walking there, and she found this plate. She's rheumatologist, mother of 3 children, my wife, and for those who don't speak Italian, marriage is a relationship where one person is all right and the other one is the husband. So today I'm the husband. I will share my opinion. It's not the right opinion, and we'll share our experiences here. So let's go. It's a woman, 74 years old, as businesswoman. And for the past year, the pain in the solar foot to the right, worse than the left. After increase the amount of home office and moving for the farm. I'd like to ask you guys about the shoes. Which important the shoes for the pain in the foot?
For me, the first one, with the higher of the not the second, not the third.
I think you can introduce your yeah.
I'm Dr. Piccini. I'm the chief of a military hospital orthopedic surgeon.
Please introduce.
I'm Gabriele Panegrossi. I am director of orthopedic unit in this hospital.
Okay.
Just behind of this wall.
So I don't have the clothes to be here with these guys, but we will try. So she changed his foot because usually in business do like this, and now in Brazil we call it Havaianas. It's very common, the pain in the foot. Right? So I don't know here, but in Brazil we use a modified scale of pain. It's called Neymar Jr. scale. So in the rest it's 3, and the worst pain is 8 when they go the first. And these have some royalty. It's my royalty. I developed with ChatGPT, so I have to share with ChatGPT. And the worsening factors was the first step of the day, and when it sits a long time and go up, in the night it's worst. So this is the personal background. I think you can comment if you think that something of that is important for the evolution. Usually when you have breast cancer, it's a contraindication of shock wave when you do in the same spot, but after treatment, maybe you can do it. But you think statins or depression, it's worse results when you treat a patient with a historic of depression?
For the statins, it depends. A lot of patients have a problem, muscular problem, but other no pain.
Okay.
It depends.
So here the radiation and chemotherapy, you must be aware. So sleep quality, she has a restorative sleep. We have some studies of sleep and pain. When you are used to get surgeries, the sleep is important for the result of the patient, if it sleep well or not. No?
No.
Okay. This is a 70 years follow-up, an RA study. And usually the developing of pain, worsening of pain, and it's the best time of treat the sleep problems in the beginning. You have some protocols in total knee arthroplasty where you do a sleep fluxogram to get better sleep before the arthroplasty to get a better result. In shoulder, we have some studies like that. In foot, we don't have some studies about pain and sleep. But like we are all doctors here, this is a JAMA study that said that physician sleep is important either. And now we have evidence that sleep impactor in medical error. Here the trainee and attendee. So I look at you, all you are sleeping. The first class in the morning tomorrow is mine. So be coming in the wine, so to perform better tomorrow. And the biorhythm is like 2 or 3 weeks. We have a lot of gut of brain axis studies. In pain, we have some studies that the gut can impact in neuroplasticity that Nicola Mafuli said before. Physical examination, all normal. Besides the sensitivity, we have thermal hypoesthesia and hypogesia in the left foot and DN4 positive. Usually when you have some neuropathic pain patients, the evaluation is worst in your practice, usually, when you have neuropathic pain.
It depends on which is the pathology cause the pain.
Then, okay.
Yeah.
So we have some studies that show the DN4 positive, you can do like 7 questions and 3 of physical exam, that you can have neuropathic pain independent of the lesion. So here Osvaldo cite my studies. I have 2 studies that published in Danielle paper, but they have this British Journal of Pain that show us that mid-Achilles tendinopathy, Achilles tendinopathy, and plantar fasciitis, 25% have neuropathic pain without a nerve lesion because we have sensitive central sensitization and peripheral sensitization as either. So it's important to have the diagnosis of neuropathic pain. In shoulders, like 18%, in knees, like 20%. So we have X-ray bilateral with calcaneus pars and MRI with plantar fasciopathy. So we have the exams that say you have plantar fasciopathy, and all the day they said about the imaging exams and pain. We have this correlation. how important is the exams for you guys to start treatment? In heel pain, you think that it's important to have MRI or X-ray, or we can treat with the physical exams and the clinic of the patient?
For me, it's important, but important first of all the clinic. First of all, because when we see X-ray with spurs, I touch and then feel pain, I leave there, no treatment. The point is to see. I think that you visit and you can agree with me that you look both right and left, and you see that sometimes the pain is no, there is the spurs, and the other one, the big one, they have no pain.
Yes.
So it's important the clinic. Then the X-ray is important to the treatment.
But it's very important the differential diagnosis between spurs, between fasciitis, plantar fasciitis, or bone marrow edema of the bone. And then if I'm not sure that the pain is only for the spurs, I suggest to do MRI to exclude, to avoid other diagnosis.
Yeah, I think it's like that. We need the exams to exclude other pathologies, and we have some studies in shock waves in the knee. When you have this bone and edema, the results of shock wave is better. We don't have many studies in the pain with the foot, but I think get better when you have a huge bone edema. So, what do we do in this case? Shoe adjustment, stretching, ice, regenerative medicine, intervention, surgery, shock wave. What do we think we should do here? It's open, and Daniel will help us in the shock wave part.
First of all, shoe adjustment, stretching, and ice. First of all. Then, if the pain still remain, physiotherapy, shock wave. And the third one, regenerative medicine with stem cell, cellular staminali.
Yeah, the same. It depends. If I'm sure about diagnosis, I can start all with shock wave treatment. If I'm sure with a bone edema or something like this, because it's very useful to do that. It depends on the diagnosis, which is the non-pharmacological conduct.
Yeah. This patient had the shoe adjustment, stretching, ice, and shock wave therapy. Not shock wave. She had radial pressure waves, 5 sessions, 6 weeks ago with 30% of improvement. That in pain, our studies, we said 20% is okay and 50% is a very good result. So, but we have some problems in the shock wave. How we do it, the number of sections, interval, frequency, intensity. So I will ask Daniel to help us. Here's some protocol.
Is supported by the American College of Foot and Ankle Surgeons, but they say that it is not necessary to even have X-rays to begin the treatment. I do not agree with them. I agree with you. I think at least to have an X-ray. I don't consider the spur important for making decisions. So it is just accidental to have or not a spur generally, except in the case that Osvaldo Valle mentioned. So if the case is acute, I prefer to go to rehab, and of course always to improve the mechanical features. If there is in the MRI edema, bone edema, I prefer focus waves. And if not, radial pressure waves could be a good option. I agree with the frequency, with the intensity, and with the number of sessions.
Yeah, I agree. If you do a shockwave or radial pressure, if you like that. But the problem, it's like Osvaldo said, the diagnostic differences, because this is a post cancer treatment with neuropathy in the foot. So you do the shockwave in the plantar fasciitis, but you have the neuropathic pain associated. So this is the only study that you do shock waves and myofascial pain together. I think we should do always. It's difficult to say always, but when I do shock waves, I always do the trigger points associated. So you have just a study. I think we should do like tennis elbow with the extensions for the shoulder and the supraspinatus, like Laura said. So the only study shows us that is better with the myofascial pain and tendinopathy. But the personal background, she tried pregabalin since 150 2 times a day. That is a good dose, but for 1 month. We need like 3 to 6 months. And get some side effects, because it's not, pregabalin you have to have a titulation more slowly, and here was very fast. And paracetamol, we have 70% better, and the importance is as how percentage of improvement, because in pain, 30% is good, 50% it's great. So the end point is not to get without pain. So we have a good result here and a bad result here. But if you go to the literature, we have just published in 2025. Daniel was in my PhD, now he's in Denmark. This group is called NeoPsych. It's a group of International Association of Studies of Pain, just study neuropathic pain. So this is the guideline. We have gabapentin, pregabalin, mirogabalin we don't have in Brazil, duloxetine, venlafaxine, amitriptyline or nortriptyline, and plaster of lidocaine. We don't have capsaicin in Brazil, and TMS and opioids. This is how we treat neuropathic pain in every place. So this is how I would treat in Brazil, because we have these options. So usually when I do this, I do like a pain specialist. I think Renato can help me. She has a bad result with pregabalin, and she get worse when suspend her antidepressant, was escitalopram. She don't want to see pregabalin again, and she has neuropathic pain in both feet.
I would like. In Brazil, we introduce always amitriptyline. It's a good option for the sleep also, and it's a myorelaxant, so we love it. And I would give a small dose. We have small doses. And for topical treatment also, it's a good choice. Perhaps it starts with a topical treatment, and then if it's not enough, we can go to amitriptyline associated.
Here, every option here is right, so you can do either way. So I start with duloxetine because it's the depressant dual. They have serotonin effect in depression, and she get worse when suspended escitalopram and gets better for the pain. We have New England evidence saying that duloxetine it works for the pain independent of the depression. And topical treatment, as Renato said, 5% plaster. It's not if you pain, you have to do like 1 month, 3 months to get desensibilization. And here for the analgesic options, she responds 70% with paracetamol. I don't think we need to change or add an opioid here. So 1 month later, remember, she had shockwave 6 weeks ago. Now we have like 10 weeks of shockwave. So we have the time of shockwave acting, and I'm using the first line medication for neuropathic pain. So we have 50% better, partial improvement in the first step, and significant improvement in the night. But she said it's not okay because she still have pain, but 50% is great. Danielle, you think we can try, she made radial pressure waves. 10 weeks, you think you can try focus shock wave or wait a little bit more?
I have learned, and it is already described, that we must wait. We don't not have the definitive result in a few weeks with radial pressure waves or even with focus shock waves. When I treat a patient with plantar fasciitis with even radial pressure waves or shock waves, I tell them that they will get the more balanced result around the 3rd or 4th month. So, and in some way, the history of this patient is coherent with that. At 6 weeks, she was 30% better. Now with 10 weeks, she's 50% better. And perhaps if you wait, she will get even better, and time will give her the good result. When I began with this 25 years ago, I was even more anxious than the patient, and I was applying shock waves. I was using just focus at that time at the 4 weeks or 5 weeks because nothing was going on the way I wanted, and sometimes I was worsening the patient. So I have learned to wait. If at 3 months there is not a good result, or of course, if it is worsening, I move to another option. But if I see that it's getting better, I prefer to wait.
We have a study of Wang that follow up 2 years of shockwave and better results with the conservative treatment. So, my conduct, start cycling because to go walking from the foot is not the best option. Keep for at least 6 months because duloxetine you have to at least 6 months for pain. For depression it's like 1 year. And lidocaine patch at least 3 months, and if need analgesics. 3 months later, 90% better. So my case here is to show you sometimes you don't need to do the shock wave. We are in the shock wave congress, and always the answer is shock wave. Sometimes you have to wait, understand the biological effect, and do a multimodal treatment. So here, no night pain, because neuropathic pain, usually the worst is the night pain. The first step is the plantar fasciitis. So we get improvement here first because the medicine, probably, and here because the shock wave. So we get a better result. And here is important when you do a antidepressant that acts either in depression. They have in psychiatry a Kupfer curve that said when you have remission of depression, you have to stay like 1 year before get out the antidepressant. So be careful when get out. Lidocaine patch after 3 months you need to discontinue it, and the analgesic if it's needed. So my ice break comes to a take-home message. Marcus Aurelius said that everything we heard is opinion, not a fact. Everything we see is a perspective, not a truth. So this is my perspective, like a pain specialist. I know we have a lot of opinions here. So let's be more like Marcus Aurelius and less like my wife that is waiting me. So I have to thank you all. Grazie mille, and I hope you have a good evening. Want to say something? So the president, you can say the wine is finito. So
Let's go to the dinner.
Dinner. A tomorrow.